Doctor, recording will automatically will happen and only the live will be starting now.
Hello.
It will be recorded, doctor.
We are live, we can start. Okay.
So I will start.
Yeah, we can now.
A very good morning, ladies and gentlemen. And on behalf of the organizing committee, I'm Dr. Sunil Narayan. I'm the organizing committee chairman, and I'm also the president of the Cochlear Implant Group of India and the president of the Global Cochlear Implant Access Network. Now, we welcome you, a very hearty welcome to this 18th National Conference of the Cochlear Implant Group of India, CIGICON 2021, and the 6th World Congress of Cochlear Implants in Emerging Nations under the aegis of the GCIN. We have 3 days of an extremely extravagant, I must say, scientific program we have put together over the last 2 years. And I think it's coming to fruition, albeit in a very virtual format. This is the first virtual conference that we have organized in this focused association. And hopefully with all your best wishes and blessings, we will do well in the next 3 days. We begin this session and we are now in the surgery hall. We have a parallel session going on in audiology and in rehabilitation as well. So we begin our program now with video sessions as unedited as possible to talk more about it and to introduce the moderator for the very first session. I would request our scientific committee chairman, Dr. Shankar Madikeri. Over to you, sir.
Can I sit there? Is it better?
Thank you, Sunil. So I'm Dr. Shankar Madikeri, chairman of the scientific committee of CIGICON 2021.
You don't need this, no?
6th World Congress of Cochlear Implantation in Emerging Nations. So just before introducing Dr. Milind Kirtane, I would like to say just a few words. So this concept of this unedited video sessions, I thought of because the same thing we had tried in our state conference in 2015, it really worked very well. And because of the COVID situation since last year, earlier, which was planned as a live surgery, so we thought of changing over to the unedited video session, still showed the important steps of each particular operation by an expert in that field, and also to be moderated by that session by another expert from the national faculty. So that was the idea. I hope this really going to work well. So we have eminent speakers and surgeons from around the globe, and same way the eminent speakers and faculty from India who are moderating these sessions. Now, can I have the Dr. Milind Kirtane's introduction slide, please? So Dr. Milind Kirtane is my teacher, mentor, and a great friend, and is my like elder brother. So Dr. Milind Vasant Kirtane is an Indian otorhinolaryngologist. He is reported to have performed the first cochlear implant surgery in Mumbai. The government of India has honored him in 2004 with the award of Padma Shri, the 4th highest civilian award for his contributions in the field of medicine. He is a consultant ENT surgeon in various hospitals, and he is performed over 2,300 cochlear implant surgeries. And Dr. Kirtane in 2005, the awarded with the BC Roy Award from the government of India. Dr. Kirtane was the first person from India to be elected to the Baroness Society, Sweden, and he also holds the membership in the Neuro-Otological and Equilibriometric Society of India. He is on the editorial board of Neuro-Otological and Equilibriometric Society International and International Tinnitus Journal and ISRN Otolaryngology, and even the archives for sensology and neurotology in science and practice. Dr. Kirtane is reported to be active in social activities and is credited with several articles, or 50 of them, and books on otology, neuro-otology, and endoscopic sinus surgery. Over to you, sir, to carry on the further proceedings of this session. Thank you.
Okay, Shankar, thank you very much for that introduction. A little error there. I was not the first one to do a cochlear implant surgery in Mumbai. That was Sandra Disa. That's a correction. Can I have the slide for Dr. Sanaroglu, please? Can you bring it on the screen? That's right. Dr. Levent Sanaroglu from Turkey is a very dear friend, very prominent in the field of cochlear implants, has done yeoman service to the specialty by his work on cochlear malformations. He did his medical training and otolaryngology became associate professor, and he was a research. Sorry, I think I got disconnected and got connected again. Recently performed a histopathological study on inner ear malformations and trying to explain the pathophysiology of developmental inner ear anomalies. They performed in his team, over 2,800 implants. They also started an auditory brainstem implantation in prelingually deaf children in 2006 and has performed over 135 ABI in children. He has 120 articles in English language in peer-reviewed journals. He was also the past president of otology and neuro-otology in Turkey. He was the chairman department of otolaryngology at the Stapey University between 2006 and 2011. During this 4-year term, audiology undergraduate program was set up in the university. Ladies and gentlemen, please be prepared for a fantastic presentation from Dr. Levent Sanaroglu. Levent, over to you.
Dr. Kirtane, thank you very much for the nice introduction. And is my voice clear? Voice okay? Okay. So I am really happy and honored to be part of this meeting. Right now, I am in Italy for another meeting, and it's 4:30 in the morning. So I hope I will be presenting my patient to you clearly. I wish you a successful meeting. So I want to share with you the operation of a very young patient who had I performed simultaneous footplate fistula and management, and also the cochlear implantation. So she was 2 years old female, referred to me last year in November. She had bilateral congenital profound deafness. She had 2 attacks of meningitis, and that was the problem that she had. And on the right side, she had cochlear hypoplasia type 2, and on the left side, IP1. I want to show you the images. So this is the hypoplastic cochlea on the right side. As you see, there is well aerated mastoid on this side. But when we look at the left side with IP1, we see that there is a soft tissue mass in the mastoid and the middle ear. So this continues in all sections. In this situation, we have to look at the MRI as well. And on MRI, we see that this fluid collection is similar in intensity in the cochlea and also the CSF. So we can think that the CSF is passing into the inner ear, the cochlea, and the vestibule, and through the footplate, it goes into the middle ear and mastoid. And the patient has a cochlear nerve on both sides, and this is the reason why she's having repeated attacks of meningitis. So the problem is to repair the Staples footplate fistula. But if we repair the Staples fistula only without doing cochlear implantation, there will be no future chance for implantation, because the soft tissue that we put into the vestibule and inner ear may cause fibrosis. So my aim now is to do simultaneous fistula repairment and cochlear implantation at the same time. So this is going to be what you're going to see for the next 30-40 minutes. So I will go now to the video clips, starting from the first video. Can you see the video now? Is the video running smoothly?
Yes, very, very clearly, very clear.
Okay, okay. So I don't have the part that I did this incision and so on and so forth, but I think here I'm doing the mastoidectomy, and this is the opening of the antrum. Can you see my mouse as well, pointing to the structures over there?
Yes, Levent, yes.
Okay, so here my interest was to see if there is a CSF leak or not. So let me see. This is the lateral semicircular canal, as we see here. So this is opening into the middle ear. We see incus somewhere here, but as we see, there is a fluid coming from the middle ear to the mastoid. And when we remove the fluid and we wait, we see that it comes once again. So my earlier experience tells me that it comes from the Staples footplate, but we have to make sure that this is the case. I know there has been patients like this reported from India, because I investigated the literature, and I have seen that there were cases reported from India, and I also remember to talk about this with Professor Kirtani. So this is a clear view into the middle ear. You see that there is a clear fluid coming in from the middle ear. Okay. So in this case, our job now is to perform a opening of the posterior tympanotomy, facial recess, and see what is there. So we make sure that the fluid is coming. So this is incus. You see, I also point the incus. So we have the landmarks, incus, lateral semicircular canal. We see the fluid, and now we are opening the facial recess. So to open the facial recess, first, it is very important to thin the ear canal. But at the beginning, I use a cutting burr. I always keep an eye on the incus, because the tip of the short process of the incus is very, very important landmark. So this is always in front of me, and I make the opening as close as possible, leaving a tiny bony breach between the facial recess and the incus. So this is what I'm doing now. In the past, I was I was opening the facial recess 25 years ago when I first started cochlear implantation, very small, but now it is my practice to open it as large as possible, to see as much as possible in the middle ear, because it gives you flexibility. So at first I use a cutting burr to do this, as we see here. Then 2 millimeter diamond burr. This patient has a well aerated facial recess. So as we see, it's aerated very well. Now we start to see the middle ear. When we go further deeper, it is better to change the burr to 1.5 millimeter diamond burr. We always work parallel to the facial nerve. It is important to study the tomography beforehand to see if there is any facial nerve abnormality. And if the recess is narrow, it is a very good practice to identify without exposing the facial nerve. So in this situation, we had a very good recess, which was not necessary to identify the facial nerve, but that is something we have to do in certain cases if we need to. So my aim is to expose as much as possible the Stapes foot plate and also the round window. So normally we don't have to look at the Stapes foot plate, but in this particular case, the situation is different. And you will see that the the Stapes was very much angulated. So now we see the Stapes here, but we have to see the Stapes foot plate. So we have to thin the buttress a little bit more. And here we see the tympanic course of the facial nerve. Yes. At the same time, we have to see the round window. So this is what I do to expose the round window as well. So as you see, we have a very good access through the facial recess in this particular patient. So we are now trying to see if there is the fluid is coming from the foot plate. So this is a very important part of the surgery where we see that the fluid is actually coming from the foot plate. You see, when we wait, the fluid is filling the middle ear, as we see. You see, and at this point, I do not do anything else through the facial recess. This is very important because simultaneous CI and fistula repairment first time I did this in 2013, and that was the first time I had a fistula and cochlear implantation surgery, and I didn't know actually what to do. And I tried to repair the fistula through the facial recess. And this I do not suggest you to do, because we do not have a direct view to the Staples footplate through the facial recess. And in that particular case, I tried to do it, repair it through the facial recess, but in the end, there was a fracture in the footplate, and I had to remove the staples during the surgery, which made the situation much more difficult. So in this particular patient, when I see the CSF leak, I did nothing through there, and I started to elevate the tympanomeatal flap and enter the middle ear through the ear canal. Why I do this? Because we have a direct view of the Staples footplate through this. So we have to be very gentle because we don't want to make a perforation in the tympanic membrane because this is a patient with implant, with leak, and we don't want to cause an additional pathology. So we have to be very careful during the elevation of the tympanomeatal flap and entry into the middle ear. You see, the situation in this particular patient, that is called a tympany, is very difficult because the stapes is very angulated towards the back of the patient. So what I do here, I have to make a very good opening, very good articotomy, much larger than usual patient to evaluate the footplate. Now we say we preserve the core tympany and enter the middle ear. So it is wise to use angulated dissectors when we elevate the tympanomeatal flap from the annulus. So I start to thin the ear canal so that it will provide me better access to the attic area. So while doing this thinning of the enlarging the ear canal, we should not damage the ear canal. This is very important. If there is a damage, it has to be repaired. So this is what I'm trying to do now. I'm trying to enlarge the ear canal so that I will perform the articotomy better in this situation. So first we start at the lateral part of the ear canal, and then with a larger burr, and then we go medial with a thinner burr towards the attic. This is what I'm doing now, and so as we see, we started to visualize the incus, but as you can imagine, we still have a long way to go because the angulation is not very favorable in this situation, and we have to tilt the patient backwards, hoping to see a bit more of the Staples footplate area, but we need to make a very, very large articotomy, which at the end requires a repair with a cartilage graft. So this continues like this. As we see, I have this section all the time with my hand protecting the tympanomeatal flap with irrigation and tiny burr, trying not to damage any of the additional structures. We should not rush at this time, because if we rush and damage the tympanic membrane, then we will have to make a graft there. Therefore, we need to be patient, careful, and at the same time trying to expose the necessary structures. So we have a little bit better view now, but still we don't see the round window, the oval window area. Similar view. So I decide to make a larger dichotomy because the view is not good. So I use a slightly larger burr. I remove the soft tissues here. So this is a 2-year female. And of course, the ear canal is very, very narrow, but these are the children who has the symptoms at this age. So we have to be ready to enlarge the ear canal. In the past, I was doing this via endoral incision because I didn't have the view to perform cochlear implantation at the same time. But now we repair the leak along with the cochlear implantation. That is the reason why I do this in combined approach, post-auricular and the transcanal combined approach. So we started to identify the footplate area a little bit better now, but we have made a very good amount of dichotomy. So we can see the facial canal tympanic segment as well, but we have to make sure that we have better view because, you know, the CSF leak changes the refraction of the area, and we can have difficulty in identifying the facial nerve. So we have to be very careful about this. So we are trying to obtain a very good view of the area. Okay, so now we have a slightly better view. We need to make zoom to see it in more detail, but you can see the facial canal now. But when we remove the fluid, we don't, the facial disappears. So this is very important because the clear fluid, CSF, can change the refraction of the area, and we can have difficulty in identifying the area. So now I have a smaller suction in my hand, and I remove the CSF all the time so that I will have a clear view of the facial nerve. So you see, this is the facial nerve, and there is a defect at the foot plate. And now it is important to evaluate the defect in the Staples footplate, and my aim is to enlarge this footplate defect with a tiny diamond burr, not any peak, with a tiny diamond burr, and place a fascia in a dumbbell fashion into this area. So this is what we need to do. So I have to make sure that the stapes is intact. We should not remove the stapes. If we remove the stapes is the most important structure keeping the fascia in place. So we should keep the stapes in place, and we should use a diamond burr to enlarge the defect. Until we have sufficient space to place the fascia between that. So this is the defect, but the defect is small we cannot see it very clearly. Definitely, we cannot insert the fascia through here. If we try to do that, we will break the foot plate. So this, I'm using a tiny burr, maybe 0.4 or 0.6. Now, I don't remember exactly in this particular patient what was the drill, but we have to use a very tiny burr, and we have to make sure that the burr does not damage the facial nerve. So the burr is between the crura and the facial nerve. So we should never do it through the facial recess because we don't have a view like this there. So this is what I do now. This is what I do now, and very careful. So the area is very tiny, as you see, and area is very tiny. And so I have this section, as you see, between the crura and the diamond burr, between the crura and the facial nerve in this tiny space. So if we remove the suction, it is very unreliable to use the burr because of the facial nerve. But now I think we are having sufficient opening in the Staples foot plate. I think this is one of the most important part of the surgery, to enlarge this opening until we can have a fascia passing through this area. So this is the next clip that I want to show. As we see, we have a very good amount of CSF leak. So this is a gusher. And I, in the meantime, I take a fascia at the start of the surgery, not now, at the start of the surgery. In this particular situation, I prefer to have a real fascia because the fascia is a very good structure. I wouldn't suggest to use muscle tissue, or definitely fat should not be used, but fascia is a strong material, and gently we need to insert this through the defect into the vestibule. This is not easy because we have to remove the fluid, and the suction should not remove the fascia. So I suggest we learn how to use the suction without closing the opening as well. And we should also not damage the facial nerve. This is one of the most difficult part of the surgery. And but you know, as otologic surgeons, we learn to be patient, and with patients, I think you notice that I found the opening, and the fascia is now running smoothly into the defect, into the vestibule. So at the end, what we have done is pushing the fascia into the vestibule through the crura, just like in a dumbbell fashion. And you see, the function of the staples is very important. It keeps the fascia in place. Unfortunately, there are examples in my experience that I was trying to place the fascia over the defect at the beginning, or sometimes, you know, when using when using the peaks, it fractures, and I had to take out the staples. That makes the situation much more difficult. But you know, if you make an opening and insert the fascia in a dumbbell fashion, we now have very good and sufficient control of the leak, and now we can wait a few more minutes to see if the leak is sufficiently controlled as well. But as you can see, there is no more leak in this area. Okay, there was a cloth that I wanted to remove at that place, but there is no more leak from there. And at this moment, I go back to the mastoidectomy and look through the facial recess and prepare for the cochleostomy. In this, normally what I do is I remove the round window niche and visualize the round window membrane and try to use a thin electrode through the membrane, but not all electrodes are suitable for this. And if there is gusher, I like to use the electrode with the stopper that we develop for these cases. And the stopper requires enlargement of the round window niche. So the round window is, so this is the area of the round window niche, and I will do an enlargement of the area and so, you know, the angle of this patient is not very favorable, but it is very important to thin the ear canal properly. And we are now trying to visualize the scatotympany. So this is the tendon, this is pyramidal eminence, and I have seen that if the leak continues, it creates a lot of fibrotic tissue around these areas, and sometimes this makes the identification of these structures slightly more difficult. So this is what I am doing now, trying to enter the scatotympany, which will reward me by another CSF leak. So this happened now. Of course, we block the CSF coming foot plate, but we still have CSF filling the cochlea. Therefore, when we make another opening at the round window area, definitely this is expected, and this needs to be repaired properly as well. So this is a slightly better view of the area. We see the promontory here, and we have a better view of the enlarged round window opening into the cochlea. So I prefer to have an enlarged opening because it gives me opportunity to insert the fascia into the cochleostomy around the electrode. If you make a small opening, it is very difficult to tack in the fascia around the electrode into the cochlea. So this is what I do now, trying to obtain a sufficient opening. And we have to prepare the electrode as well. I like to pass the electrode through a tiny fascia, as we see here, and to advance this fascia until the stopper. My nurse, who is with me for many years now. She knows how to prepare this fascia, and she passes a straight pick through a tiny millimetric fascia, and when it is dry, I can easily advance it until the stopper. So this ensures that we will have fascia all around the electrode. And in the meantime, I made a huge athecotomy, which needs to be repaired. I had a small tiny cartilage tailored for the defect, and we are ready for that as well. Now we have to make the insertion into the cochlea. So first I center my microscope in the cochleostomy with a large magnification. Then I zoom out and take the electrode with the fascia. Sometimes we may have to do it in a few attempts, but the electrode insertion should be, we need to aim the electrode towards the lateral wall, not towards the modalis, because if there is a gusher, there may be defective modalis, and the electrode may go into the IAC. And in these patients, we need to make the intraoperative X-ray at the end of the surgery to make sure that the electrode is not in the IAC. So if a revision is necessary, we have to know this in the surgery. So the electrode is inserted into the IP1 cochlea. Now we are sure that there is fascia all around the electrode, and we need to push the electrode gently into the opening so that it will create a very good closure of the area, because we don't want to deal with leak afterwards. In the meantime, I zoom out again and try to obtain a good position for the electrode lead, because if we do not support the lead properly, it may come out and create electrode may come out as well. So this is very important as well. And we now look at the area once again. There is still some leak coming from there. Okay. I plan to make to insert a tiny fascia as well. So we have a better facial layer now between the electrode and the stopper, between the electrode and the opening. We squeeze the electrode into the cochlea, and we look for any leak coming from here. So now we have we view both sides if there is any leak, we look at the Staples foot plate area once again to see if there is any leak from here. We gently remove the cloths with a tiny suction. And this is the round window area. We don't have a leak from there as well. We have a nice view of the stapes now, and to see if there is any leak. But I think, as you can see, there is no more leak in this patient with these methods. At the end, I like to use fibrin glue, but to tell you the truth, the most important thing is the first layer of defense that we placed properly the fascia into the defect and also fascia around the electrode. I think that is the most important part of the surgery. Of course, I use these glues, then a second layer of fascia around this area. But which one do you rely is the first layer of defense? This I have to make sure. Then I put some more glue to that area, and I place a gel foam to this area because we will place the cartilage graft, and I want that to be supported on the under surface. Therefore, I put some gel foams here, and this is the cartilage graft that I take in the meantime to repair the defect in the attic. Because as you see, we made a substantial defect to see the oval window, and the cartilage is placed now there. And we have the luxury of fibrin glue now. So I use some glue to repair, to glue the cartilage as well. And this is the area we don't have any leak. And I place some more fascia and some more glue here as well. But as I said, the first layer is, I think, the most important layer in this situation. And at the end, we need to see the through the ear canal as well, because we have to make sure that there is no defect there, no retraction or defect or perforation or anything. Using the CIGICON at the start of the surgery is very good, because if we have a defect, it is visualized in the mastoid, in the middle ear cavity. So in this particular patient, at the end of the surgery, we see clearly the tympanic membrane intact, and that's the end of the surgery. So I will show you some more slides and then finish my presentation. Can you see my slides now?
Not yet. Levent,
We're seeing you actually. We just see your picture.
Okay,
We're not seeing the slides.
Just one second. Just one second. Okay. Okay.
Yeah.
Okay. So, you know, during pandemic, I stayed 3 months at home, and we only go to hospital for emergency cases, but 3 months at home. And you know what I have done? I looked at all the images, about 950 cases with inner ear malformations when I was at home, and I reported their findings. And I also discovered that there is a pathognomonic sign of the Staples Fistula. So you can find more information in this paper. So we, when we have the Staples footplate fistula, there are 4 situations. We can have normal staples. We can have a defect at the Staples footplate. We can have a cyst originating at the footplate, and we can have a leaking. We can have a leak at the Staples footplate. And this is normal tomography. This is normal MRI. But if we have an opacity on tomography and a cyst at the footplate on MRI, this cyst on MRI is pathognomonic. So this is at the same intensity as the fluid in the cochlea and the CSF, and is pathognomonic for the Staples fistula. I operated 17 cases for this fistula, and 13 of these are IP1. We can even see this in common cavity cochlear aplasia as well, but we only operate IP1. This is a separate paper where we describe our surgical findings, but only IP1 come to us because they experience meningitis. The others do not. And in these particular patients, we have a defect here. After removal of the cyst, I like to enlarge this opening with a diamond burr and place a fascia into the opening, as I showed you. The simultaneous CI and fistula repair, I performed 6 cases so far, first time in 2013. But what I have learned is to keep the staples in place. This is the most important thing. Otherwise, the surgery is very complicated. And this is the end of my talk. Thank you very much for your patience. I hope it was very clear what I have done, and I am ready for any questions or comments that you may have.
Yeah, thank you very much, Levin. Fantastic demonstration. Unbelievable what you could do on the footplate. I mean, and also compliments to your anesthetist. You had a fantastic feel all throughout the surgery. We could see every step so clearly. Otherwise, you get bogged with, you know, blood coming in the way.
Yeah,
but
you're right.
Fantastic, and your movements were absolutely superb. So thank you very much for that. We should, in IP1 cases, look for the signs that you've told us. You know, we just see the IP1, we want to go ahead, but I think we should look at the footplate area in all these cases. If there are any questions, Sunil?
No, doctor, we have not received any questions.
Okay, thank you so much, Levin. Yeah, Sunil?
I just had a question. Levin, would you recommend that not just in IP1, but in every other cochlear malformation, we should look at the oval window every time? It would be...
You know, Sunil, the important thing is, at first I was thinking that this defect is caused by the CSF pressure, but it's not. Because I have seen patients, histopathologic slides that, you know, there is a very good barrier between the cochlea and the eyes, but they still have this. So I have patients with cochlear aplasia. So you see the cochlea is absent, but they have the vestibule, but the defect is there. So we see this in common cavity, IP1, cochlear hypoplasia, and cochlear aplasia, as long as they have a vestibule and endosteal developmental malformation, we can have this. But if we have, for example, aperture stenosis, or it is very difficult to expect this in that, but we have to look for these signs in all IP1s and hypoplasia cases.
So where the porous acousticus interns, if the cribriform plate is missing and you have a direct communication of the CSF with the inner ear.
That's right.
Right. Okay, Levin, thank you very much. Sunil, if there are no
Welcome.
questions, then we can go to the next and let Levin catch up on his sleep in Italy, okay?
Absolutely. So I just want to reinforce the fact that Levent has traveled from Turkey to Italy. He's in Naples. He didn't sleep all night. We had this discussion from his Istanbul airport last.
Yes.
Really appreciate
My
it.
friends, I wish you a successful meeting and hope to see you in person
Thank
once
you so
again.
much. And ladies and gentlemen, I also wish to let you know that Levent Sinaroglu will take over as president of the Global Cochlear Implant Access Network tomorrow in the inaugural ceremony, but I don't know if he'll make it for that. But I will hand it over to him, and he would organize the next conference in Istanbul, hopefully next year. If not, it will be the year after. Thank you very much, Levent. Really appreciate it.
Okay,
Take
bye-bye.
care. Please
Thank
take
you,
care.
sir, Dr.
Bye-bye.
Kirtane.
Bye-bye.
Thank you very much.
Bye-bye.
We'll move on now to the next, and this would be again another unedited videos session. As unedited as possible. The idea is to make it as live as possible with a live commentary. To help us with this, I have my dear friend, Dr. Sumit Mrug. May I have Sumit's introduction slide? Sumit's going to moderate this session, which is on management of the ossified cochlea. We'll try and have one or perhaps two case scenarios with Simon Lloyd, another dear friend from Manchester, UK. Talking about Sumit, he's an absolutely fabulous, resourceful member of the Executive Council of the Cochlear Implant Group of India. And I think that is how I would like to introduce him, apart from the fact that he's a very well accomplished cochlear implant surgeon, perhaps one of the youngest when he started. He's not so young right now. He's done more than 350 cochlear implants, both pediatric and adult. He has a big cohort of adult cochlear implants, several awards, Sushrita Award, Max CEOs Award, and various other special interests as well in ENT. Over to you, Sumit.
Thank you, Dr. Sunil. It's been a pleasure to be here, and it's been a great, fantastic session by Levent Sinaroglu to start the ball rolling. And I welcome Professor Simon Lloyd from UK. Greetings from India and greetings from Cochlear Implant Group of India and our conference. And to introduce Dr. Simon Lloyd, Professor Lloyd is a consultant neurologist with an interest in lateral skull-base disease and auditory implantation. He is also professor of otology at the University of Manchester. His clinical practice is based at the Manchester Royal Infirmary and at the Salford Royal Hospital, where he is a part of the UK's largest skull-base and auditory implantation services. His academic interests are focused on new innovations in auditory implantations, hearing rehabilitations in neurofibromatosis type 2 and vestibular schwannomas. He is the president-elect of the British Society of Otology and secretary to the British Skull-Base Society. He is also a trustee of the British Acoustic Neuroma Association and Skull-Base Foundation. Welcome, Professor Simon Lloyd. He is going to talk about cochlear implantation and ossification. It's a very difficult task, not only in terms of the timing of implantation, the selection of cases, but also facing intraoperative challenges and also the outcomes. Over to you, Professor Lloyd.
Thank you very much, Sumit. I hope you can hear me okay.
Yes, fantastic. I can hear you very well.
Fantastic. Technology is a wonderful thing, isn't it?
And thanks for joining. It's been very early in UK. It's about 4 a.m. and really appreciate you joining live with us.
No, it's a real pleasure. I'm very grateful to you and grateful to the organizing committee and particularly Sunil for the invitation to come and speak to you all. I very much hope that you enjoy the conference. So I'm going to share my screen. So just bear with me for a minute.
Yeah, sure. You can take questions at the end of the talk. So maybe you can just send it in the chat box.
Sure. Yeah, that's fine by me. Can you see that okay?
Yes, I can see your slide.
Okay, and that's okay?
Yeah, that's fine.
Fantastic, great. So yes, the title of my talk is Cochlear Implantation in the Obliterated Cochlea. This is probably the most challenging case or type of case that we see in our cochlear implant practice. And I hope that through this talk, I'll be able to demonstrate some of the techniques that we use here in Manchester and other surgeons around the world use to try and get around some of the difficulties that you face when you're dealing with these cases. I think before we start, there's a few things that I'd like to highlight that are common to all of the cases of cochlear obliteration that we operate on. I think the first thing is when you're faced with someone that's had meningitis, which is the most common reason why the cochlea is obliterated, you should expect there to be difficulties, even if the imaging suggests otherwise. And if there is any evidence of the obliteration of the cochlea on the imaging, then again, expect the case to be a challenge. The second point is that imaging is absolutely critical for these cases. We insist that every case has both a CT scan and an MRI scan. And that allows us to get a good idea of the bony anatomy and the soft tissue anatomy. The CT scan gives you very limited information about the ossification or obliteration of the cochlea. It has to be a fairly advanced case of obliteration for there to be significant obliteration on the CT scan. So the MRI really is the more important of the two. And it's very important to look not just at the cochlea, but also to look at the semicircular canals as well, because you often see early obliteration in the lateral semicircular canal in particular, and that can certainly give you an indication of whether you're going to have challenges when you're carrying out the surgery. When you're looking at the cochlea itself, it's very important to look at both the scala tympani and the scala vestibuli. It's often the scala tympani that is obliterated first in meningitis cases. So it's certainly worth considering if you can't get access into the scala tympani to look at the scala vestibuli, and you'll see an example of that in the cases that I'm going to present now. And then the third point is when you're faced with an obliteration case, it's important to firstly have a depth gauge available to you, because you want to be able to probe the cochlea and make sure that you know whether or not the cochlear duct is obliterated, and that can then guide you as to whether you have to take a different approach. And that means that you're not using the proper electrode in order to test to see whether or not the cochlea is obliterated. And also, we always try and have a split array available to us when we're undertaking these cases. And that's not quite so easy as it once was, because you have to order in advance the Medel split array that we like to use, and it takes a few weeks for it to come. So these cases are often time critical. With the meningitis, the obliteration can progress relatively rapidly, and sometimes we don't really want to wait that sort of length of time. So that's a fairly recent challenge that we've faced with these cases, as we used to be able to have split arrays on the shelf, but we're no longer able to do that. And then the other factors are access is critical. Often you have to access the second turn of the cochlea. You'll see in all of the cases that I'm going to talk about today that it's very important to get as good access as you possibly can. So almost always we have to remove the incus. We have to widen the posterior tympanotomy to make sure we've got an adequate view of the promontory and the area around the cochleariform process. You need to make sure that you can change the direction of your approach for the electrode, so that you can try and get around any of the obliterations that might be present. And then finally, always make sure that you have a depth gauge. And the final step, which again you'll see in all the cases that I've done here, is to remove the Stapey superstructure, leaving the Stapey's footplate in place, because again that gives you good access to the area where you would find the scala vestibuli, and it also gives you better access to the area where you'll find the second turn of the cochlea. So I'm going to present 3 cases. The first case is a case of, it's actually a local anesthetic case, and that will demonstrate a scala tympani insertion. The second case is a case of a splitter electrode, and the third case is a case where we inserted the electrode completely through a second turn cochleostomy. So just a brief history on the first case. The patient was a 70-year-old gentleman. He had COPD and atrial fibrillation and was on warfarin. He developed meningitis back in 2016. We operated on him fairly shortly after he'd recovered from that. And he actually made a very good recovery, other than the fact that he had audiovestibular problems following the infection. His vestibular testing showed that he had a significantly reduced V-hit in the lateral semicircular canal on both sides, and he had a bilateral profound sensory neural hearing loss, but he was getting some benefit from the hearing aid on the left side. His threshold average on the left was 65 dB, but his BKB scores in quiet were significantly worse than one would expect for thresholds like that, and he only scored 20% on his sentence testing. On the right side with his hearing aid, he had no measurable hearing. This is just an example of his imaging. The changes were fairly subtle in his case. You can see on the left-hand side that the signal characteristics in the cochlea were slightly less than on the right-hand side. And there was also quite a lot of obliteration of the lateral semicircular canal and the posterior semicircular canal. So again, indicative that we were likely to face some degree of ossification or obliteration, but we didn't really know how severe it would be because the anatomy of the cochlea was relatively well preserved. So we went in prepared for all eventualities in this case. So we decided to proceed with a cochlear implant on the right side, even though that was the side that had slightly lower signal, because he was still getting benefit from the hearing aid on the left side. He wasn't fit for a general anesthetic, so we did this procedure under local anesthetic, and we did the surgery on the 13th of September in 2017. So I'm just going to show you the video now. I have actually edited these videos a bit. They're mainly about 10 minutes long, and there's 3 cases, so hopefully we'll be able to run to time. So just bear with me, see if I can get this working. So in this case, I've already carried out the cortical mastoidectomy, and I've removed the incus. I've also already tried a round window insertion with a depth gauge, and have been unsuccessful in passing the depth gauge in more than 7 electrodes. So I took the decision to try and access the cochlea via a scala vestibuli approach. And you can see here, I'm just putting some cotton wool with local anesthetic into the posterior tympanotomy just to anesthetize the middle ear space. The patient was fully injected with local anesthetic, obviously, beforehand, and actually the cortical mastoidectomy went smoothly without any problems, and he wasn't experiencing any pain until opening up the posterior tympanotomy. So I just added some local anesthetic in at that stage. And you can see here I'm getting wide access to the middle ear through extension of the epitympanotomy and a wide posterior tympanotomy. I'm just drilling here between the external auditory canal and the bone of the tegmen. And I'll just take out the local anesthetic pledget, and you can see some of the anatomy here. So you can see the lateral semicircular canal here, just behind the shaft of the burr. You can see the facial nerve You're just starting to see the malleus head at this point. And that's important because one of the main landmarks in cases where the cochlea is obliterated is the cochleariform process and the tensor tympani. And you're just starting to get a good view of those structures now. So when the drill's not in the way, you can see the cochleariform process here and the tensor tympani tendon there. So I'm just going to put my laser on because it might be easier for you to see. So we've got a great view now of the head of the malleus. You've got a really good view into the middle ear space. We've got the tensor tympani and the cochleariform process here and the facial nerve here. You can see now, and you'll see better once the wash has got rid of all the blood clot, the head of the stapes here. There you go. Yeah, so you can see the head of the stapes here, the stapedius tendon, and the pyramid at this point. And I've drilled a little bit of the pyramid at this point just to improve the view superior to the round window. And I'm starting now to drill just above the round window membrane. And the scala vestibuli is situated superior to the scala tympani. So you start with your landmark of the round window membrane. You can drill away the overhang as you would do normally for a round window insertion. And you drill on a wide front, saucerizing the promontory above the round window. This is using a Medtronic Skeeter burr, although there are other companies that make these drills. And it's a 1 millimeter diamond burr that I'm using just at a slow speed, 5,000 revolutions a second. And you can see as I'm drilling that there's a lot of fibrosis within the scala tympani, which is the reason why we couldn't pass the depth gauge for the into the scala tympani. So again, just drilling away the bone, intermittently using irrigation just to wash away the bone dust, because this particular drill doesn't have irrigation attached to it. And now I'm getting to the point where I can't get a good view of where the scala vestibuli will be. So I need to remove the Stapey superstructure, and you'll see how I do that in a second. So just using a pair of micro scissors, cut the stapedius tendon. You can cut the crura of the stapes relatively easily with a pair of micro scissors. So this is just cutting the posterior crus of the stapes, and then getting access to the anterior crus is slightly awkward, which is one of the reasons why it's helpful to widen the posterior tympanotomy and do a small epitympanotomy. You can see there I've just changed my angle of approach to get to the anterior crus of the stapes. And I've divided the anterior crus of the stapes now, and that allows me to remove the Stapey superstructure. Okay. So suddenly you get a much better view of the subiculum as it comes across the middle ear between the oval window and the round window. Again, at this point, it was a little bit painful for the patient, so I've just put some more local anesthetic soaked cotton wool in there just to help anesthetize everything. And you can see the remnant of the anterior crus of the stapes there. And you've got a really lovely view of that bone just inferior to the stapes foot plate there. And you continue drilling above the round window, again with the slow turning micro burr. This is just improving the access, making the stapenotomy a little bit, the posterior tympanotomy a little bit wider as well. it's important in these cases to widen the area where you're going to do your scala vestibuli cochleostomy over a wide area, so you're saucerizing it, and you can then ensure that you come down onto it knowing exactly where the access point is going to be. So starting to get a better view now of the scala vestibuli. And this is a depth gauge, just checking whether or not the scala vestibuli is open. So again, very important to have these available for these cases so that you can test whether or not you're going to get your electrode in. And in this case, the electrode or the depth gauge went in relatively smoothly initially. And then as we got into the deeper insertion, the depth gauge didn't pass quite so easily. It was getting a little bit springy as we were pushing the depth gauge in. So it felt like there was going to be a little bit of distal obliteration. But one of the things to note is that the depth gauge that we tend to use is the 612 depth gauge, the Cochlear 612 depth gauge, which is the equivalent of the contour electrode, and that's a modiolar hugging electrode, but it has a platinum wire inside it just to keep it straight whilst you're inserting it, and that means that it's a little bit more rigid than the other depth gauges that are available. But the downside is that it's a little bit of a wider electrode than some of the electrodes that we currently use. So we know that we can get the actual electrode in if we can get the 612 depth gauge in, but sometimes the passage of the 612 electrode can make you think that it's a little bit more obliterated, and it will be more difficult than it actually is when it comes to putting in the proper electrode. Again, just applying some local anesthetic pledgets so that the final steps of the surgery are comfortable for the patient, and these pledgets were also stopping any bone dust going into the middle ear when the bed of the implant was being prepared. And you can see that I've already put in the ground electrode for the implant at this stage. So everything's prepared. Just removing all of the cotton wool that was there to stop the bone dust going into the middle ear space. Clean out all the blood from the middle ear and make sure that you've got a proper view of all the anatomy. And then the next step is to place the electrode itself. So in this case, it was a CI 522. That was the electrode that was available from Cochlear at the time. And you can see a slow insertion superior to where you would normally place the electrode into the scala vestibuli. And the passage of this electrode was very straightforward in this case. It's a narrower electrode than the 612 depth gauge, but you can again see that it was just a little springy as we got into the last part of the electrode insertion, but eventually with a little bit of manipulation we were able to achieve a full insertion. And then obviously with all cases of cochlear implantation, you need to position the electrode in a way that the electrode's not going to extrude at some point in the future. So I always try and apply a little bit of gentle inward pressure in the positioning of the electrode. It's particularly important in these cases if it's been quite a difficult insertion, because there is a tendency sometimes for the electrode to push itself out over time. So you can see here just manipulating the main electrode. There you go. So that's the electrode in place. And then, as Levent said, it's very important just to place some material around the entry into the cochlea. In these cases, you don't generally get a CSF gusher as you might do in a congenitally abnormal ear, but even so, just to stabilize the cochlea and avoid perilymph leakage in the long run, very important to block off the entry point around the cochlear electrode. So this is just some muscle that I've taken that I'll wrap around the electrode. Okay, so that's the end of the first case. And just to give you an idea of the sort of outcomes that you can get from these cases, you can see here the X-ray that shows the electrode turning nicely, as you might expect. And this patient achieved CUNY scores of 63% with the implant alone, and a BKB score in quiet of 34%. A bimodal BKB using his hearing aid in the other ear of 58%. So not a fantastic outcome, but these patients with meningitis often don't get the best outcomes, partly because of the difficulties in placing the electrode, but also some of these patients do have some central involvement with the auditory pathways, which can affect the outcome. So case 2 is a 65-year-old lady. She had polymyalgia rheumatica and had a progressive bilateral hearing loss over a period of 6 years or so. And the presumption was that she had developed an autoimmune hearing loss. By the time we saw her, she had no measurable hearing on her audiology. We didn't actually perform any speech testing because we didn't think we'd be able to get her to hear anything on that testing. She had quite poor balance and severe tinnitus. And these are her images. So you can see just some representative slices. You can just about make out the basal turn of the cochlea in this case, in both sides. Very difficult to see it. The second turn and the apical turns, though, you could see a little bit more clearly. And there was also some obliteration of the semicircular canals as well in this case. And then on the CT scan, we could actually see some abnormality within the cochlear duct. So there's a little bit of additional signal here along the basilar membrane, which we wouldn't normally expect to see. So indicative of a case that's probably going to be difficult. After discussion, we decided to proceed with implanting the right cochlear implant, and we did the surgery in 2014. So this is her video. If I can get it to run. Oh, why is it not running? Oh, there we go.
Yeah.
Okay. So again, I've already done the posterior tympanotomy, taken out the incus, opened up the epitympanum a little bit, and we've tried to place the electrode in the basal turn of the cochlea, but it wasn't possible to get more than 2 electrodes of the depth gauge in that we were using. And that's not surprising given the amount of obliteration that we saw on the scan. So our next step in these cases is to carry out a second turn cochleostomy. I'd left the depth gauge in place in this case to allow for the positioning of the first array of the first of the 2 arrays in the split array electrode. I left it in there just so that the soft tissue obliteration doesn't collapse down and make it difficult to get the actual electrode in the long run. And you can see here again that I've saucerized the area just inferior to the cochleariform process in this case. So a little bit more superior and a little bit more anterior than I was in the last case. Again, drilling over a wide area because the position of the opening of the second turn does vary a little bit in these cases. And you can see now that the second turn is open here. So when you're looking for that, you want to find the cochlear reform process and drill just inferior to the cochlear reform process. The facial nerve is a little way away, just superior here, so you're very unlikely to damage the cochlea, the facial nerve when you're carrying out this part of the procedure. And again, I'm using the slow turning micro burr with a 1 millimeter diamond attached to it. And you're already starting to see that the second turn looks much more open than the basal turn. So I'm making sure that that opening is easily wide enough to accommodate the depth gauge that I use, just to ensure that it's all patent. And if you can get the depth gauge in, then you can definitely get the main electrode in. So just zooming in a little bit, you can see very nicely now the round window that's open there, and you can see the second turn cochleostomy. This is the first of the 2 arrays in the split array electrode. So I'm just going to place the first array into the basal turn, and I was actually able to get the whole of the basal turn electrode in place. I think the nice thing about the split array electrode, this is the Medel device, is that it's quite short and stubby and relatively rigid. So it's quite good at getting past some of those softer obliteration tissues. So just using a pair of jeweler's forceps just to push that into the basal turn. And you can actually see the basilar membrane there in the second turn of the cochlea there. So this is scala tympani, scala vestibuli. I'm going to just place the second part of the array into the scala tympani of the second turn. Just fiddling about getting the orientation of the electrode correct so that we make sure the position is as good as it can possibly be. And again, you can see in this case that the second turn is nicely open. You can pass that electrode into the second turn very nicely. And then finally, as before, just wrapping some material around the electrodes as they go into the cochlea, just to stabilize them and prevent any longer term perilymph leak. Okay, so in terms of what we achieved with this, I have to say this was an unexpectedly good result for a split array electrode. Some of the other split arrays that we've inserted have not done quite as well as this lady. She achieved 97% with her CUNY sentences and 62% in quiet with her BKB and 28% in noise with her BKB, and she really loves her implant. And you can see here really nicely the 2 electrodes from the split array kind of mirroring each other, quite parallel to each other as you might expect within the cochlea. And this is her post-operative CT scan, which again shows that the electrodes are in a nice position within the basal turn and the second turn of the cochlea. So just moving on to case 3. This is a 54-year-old lady. She had an episode of left labyrinthitis 4 years ago with complete loss of hearing, and then unfortunately developed a rapidly progressive hearing loss in the other ear which started around 2 or 3 years ago. The right hearing loss had been treated previously with intratympanic steroids and oral steroids with unfortunately no benefit. And we saw her and assessed her and decided that she would be a candidate for a cochlear implant, and ideally wanted to implant her with a CI622. So this is her MRI scan. Again, quite a lot of abnormal signal within the cochlea. You can see the basal turn here, but very patchy, very low signal. There was a lot of change within the semicircular canals on both sides. In fact, on the left side, there was no cochlea visible at all. So the left ear, which is the one that had the labyrinthitis 4 years ago, was not really a candidate for implantation. So we were stuck having to consider implantation in this right, also fairly obliterated ear. We did the surgery on the 10th of February this year, actually, so not that long ago. And this is the video. See if we can get that working. There we go. So again, I've already done the posterior tympanotomy, removed the incus, opened up the epitympanotomy. In this case, I've removed the Stapey superstructure already. And you can see that I'm just starting to drill the second turn cochleostomy. I'd already tried with the depth gauge to pass the depth gauge into the basal turn, and only managed to get 2 electrodes in, so it was obvious that we weren't going to get a basal turn implantation. In this case, we actually didn't have a split array available to us because we were worried about obliteration, and we didn't have time to get one from Medel. So we proceeded on the grounds that we would be able to get a standard electrode in. And you can see here again, I'm just below the cochleariform process, and the tensor tympani. Facial nerve is here. The lateral semicircular canal is here, and I've widely saucerized the area just below the tensor tympani, just so that I can come down onto the endosteum of the second turn on a wide front. And you can just start to see now the shadow of the endosteum as I'm drilling around there. So you can see I've also left the depth gauge in this case. You can see later on when I manipulate the depth gauge, you can see that there's definitely some movement of the perilymph within the cochlea. And you can see here now the endosteum of the second turn. It's quite thickened, and just using a gently curved needle to perforate that and then open up the scala tympani, the scala tympani of the second turn. There you go. You can see when I move the electrode, you can see the movement in the endosteum there. So that's the scala open. And it's looking like that is fairly open. This is a depth gauge, just assessing whether or not I'm going to get the implant in place. This is actually a 622 depth gauge. It's not a 612 depth gauge, but in this case that went in really nicely. So I was pretty confident at that stage that I was going to get a good insertion. I didn't have the split array, and I didn't really know how much of the standard electrode I was going to get in. The depth gauge didn't quite go in There was about 4 or 5 electrodes that were out as I was just trying to insert it maximally. So I thought there might be some difficulty getting the actual electrode in, but in these cases you have to accept that there might be limitations as to what you can achieve. So this is just removing the 2 depth gauges. That's the second turn depth gauge being removed. And then just taking out the, or actually putting in the electrode before I take out the other depth gauge. So this is the actual electrode going in. It's a CI622 electrode. Again, just starting to get a little bit sticky as it gets further in, but with a little bit of gentle manipulation, I was able just to get it in that little bit further, and eventually got it in to the point where it was about halfway through the 2 markers that are present on the 622 electrode. So I was pretty happy with that. Again, just putting some fascia or periosteum around the electrode as it goes into the cochlea. So that's the end of that video, and this is the outcome we got from this patient. So the other thing to say with this case, because we didn't really know what kind of outcome to expect from a purely second turn implantation, I actually left the depth gauge in the basal turn just in case we had to come back and do a split array electrode, and you can see that on the post-operative X-ray. So you can see a really nice curl as you normally do with the proper electrode, and then this is the depth gauge that's been left in position. But actually we got a pretty good result from this second turn insertion. So she achieved 87% on CUNY sentences and 50% on BKB sentences in quiet, and she was pretty happy with that, and we were delighted, really. And this is her post-operative CT scan, again showing the electrode within the second turn of the cochlea. And this is just a picture of the depth gauge that's kind of halfway into the basal turn of the cochlea. So that's the end of my cases. Thank you very much. If anybody's got any questions, I'm more than happy to answer them.
Thank you, Professor Lloyd. It was in fact lovely videos, and these are always difficult cases. One thing which I would like to just ask you, all the 3 patients you showed were postlingual adults, so of course they must be having good speech. How about having success with good outcomes in the pediatric? Do you do a lot of them even in ossifications?
We haven't got a lot of patients, but obviously we do see a trickle of patients with meningitis in the pediatric population. I mean, these children, they often come to us whilst they're in ITU, and we know that we will need to assess their hearing, and we can usually pick them up fairly early on. So in that situation, often the cochlea is still open, and the insertion is not too bad. But the ones that come to us some weeks or months down the line, it can be quite challenging. And we've had some situations where we haven't been able to open the round window and insert an electrode or even get a second turn implantation very effectively. And we have on occasion just drilled out the basal turn and placed the electrode into a groove that we've placed where the basal turn would be, and then just position the some soft tissue over the top just to fix it in place, so that we've got the electrode as close to the modiolus as we can possibly get it. And we just have to accept that the positioning is limited and the outcome is likely to be limited in those cases.
Right, right. Dr. Sunil, do you have any questions from
the platform? I think there are one or two.
Yeah.
Questions about how prepared are you for an ABI, Simon? For an ABI in the same patient in the same sitting. So let's say you put the depth gauge and you didn't get much of a joy with the lumen, and you couldn't really put a cochlear implant. You have not even opened the cochlear implant. Are you prepared for an ABI in the same sitting? And I know you're from one of the largest ABI centers in the UK and Europe. So how prepared are you for an ABI in this?
Well, we wouldn't go ahead and do an ABI first up. We would always try and insert a cochlear implant if we can. As I'm sure you'll be aware, the outcomes of ABI are pretty limited, even in the best cases. So if we can place a cochlear implant, we can normally get a result that's equal to, if not better than, what we would expect with an ABI. And the surgery for an ABI is a major undertaking. It's not something that we would go into without having an attempt at placing a cochlear implant. So we tend to do the cochlear implant first. If the outcome is very poor, then we have time to counsel the patient and the parents about what's involved with the ABI surgery and the potential outcomes, and what's involved with the rehabilitation as a second stage. But certainly an ABI is an option for those patients where we're not able to implant the cochlea.
Right.
He's a radiologist asking a question on retrograde implant, from the second turn. If the electrode goes retrograde, obviously you would have done a C-arm X-ray or a fluoroscopic control or whatever intraoperatively, an X-ray. Would it impact your audiological outcomes and then speech and language?
Yeah, I mean, the cases where we've tried retrograde insertion, we've always struggled because it's usually the basal turn where the obliteration is. So we almost always just go for a second and apical turn insertion if we can. But these cases, you have to go in with an open mind. You have to have a strategy to use whatever technique you can to get an electrode in. So you have to use every option in your armamentarium to optimize the outcome. So if a retrograde insertion is the one that gets you the best insertion, then that's absolutely fine. I think if you can get a decent insertion in any way, that's a bonus in these challenging cases.
Yeah.
I think that there is one question which I want to ask, that in the third case, you showed the depth gauge going from the round window and you could see while you were opening the endosteum with the Middleton cochleostomy. Would you prefer doing a drill out, or you would go for always a Middleton cochleostomy? Because I could see that depth gauge going through the round window.
Yeah, so we actually did an intraoperative mini MDT in that case because there were a few options. Obviously a drill out would have been an option. And if we can get past the basal turn obliteration, then clearly the second term was clear and we could have got an insertion kind of through the round window, probably more likely through a more anterior cochleostomy. But we decided that opening up the second term was a good thing to do early on, and we would see what kind of insertion we get with the depth gauge. And if we get a good insertion, we would go for a full insertion with the second turn, on the grounds that we were unlikely to get a really good positioning of the electrode within the basal turn because of all the obliteration. And it turned out, I think, to be the right thing. I don't think we would have got a better result than that had we drilled out the basal turn. It's quite difficult to get the electrode to sit in a good position that you think is going to get a good result when you're drilling out an obliterated basal turn. And keeping it in position is quite challenging as well. You have to put a lot of soft tissue around it. We often use Tisseal just to fix everything in place. But I'm always slightly uncomfortable that things are going to move afterwards if you've not got a nice cochlear duct to place the electrode in.
Thank you very much. I think we are done with the questions, and we are almost finishing our time.
So there's just a couple of questions, Sumit. I'm not going to take them on AB and CUNY sentences, details about that, and your post-meningitic protocol in a child with possible normal Vera and OAE in the beginning. How will you follow them up? I think we'll be here all day if we take those. Email them to you, Simon. And wonderful done. Thank you so much. Really appreciate this very early morning session with you. Thanks a ton.
Thank you, Simon.
Pleasure.
Have a good day. Bye-bye.
Very nice to see you.
Thanks,
Enjoy the
Sumit.
rest
Thank
of the
you very much.
conference.
Bye.
Bye-bye.
We now move on to the next session. The next video session is about subtotal petrosectomy with the blindside closure with the cochlear implantation. We have our colleagues again waking up very early in the morning from St. Petersburg in Russia, Vlad Kuzovkov and Andrei Lilenko. To introduce them, we have our moderator, Dr. Sumit Kumar Gaur, Dr. Sampath Chandraprasad, and to introduce Dr. Sampath, we'll have Sumit who will introduce Sampath, and then Sampath can take over and introduce the speakers. So over to you, Sumit.
Thank you very much, sir. Very good morning to all of you. It's my pleasant task today to introduce Dr. Sampath Chandraprasad. Dr. Sampath Chandraprasad is a consultant otolaryngology head and neck surgeon specialized in skull-based surgeries and hearing implantology. He did his master's at KMC Bangalore, bagging the best outgoing student in the process. He has over 100 peer-reviewed scientific publications, 15 chapters in various textbooks, and book on cochlear and other auditory implants. He's also the recipient of the Best Paper Award by the Pulitzer Society meeting in 2013, and was awarded with an honorary fellow of the American College of Surgeons in 2019. He's also a visiting professor to the Shanghai University, one of Asia's largest university, and has pioneered many new concepts in skull-based surgery in India. He's also the founder of World Skull-Based, an international organization and an NGO. Dr. Sampath sir, over to you.
Thank you, Sumit. It's such a pleasure being with all of you here today and being a part of this wonderful and prestigious gathering across the world. CIGICON is one of those events we look forward to every year, and it's we here at this platform moderating this rather interesting session, which is quite close to my heart because it's to do with hearing implantology alongside skull-based surgery, skull-based tumors. So it's my pleasure and privilege, and I thank organizers and my teachers, my professors, Dr. Sunil Dutt, Dr. Shankar Medikari, all of them who have guided me through my journey in implantology and skull-based surgery. Thank you so much for the opportunity, and it's my pleasure to hand over the floor to Dr. Vlad Kuzovkov and Dr. Andrei Lilenko, who are the speakers today, and they will be presenting their experience and their knowledge on cochlear implantation alongside subtotal petrosectomy, which effectively means that These implants are done for diseases, chronic otitis, or even deep-seated tumors in the temporal bone. So it's going to be a very interesting topic, and I'm sure we have some wonderful insights coming in from Dr. Vlad and Dr. Andrei. So Dr. Andrei Lilenko is from Russia. As Dr. Sunil was saying, it's quite early and cold, I guess, in Russia right now. I've been to Russia, a couple of cities, and I know it's pretty chilly down there at this point of time. So Dr. Andrei, thank you for coming down and joining us here today, despite the conditions. So Dr. Andrei Lilenko is MD, PhD, ENT surgeon and researcher at the Department of Diagnostic and Rehabilitation of Hearing Disorders at the Research Institute of Ear, Nose, and Throat Surgeries and Speech. So Dr. Andrei Lilenko would go first and present his presentation. I invite you to the meeting and request you to kindly proceed.
Good morning, everybody. Can you hear me?
Yes.
Thank you for invitation for such a profound congress. And good morning from, you were right, Samad, quite chilly St. Petersburg. It's now something like winter coming, and even snow is being covering the streets a little bit. Our today's talk will be about this subtotal petrosectomy and cochlear implantation. I will start our presentation, and Vlad Kuzovkov will try to join in maybe 10 or 15 minutes. So as we were asked, we prepared a live video, and let me share the screen. Wait a second, please. Can you see the video now?
Not quite yet.
Quite.
We see a taskbar, but not the video itself.
Okay, please wait a second.
Yes, we see a screen now.
And now?
And perfect. Please go.
Perfect. You can see the QuickTime player, yeah? I will.
Yes. Yes.
Yeah.
We have
now
it.
It's okay. Thank you. So we would like to present a case of reimplantation in 57-year-old lady. She underwent the primary cochlear implantation 11 years ago, and this is quite a fresh case as we recorded the video just 7 days prior to this conference. So the first cochlear implantation was underwent in 2010. It was the cochlear implantation being performed in the radical cavity already at that time, and now she was admitted to our hospital with cholesteatoma and electrode being reimplanted into the radical cavity by itself. During the last 10 years, she enjoyed quite nice hearing, but in 2 or 3 months ago, she understood that she is losing it, and on the automicroscopy before the surgery, we saw the radical cavity filled with cholesteatomic masses and electrode being halfly reimplanted by itself into the radical cavity. Now I think we will try to guide you through the steps of the surgery. The incision being made on the postoperative scar with reincision of the scar. It's very important to understand that we should form the flaps in precisely when performing the rear surgery in these cases, and we should try to do it to have a good closure of the postoperative wound. So the fat and the subcutaneous tissues are being incised, and the first aim is to find the processor of the cochlear implant. So moving forward a little bit to the external auditory canal, trying to palpate the postoperative cavity through the subcutaneous tissues. That was the case in which we decided to perform the subtotal petrosectomy and simultaneous cochlear reimplantation. For sure, we could not use the same implant, and that's why the previous implant will be reimplanted. So now the flap of the external posterior and inferior wall of the external auditory canal is being formed to make the Blindside closure. So you can see this, the tongue-like flap. If to compare this case with the subtotal petrosectomy in the, so to say, normal ear, not after the radical cavity surgery, we should mention that for sure the skin is much thinner, and it is a little bit more complicated to perform a classic Blindside with the posterior flap. So you can see here that the flap is posterior inferior. Now you can visualize the edge of the cavity, and it's been removed with the skin of the posterior, with the skin of the external auditory, posterior wall of the external auditory canal. The active electrode can be visualized. And we always performing rare surgeries, reimplantations. We try to preserve the electrode, and now we will try to free it. So the posterior wall of the radical cavity is being incised, and you can see through this incision the cholesteatomic masses hanging through the electrode array. These are they. They have been removed. Those that are visible now. That's the knit that was performed on the first surgery. So for us, the aim was for sure to give the hearing for the patient and to minimize the complications in the postoperative period, so that we can be sure that there will be no recurrence of cholesteatoma. Now the electrode is being put away from the cochlea, fully put away from the cochlea. And now we'll go on to form the blindside closure, and then to move on to performing the sanation of the radical cavity. So the tissues are being mobilized and prepared to being put into the external auditory canal. You can see here the processor of the cochlear implant. It's being freed. And now the anterior flap for the blindside closure is being prepared.
Dr. Lilenko, may I ask you a question at this point?
Yeah,
of time?
sure.
Thanks for the audience. So, so this was a cochlear implant in a chronic otitis case for which a radical cavity was done, but not a blindside closure. Did I get that right?
You mean the first surgery?
Yes, the first surgery.
Yeah, the first surgery was simultaneous radical cavity and cochlear implantation.
Okay.
So now it's the reimplantation, and it will be the blindside closure. Yeah.
Okay. Thank
for
you.
this case, yes. So the electrode is exposed, and the soft tissues are being prepared. Now, Dr. Vlad is writing to me that he wants to join. Can you give the word for him? Is it possible?
Of course.
Excuse me?
Of course. Yes, for sure. So is he going to go with you simultaneously, or is he going to go after you?
I think he will start with 10 minutes from the video. Okay.
Oh, okay, right. So we will introduce and invite him once your video is over.
Yeah, so I will shut the video down now, and he asks me to give him the opportunity to go on, okay?
Which means that he's going to continue with the same video, is it?
Yeah,
oh,
that's it.
Brilliant. Okay, right, fine, perfect. Sumit or the IT team, can I have the speaker's intro slide, please?
Yeah. Does he join? I can't see.
I think, Andre, you have to stop sharing screen so that we can share ours. Yeah.
So it's my pleasure to introduce Dr. Vlad Kuzovkov, who will be joining us from this point on, taking us through the video that's being presented. So Dr. Kuzovkov is Doctor of Medical Sciences, Associate Professor of the Department of Otolaryngology of Military Medical Academy, named after S.M. Kirov, expert of the International Association of Leading Medical Centers for Auditory Implantation. In June 2018, at the Congress in Antwerp, Dr. Kuzovkov was awarded the Buren-Helms Award for Outstanding Surgical Achievements in the field of auditory implantation for 10 years. He's carried out more than 5,800 cochlear implant surgeries. He's operated in 12 countries around the world, in Europe, East and Central Asia. So it's a pleasure and privilege to invite Dr. Vlad Kuzovkov to this August gathering, and it's my privilege to introduce him as well. So thank you for joining us, and Dr. Vlad, the floor is yours.
Andre, he's not separately joined us. Is he joining you in your room with your mic and connection? Not responding.
Dr. Andre, are you there? I guess he's going to log in separately, and that's what he's trying to.
Okay. While we wait, Sampath.
Yes.
He is joining. Sorry, he is joining. He is joining. Sorry. Wait a second, please.
Is he joining separately on his connect, right? Separate connection. Andre, is he going to be with you on this connection, or is he joining on a?
No, he is joining. He's joining by himself. He's in another country right now.
Okay, all right. Until he joins, Sampath, I want to pick your brains here.
Yes, sure.
With the number of skull-based surgeries, I've watched you, and the world has watched you do these surgeries. Tell us a little bit more about subtotal petrosectomy. What's your concept of that? Because that's for the younger audience here, the junior consultants and postgraduates that have joined here. Tell us about the indications for subtotal petrosectomy and actually the definition of subtotal petrosectomy.
Yes, thank you.
Go ahead.
As I was going through Andre's video, which was a fine video, I was thinking about what was done during the first surgery. So there was a cochlear implantation done possibly for a chronic otitis, but without a Blindside closure. So that for me was the error in that case, for which Dr. Andre was commencing upon a subtotal petrosectomy, which was the right thing to do to set right the mistake. So subtotal petrosectomy for me includes first drilling out the mastoid, canal wall down, and proceed. So when we have a canal wall down cavity, we are looking at clearing all the disease. And if there is a tumor, perhaps a tumor as well, let's say a tympanomastoid paraganglioma, some deep-seated tumors as well, can also be attempted to remove by what we call subtotal petrosectomy. Subtotal petrosectomy is the first step to more deeper surgeries in the temporal bone, which could include translab, not translab. Translab has the canal wall up, so I would keep translab out, but transaortic approaches, transcochlear approaches. So one of the primary components of subtotal petrosectomy is to do extensive mastoidectomy and to have the full liberty to remove the disease, first thing. Second thing, the second most important aspect of a subtotal petrosectomy is closure of the cavity from the external world, which means that we need to then close the eustachian tube and close the external ear canal. So the second most important step is Blindside closure. There are certain techniques which come with closing the external ear canal, and we will probably discuss this at the end of the video session. And the third important aspect is to close the eustachian tube, which means that the nasal cavity is now completely separated from the surgical site. The fourth step is to fill the cavity with fat, which is what most people do, but yes, you could leave the cavity without fat, but I wouldn't recommend that. But placing a certain amount of fat inside the cavity to fill the cavity are the four essential components of a subtotal petrosectomy. Now, coming to the indications of subtotal petrosectomy, we would do a subtotal petrosectomy for chronic otitis and for tumors in the temporal bone. I myself have done about 10 cochlear implants with diseases in the ear, including chronic otitis and tumors. And I prefer doing simultaneous ipsilateral cochlear implantations rather than stage them, provided I'm confident of total disease clearance. I would not do a simultaneous ipsilateral cochlear implantation, which means a CI at the same sitting, if I have any doubts as to with regards to the total clearance of the disease. But if I feel that the whole cavity is nice and clean, I would probably attempt a simultaneous ipsilateral cochlear implantation. I prefer doing simultaneous. Yes, I think Dr. Vlad has joined us as well. And if, yes, I can see Dr. Vlad. So we were just discussing steps, indications of cochlear implantation with subtotal petrosectomy. So I already introduced you, Professor Vlad, and it's an honor and pleasure for us to have you here. So you could go ahead and present your presentation while I will step back. Thank you.
Vlad, unmute yourself. Nice to have you here. Yes.
So I already introduced you, Professor Vlad, and it's an honor and pleasure for us to have you here. So you could go ahead and present your presentation while I will step back. Thank you.
Continue video.
I think you have to log out from the delegate link and then.
Vlad, unmute yourself. Nice to have you here. Yeah.
Please log out from the delegate link.
So you could present presentation while I will step back. Thank you.
Okay. Just video. I need to show.
I think you have to log out from the delegate link and then.
Vlad, unmute yourself.
Yes.
Nice to have you here. Yeah.
Can you hear
Please
me?
log out from the delegate link.
I can start video from
log out from the delegate link and then.
Vlad, unmute yourself.
Yes.
Nice to have you here. Yeah.
Can you hear
Please log out from the delegate link.
Okay. Our video that we should start from 10 minutes.
And we need to discuss indications for this subtotal petrosectomy and contraindication also, because we do it really, it's not a routine procedure, because sometimes we try to do something like tympanoplasty with Cochlear implantation, and sometimes we use calculators for reconstructions of cavities and cover also because medical cavities. Procedure, because sometimes we try to do something like tympanoplasty with Cochlear implantation, and sometimes we use calculators for reconstructions of cavities and cover also because sometimes we try to do Cochlear implantation, and sometimes we use calculators for reconstructions of cavities and cover also because
IT team, please note that we're not able to hear Vlad.
Yeah, so I have a feeling, Sampath, there's some connectivity issues, and he's checked from two links, both the Zoom and Get platform. So my request to Andre, if he's still there, is Andre, with permission from Vlad, if you can continue the discussion and complete it, we will save some time. It's a humble personal request. If Andre can just continue the video and show it to completion, we would appreciate that. Andre, if you do that.
Absolutely.
Andre is left the meeting.
Oh. There's a definite lag between what we do here and what's reaching.
Yes, there's a 20-second lag between the Zoom to the platform, so which is why the speakers would be in the Zoom link and the delegates are on the platform. So it's not good to be in both the links.
Correct.
Ask Vlad to unmute. He is muted still.
Yes.
We have sent a request of Andre doctor is back.
Andre is back?
Yeah, we are letting him in. 2 minutes.
Yeah, let him in. And let Andre continue and complete the video, Sampath.
Correct. Yes, absolutely agree.
We can involve Vlad perhaps for the Q&A.
Correct.
Vlad, are you in? Sorry, Andre, are you in?
Not yet. Not yet.
Yeah, he's in.
Yes.
So,
2 minutes.
Yeah, let him in. Yeah. Let Andre continue and complete the video.
Yes, sure. Andre, are you with us? Can you hear us? Please unmute yourself. Yes, okay, perfect. So Andre, can you hear us? Yes.
Yeah, I
you
can.
now.
Can you hear
Brilliant.
me?
So yes, we can hear you. Can you go ahead with the video, please? Because we are having problems with Vlad's connect. I think he's on the other platform, and we are all on the faculty platform. So can you go through
Share
your
the
video?
screen again and go on with the video. Yeah.
Yes, and Vlad can join us with the Q&A session.
Yeah. Sorry. Yes. Now, is it okay?
You can see a taskbar of yours, Dr. Andre.
Now the video.
No, doctor.
Not yet.
Not yet.
And now.
No. Stop share like you did earlier. Stop share and come back.
Now.
Yes, perfect, doctor. Yeah, good. Thank you.
So will Vlad continue commenting it? Yes. Can Vlad comment? Can you comment?
He can do so. Yeah.
Okay, so I start the video and he will comment. Is it right?
Dr. Vlad, can you unmute, please?
Yes. I can join you, and I will comment every step of our system.
Now.
Yes, perfect, doctor. Yeah, good. Thank you.
So will Vlad continue commenting it? Yes.
Yes, please.
Yeah.
Yes.
Yeah. Can Vlad comment? Can you comment? Okay, so now.
Andre, I think Vlad has a lag, so the event reaches him 20 seconds later. So it's better that you comment because the video is not going to be in sync with what he's going to comment.
Okay, so sorry for this occasion. So the previously formed flaps are now being put into the external auditory canal and being stitched to complete the Blindside closure of the external auditory canal. It's very important to keep in mind that the skin of the flaps should go outside, not coming inside to prevent the. Is it okay? Can you hear me? Because I have some problems with sound now. Is it okay?
I think you can mute everybody else other than the speaker himself. Yes, and yes, Vlad is muted now. I think you're good to go, Andre.
I can go on?
Yes, sure.
So yes, that's important to fix the flaps in such a manner that skin will be outside, not inside, for sure, to prevent the cholesteatoma recurrence in the postoperative period. Because we all know that it will be very hard to assess the episodes of recurrence of cholesteatoma when we perform the Blindside closure, especially if it's a simultaneous Blindside closure and cochlear implantation, because we are limited in terms of postoperative diagnostics. The CT scan will be not as much informative due to the fat that will be in the cavity, and we won't be able to have the good visualization in MRI in DWI regimen because there could be some artifacts. That's why it's a very, very important step to feel and to know that the skin will be outside. So now, as the closure of the external auditory canal is completed from the outside, the flaps are being fixed to the interior parts of the cavity. So you can see it right now. To form the right position of the external auditory canal. I will try to put the video a little bit faster because skipping some steps because we are for sure due to our problems out of time. Sorry. So now it's the cavity itself being worked on. The inner layer of the cavity is being senated. You can see it from the anterior angle. Now from the posterior part of the mastoid cavity. It's been removed. You can see now under the suction tube pure bone of the promontory. So the cavity is being widened because we need to be sure that all the pathologic process is being removed, and on the preoperative scan, this patient had a couple of defects, bony defects of the middle fossa bony plane dura. You will see them in a couple of seconds, I believe. So the cholestatomic masses in this particular case went into the synodural angle. So all the cells of this area need to be opened and exposed. So this that's the epidermis from the bony plate of the middle fossa dura. Classically, we need to open and excise the tip of the mastoid while performing the subtotal petrosectomy. But in this lady, in this patient, we can see that the mastoid tip is not interested in cholestatomic masses, so we decided not to cut it and preserve intact. It was exposed to the limits of the bone, of the healthy bone, and not being extracted. But in this lady, in this patient.
Go ahead. Andre. Yes.
Sorry, I have a, excuse me, because I have a something like double hearing now.
That's
What I'm saying, I hear in 10 seconds. I don't know why.
Vlad unmuted himself, so it's coming from Vlad. So you can go on.
Okay.
You're
okay.
doing well.
So the anterior wall of the former external auditory canal, the anterior wall of the post-operative cavity is being exposed, and the cholestatomic mass is being taken away from the epitympanium area. Here you can see the bony defect of the middle fossa dura, and this is the other place where the dura has been exposed by the process, by the inflammative process. So all the layer of the middle wall of the cavity is being put away, because in subtotal petrosectomy, and by the way in the radical cavity surgery as well, we for sure try to not preserve it, even if we're sure that there is no epidermis on it. So it's better to drill out everything till the bone. The logic muscles are being put away. Another important step in performing the subtotal petrosectomy is to make a closure of the eustachian tube, and that's why it was drilled out till the isthmus. So you can see here the eustachian tube, and it's been drilled out, and then the closure with outer cartilage will be performed. So the mastoid segment of the facial nerve is being put a little bit down to be sure that there is no pathologic process in facial recess. So yes, now the cartilage is being grafted from the auricular cartilage, and is being placed and put into the eustachian tube to fully tamponate it. And also it's fixed by the outer fascia. Now the new cochlear implant is being put into the previously formed pocket and bed, and being provided to the access to the cochlea. On the first surgery, it was around window access, so for sure there was a scar tissue, but still we didn't need to perform another access to the cochlear spiral canal, and used the same one. So it's the standard electrode being inserted without any troubles. The inflammation didn't come to the cochlea, so there was no spiral canal obliteration or stenosis, and electrode is being fully inserted into the cochlea. At the same stage of the surgery, the fat was harvested from the belly of this lady, and yeah, now then you will see it being put into the cavity to make a closure, and we put the fascia to fix the insertion place, the round window area place. the excesses of the electrode are placed in the cavity. The excesses are also covered with outer cartilage and fat. The fat graft is being put into the cavity as well. It's been tailored to the size of the cavity, and now the wound will be stitched and layer by layer closed. The drainage tube was left in the area, and we don't use cosmetic stitches in such kind of surgeries, and put the just cutaneous stitches as in all informative years. Thank you, and sorry for this delay and inconvenience caused by us.
Sampath, if you're there.
Yes, I was there. I'm sorry, I unmuted myself.
Okay. Do you want to remove your mask? We would like to see you. Good man. So what we'll do is we'll give you guys another 5 minutes. So we've just run out of time, but we factored in use like connectivity and whatnot. So Andre, I think Vlad came in and left again. So between you and Sampath, if you can discuss for the next 5 minutes, and then we can close this session. Yeah, go ahead.
Thank you, sir. So a couple of comments, and Andre can probably take this forward. So I believe that when we are doing a subtotal petrosectomy, we have the liberty to have a wide mastectomy, even do the deeper skull-based procedures. So disease clearance is important. So without disease clearance, a subtotal petrosectomy would fail. So whether it's a cholestoma, whether it's a tumor or an infection, it needs to be cleared completely. That's the foundation on which simultaneous ipsilateral cochlear implantation alongside subtotal petrosectomy stays on. First thing. Second thing is adequacy of the blind sac itself. The blind sac, if not done properly, could lead to epithelium migrating inwards into a fairly big cavity that you would have drilled out doing a subtotal petrosectomy. So this is something that needs to be kept in mind. And the third part is the skin clearance on the medial part of the blind sac. So when you cut the external auditory canal, you do a good blind sac, but if you've not removed the remaining part of the skin, the tympanic membrane, the annulus in toto, then that could again be a source of cholestoma. So it's very important fundamentally in a subtotal petrosectomy with cochlear implantation to first do an adequate disease clearance, to do a perfect blind sac. In my case, what I do is I do a 2-layer blind sac. I bring it out like the way you did, Andre, and then I reinforce the blind sac with a second layer where I stitch in the conchal cartilage to the tracheal cartilage. And in most cases it happens, but in those cases where it doesn't, I still take the lower border of the flap that I've created and still manage to get a second layer of a closure along with the blind sac. The third thing which I would like to bring it to the audience notice when one is doing subtotal petrosectomy is about the suprastructure of the stapes. Now, when I have seen in my previous cases that when fat is deposited without removing the suprastructure of the stapes, sometimes the pressure of the fat itself can give rise to postoperative vertigo. And quite often this is attributed to the CI itself, but it's not really true. So it's very important to resect the suprastructure, leave only the foot plate so that there is no pressure effect on the stapes leading to postoperative vertigo. Finally, the fat itself. The fat, when put inside, should be free of infection. So we're going to take it out from the abdomen, and it's a different site. I usually use 2 sets of instruments. I don't mix the 2. I put fat in gentamicin just to make sure that the fat is sterile before I put it back into the cavity. So cochlear implantation with subtotal petrosectomy is a brilliant idea. It gives a lot of area for the implant itself to be put in place. So there's no question of a misplaced implantation, but the caveat is disease clearance, adequate blind sac, adequate closure of the stitching tube, which is also another portal of entry for infection to come in through the nose, and of course fat which is free of infected, which is treated fat, I would say, with gentamicin. So some of these points that I would like to highlight. I would like your comments on what I just said. Thank you.
For sure, Samarth, I can't agree more with you, especially in terms of skin, working with skin. And in this particular case, we didn't have Staples superstructures, and that's why we didn't need to remove them. So it was the better variant. But
I also noticed that I also noticed, Andre, I also noticed that you were lucky in terms of the conchomyotoplasty itself. If the previous surgeon had done a fairly large conchomyotoplasty, you would have had a difficult time doing the blind sac. I've struggled with some of my cases as well, where the previous surgeon had done a radical cavity with a big conchomyotoplasty in the old classical way, which would mean that it's not going to be an easy blind sac as well. So these are some of the, I would say, pitfalls or difficult points when one would do a subtotal petrosectomy.
Yeah.
So, Vlad has joined. Maybe he has some comments.
So we're glad to have you back, Vlad, and sorry about that technical glitch. But I'm sure you were the operating surgeon along with Andre, so you know what video was played. So if you would like to share your thoughts, your experience with subtotal petrosectomy in relation to cochlear implants. I know you've done vibrant sound bridge surgeries with subtotal petrosectomy. Just share us your vast experience in this kind of surgery.
So we do it not, as Andrei said, we do it not every day. It's not everyday procedure, it's not routine. But sometimes if we have a radical cavity and if we have to close everything, and if we want to ensure that we will get a good result from cochlear implantation and no drainage from a cavity, so we do it. We do subtotal petrosectomy, and usually it's re-operations like this. It's also, it was second surgery on this patient, and several years ago she undergone tympanoplasty and some kind of canal wall down procedure, and it's better to close your second tube and to close to cut any relations between outer ear canal and environment. It's better to do this because sometimes our complications worse than we should expect. And also it's discussable topic if should we do subtotal petrosectomy if you have CSF leakage during surgery in cochlear malformations. So usually we try to use formed electrodes with cork, and we do not use subtotal petrosectomy in malformations. So usually we do it only for chronic otitis and for radical cavities, and sometimes for, of course, if we will discuss something close to chronic otitis or some pathology of inner ear, we can speak about this a lot, but if we discuss only cochlear implantation, I can say that we do with surgery subtotal petrosectomy only in cases if we have revision surgeries, if you have some conditions with chronic otitis, with cholesteatoma. Okay.
Yeah, that's great, Vlad. And unfortunately, we couldn't spend more time with you just today, but we'll do that definitely another time.
Sorry, it was something wrong. My connection
with the links. Yeah, it happens. So thank you, Vlad, and thank you, Andre. We've been in conversation for the last
thank you
now, and wonderful. We enjoyed the video, we enjoyed the discussion, and thank you, Sampath, as well, for your contributions and your sharing your experience with us. Sampath, incidentally, was in Italy with Mario Sana, one of the largest skull base units in the world. And so thank you again for doing this for us.
Thank you, sir.
Thank you.
All right. Bye for now.
Bye for now.
On to the next video session, and this is on Bone Bridge by Javier Gavilan, and we will use the moderator. Dr. Shankar Madikiri will introduce the chairperson moderator, which is Dr. Rajesh Vishwakarma.
Nandel Berlin. Oh, he's on, huh? Good morning, everybody. It gives me great pleasure to introduce Dr. Rajesh Vishwakarma, one of our past presidents of Cochlear Implant Group of India. He's the director, professor, and head of the Department of ENT and Head and Neck Surgery at Apollo Hospitals International, Ahmedabad and Gandhinagar, Gujarat. He was the president of Cochlear Implant Group of India from 2017 to 2019, and is also the president of Neuro-Otological and Equilibrimetric Society of India from 2017 to 2018. Having pioneered the cochlear implants and other hearing implant surgeries in government hospitals in India, that is his credit, and he have mentored and trained scores of surgeons and helped people to start cochlear implant centers across the country. He has been an invited faculty at numerous national and international conferences and have performed live surgeries at various workshops and conferences. And he has published more than 25 peer-reviewed articles in national and international journals. Over to you, Dr. Rajesh Vishwakarma, to take over and conduct the further proceedings of this next surgery on the bone bridge.
Thank you, Dr. Shankar, for that nice introduction. And moving on to the next session, which is for bone bridge surgery, we have with us an eminent faculty, Javier Gavilan from Spain. So before we start, let me introduce you. Dr. Javier Gavilan studied medicine at the Autonomous University of Madrid between 1973 and 1979. He then completed his ENT residency at the La Paz University Hospital. Later, he worked as a specialist doctor in different hospitals in Madrid until he obtained the position of titular professor of ENT at the Faculty of Medicine of the Autonomous University of Madrid by election in 1989. In 1997, he was appointed head of the otolaryngology services at the La Paz University Hospital, Madrid, Spain, both the General Hospital and the Children's Hospital. In 2005, he was qualified as professor of the specialty by election, obtaining 3 years later the position of Professor of ENT at the Autonomous University of Madrid. Also, let me tell you that Dr. Javier Gavilan had visited Delhi in one of our national conferences, and he delivered the lecture on bone bridge, and we were all very much impressed by his work on the bone bridge. Over to you, Dr. Javier Gavilan. Please, we can move on. Thank you.
Good morning, and thank you very much for your kind introduction. It's a pleasure for me to be here. I would like to thank the organizing committee for allowing me to be here with you. And I would like to show you a live surgery on bone bridge. Can you hear me well?
Yes, we can hear you well.
Okay, I will share the screen. And before starting the surgery, I would like just to give you a brief idea about the case we are going to see now. I would also like to thank my co-worker and good friend, Dr. Luis La Saleta, for sharing with me all these last years of surgical experience in the field of otology and hearing implants. As you all know, the indications for a bone conduction device depend mainly on the bone conduction threshold of the patient. So for bone bridge, which is the case that we are going to show in a minute, the bone conduction threshold of pure tone audiometry of the patient must be within this red area. And the idea is to have the bone conduction in the upper part of this red area, because when you approach the lower half of this area, you will have another solutions. Right now, the solutions for hearing restoration are so large that you shouldn't go to the end of the indication. Just move to the next thing you can do before doing an indication which is just in the margin. You all know that bone bridge can be positioned in the mastoid. This is the typical or the original position for bone bridge, but you can also put it posteriorly in the retrosigmoid area. The idea of retrosigmoid means for most surgeons means dura and cerebellum and CSF, but it's just a small hole that we are going to do in the posterior part of the mastoid behind the sigmoid sinus. Or you can go above the mastoid to the middle fossa area and do a middle fossa implantation of bone bridge. These two options are our main election in most cases, because our main indications for bone bridge are patients with radical cavities, therefore there's no mastoid, and patients like the case I am going to show you just after this short introduction, which is a patient with an oral atresia, a congenital malformation. And these patients may require reconstruction of the ear going to the mastoid. Therefore, leave the mastoid free and put your implant posteriorly or superiorly to let next surgeons be able to have a free surgical field. Okay, now coming to the case, this is a 35-year-old female that came to us with a left ear congenital atresia, and she also had a facial paralysis due to a hemorrhage at birth. As you can see, she has almost no ear, and she had obviously on the other side a completely normal hearing on the right side, and of course a purely conductive hearing loss on the left ear with a bone conduction very in the middle of the bone conduction indication area for a bone bridge. And she was asking for a solution, and we decided to put bone bridge. As I told you before, you can put bone bridge in the mastoid, you can put bone bridge posteriorly, or you can put bone bridge in the upper part in the area of the middle fossa, according to the required reconstruction that can be taking place in this area. So therefore, we have these two options, and we check the retrosigmoid position. The main problem with these patients is that you have no landmarks to show where your incision must be. This is the mastoid tip, so you're lacking a lot of landmarks to position the bone bridge, but the retrosigmoid area should be around here, and the middle fossa area should be around here. And we finally decide to go to the middle fossa and put the bone bridge there. So just a few words about bone bridge itself. Bone bridge was delivered to the market around 9-10 years ago, and that was the first version of the device, which is the BCI 601. A couple of years ago, we had the new version, which is the BCI 602. The main difference, the most important difference of these two versions is that BCI 601 has almost 9 millimeters of depth that must go inside the bone of the skull base. And patients don't have, most of them, especially children, don't have almost 9 millimeters bone in the retrosigmoid or in the superior part of the temporal bone. And BCI 602 has only 4.2. So the main difference is the reduced depth of the BCI 602. But it also has a couple of more differences. One of them is that instead of having to drill a hole to put the screw, we use self-drilling screws that just go inside the bone in a matter of seconds or just less than 1 minute. It's a fast, it's an easy, and it's a tight fixation. It's much more tight than the one we did before, drilling the hole and then putting the screw. And finally, BCI 601 had lifts to bring this 9 millimeters outside, and it had 4 lifts coming from 1 millimeter to 3 to 4 millimeters, just to bring this part less deep into the bone. As you said, as I said, as you know, the BCI 602 is only 4.5 millimeters, and therefore the lifts have been reduced to just 1 millimeter that you can put here and bring this depth of insertion reduced to 3.5 millimeters, which is available in most cases, even in small children. Just one last comment is that you can put 1 lift, 2 lifts, or no lift, depending on the situation and the curve shape of the skull of every single patient. Okay, now let's move to the video. It's a surgical video, as the organizing committee asked me to do. I have made almost no edition of the video. It's a complete surgical procedure. It takes around 25-26 minutes, and I will be commenting. And of course, if you want to have any question at the end, we can. I will be more than pleased to ask your question, to answer your questions. So the bone bridge is here, and here we go. As I said, it's a female, 35 years old, with the left ear congenital atresia, and we are going to put the bone bridge 602 in the middle fossa. This is the patient with the position of the mark position for the receptor, and we will start. And as you will see, we start with an incision that initially seemed good, but we will have problems when we try to insert the implant, and we have to extend a little bit. And this is one of the problems that we have, as I said before, because we have no landmarks. So we don't have an ear, so you don't have a real image of what's going on, what's the size, the real size of this incision. Well, the fact is that we started with this incision to go to the middle fossa. Remember, we always perform 2 layers. We do a superficial layer and then a deep layer, a deep plane, including the muscle, just to cover at the end of the operation the whole implant. We ligate the temporal superficial temporal artery that is just in the middle because it's a middle fossa approach. We section, and ligate both ends. It's a large artery, so you better make sure that it's well ligated to avoid bleeding, especially in the post-op period. If you just coagulate or do electrocoagulation, it will be more dangerous. So we just prefer to suture the artery. Of course, if you go to the retrosigmoid area, you will not find this artery. In the retrosigmoid area, you will find the emissary vein, which is also a problem. You have to coagulate or to put some walks to avoid bleeding from this in the posterior area. But here we are above the temporal line and we have the superficial temporal artery. So after ligation, we raise the second layer of the flap. This is the first layer, and we will section the temporal muscle and create, like in any other one, a subperiosteal flap, a subperiosteal pouch. So we are going to develop a lift of the temporal muscle to create the space to insert the receptor for the coil, for the magnet that will fix the external part of the implant. We just separate, like for this is same step as you do for a cochlear implant, for an ABI, for a sound bridge, or for bone bridge. All these implants, they will need a separation, a plane where you can go over the bone without having to open externally, just creating this. As I said before, you can see this is very narrow. So we tried to insert the dummy to see if it fit, and it was obvious that the incision was a little small. So we extended a little bit the incision. As I said, this is like live surgery, so I will show you everything as it was. Now the incision is a bit more wide, and we will have space enough to put the implant, as you will see. We will have to extend the subperiosteal area that we created first, and you will see this in a second. We put a self-retaining retractor to have both hands free and complete the subperiosteal separation of the temporal muscle, exposing the bone where we are going to make the bed, the bony bed for the FMT, for the floating mass transducer, which is the vibrating part of the bone bridge. So separation of the temporal muscle, we try to pull it upwards and create, and we imagine more or less where the position of the receptor for the magnet must go. This is the area where we want it to be at the end of the operation, which should be around an angle of 45 degrees of the temporal line. If the temporal line is here, we want the receptor to be in a 45 angle of the temporal line, just to keep it in a physiological position. So you can bend this transition between the FMT. You can bend the transition between the FMT and the receptor can be bent up and down, and medial and lateral, as I'm showing now. So this is where the FMT will go probably, and this is where we want the receptor for the magnet to put the external processor outside. So this is, right now I think we have enough space to drill the bone and prepare the bed for the bone bridge. We complete the insertion in the subperiosteal pocket, and we check the final position before starting drilling to see that we will not have to touch more the incision. This looks, well, to me, I think it's good position, and therefore we will start drilling the bone. Just to make sure that we have the right position. And this is a step that we always do to check the thickness of the flap, because a very thick flap may create problems with the magnet, with the fixation of the magnet. If you have to put a very strong magnet, you can create problems to the skin. And if the magnet is not good enough, the sound processor will fall down. Therefore, we prepare a flap that is at the most 7 millimeters of thickness. That was what I was checking before. Now we mark the position of the FMT, where the place where we want to drill the bony bed. The tool to mark is always difficult to handle and see because it's straight handle, but we can mark it more or less. We have an idea where we want our FMT. And right now, the only important thing that you have to do is to make a tight bed, not to be too big, because if it's too big, you will not have place for the screws going into the bone. So the FMT doesn't have to touch the bone. This is not the idea. The idea is sound is transmitted through the two screws, but the two screws must be very well fixed into the bone. So we go little by little, going from smaller to bigger, just to avoid a huge bone bed and no place to put the screws. And we start always with the largest burr we have. And remember, a very important thing here is to have sharp edges of your bed, of your bony bed. You cannot have a bowl. You have to have a pot, a straight angles to be able to put the whole implant inside. Once we reach the dura here in the temporal, in the middle fossa or in the retrosigmoid area, most of the times you will have to expose the dura. But exposing the dura is not a big deal. It's not a problem because right now with the 602, there's almost no retraction. And even if it's retraction, there is no problem of retracting. We have been doing this and putting bone ridge in contact with the dura since 2012 without a single problem in the middle fossa or in the retrosigmoid area. So you have to be careful drilling to avoid injuring the dura, which is this is of course important, but it's the idea of the implant touching the dura is not a big problem. Once we finish with a big drill, with a big burr, we will change to a smaller one just to make these straight edges on the bottom of the bed to allow the good positioning of the bone. But you see the dura there. So we separate dura from the bone to complete the drilling of the anterior part of the bony bed and complete the removal of these rounded edges left by the burr, by the large burr. Separation of the dura from the bone, just to avoid injuring with the drill. And as I said before, this is not a real middle fossa approach. A middle fossa approach will include the exposure of the superior surface of the temporal bone and entering the internal auditory canal or closing a CSF leak or whatever. You see that it's still very little, but as I said before, I don't want to make it big, because if I make it big, I will not have room for the screws and I will have to start checking for a different position. This is something we always do. We use a silastic sheet to protect the dura now that we are going to drill over the dura. So we put this elastic, this one is obviously too large, we have to trim it a little bit, and insert under the bone to protect the dura from the drilling. So we are just trimming the elastic sheet, and once we have it, we will put it inside. So elastic is now inserted, will be inserted into the under the bone, between the bone and the dura. Here we go. Now it's rounded and more appropriate in size. And here we go. And this will protect the dura from the drill, from the burr. Now we can remove all this anterior part of the bone that is remaining and complete the full size of the bony bed. As you see, most of the operation now we change the burr, and now we are using a diamond and not as large as the first one. And with this diamond, we will carefully remove the bone. And as I said, I was telling you, most of the time of the surgery is just dedicated to create this bony bed with an adequate size to the bone bridge, to the FMT. Some surgeons use the tool that neurosurgeons have to create craniotomies. The size, the diameter of this device is quite the same as the one of the FMT, and some surgeons are using this. I never did. I always used autologic burrs and drills, just like for any other autologic procedure. But maybe this could be an option if you have access to this kind of craniotomy devices. We keep drilling, and that will be most of our time. Will be just drilling, just to create straight 90 degrees angles, edges, to be able to accommodate the FMT in its final position. We will do the same now to the posterior part. We put this elastic, continue measuring, checking where we want more or we want less bone, where we don't want to go further because it's just close to the edges, and just making sure that you don't make this hole too big. I'm marking a little bit more again. Here you see we will drill this part. This is okay now, but we will drill here. We'll remove this part of the bone until we can put the FMT. And as I told you, there is no need of the FMT touching the bone. It's not a problem if it touches the bone, but you don't need to keep the FMT in contact with the bone. What you need is to have the two screws that you are going to fix, self-drilling screws that you're going to fix so easily with this 602, with this new development of bone bridge, with this new version of bone bridge. And with this, you have to fix the screws very well, very tight into the bone, because this is the method that bone bridge uses to transmit vibrations to the bone. We are just getting to the size. Now, the final size will be around here, but we need to remove this bone to create a sharp angle here. So we do the same as we did before. We protect the dura with elastic, and we use a diamond burr just to cut the edges of the craniotomy, of the round craniotomy we are doing to put the FMT. Irrigation, slow motion, and trying not to go close to the dura, but it's protected, so it's not going to be. We will not have any problem. We actually never had a problem with this surgery. We're used to skull-based surgery procedures, and therefore we are familiar with dura in the middle fossa or in the posterior fossa. But as you see here, in the external part, we have enough bone removed, but we have to remove the bone just inside, just to create what I told you from the beginning, a sharp angle to be able to accommodate the shape of the FMT. So this is important, because you may have, if you go further away now, then you can start being in problems, because here you will not have bone. If you go further here, which is where the screws are going to go, if you don't leave this bone here, you will get in trouble. So you need space inside, not more outside, not further outside. And this is why it takes so long. Well, so long means 17 minutes up till now. It's just making a very adequate. Now we are just getting to the size, still a bit more, but as I said, most of the time of this operation is drilling. What I'm doing now is, with bipolar coagulation, I coagulate the dura. When you do this with bipolar coagulation, the dura retracts. So this is a measure that we use very often in skull-base surgery, and it helps to retract the dura, not to have it so bulging outside. And it helps, just the separation, as you see, it helps. It's just 2 or 3 touches with bipolar coagulation. And with this, first of all, you will not have bleeding from the superficial dural vessels. And second, you will get a good retraction of the dura. And we will complete the bed for the FMT anteriorly, a little bit more. Once we put the dummy, the positioning tool, we check where we need more drilling, and we check where we have enough drilling just to avoid removing too much. So we go little by little until we obtain the final shape and size that we want. So elastic again is very helpful, because it gives you, I mean, if the diamond bird touches down, it will not touch the dura, it will touch the elastic, and it will not create any problem. As you see now, I'm just drilling the inside of the bed, the inside where the angle must be straight, not outside, just inside, just creating a 90 degrees angle all over the circular shape of the bed for the FMT. Well, actually, this is not a difficult surgery. You have just to be careful with the size, but this is, and with the structure around. But this is like any other surgery. You have to always be careful. Surgeons are careful or are not surgeons. And right now, I think we have it. Now you see, it comes into the dura. It stands by itself. So now we can put the FMT, and now surgery will be very easy. It will not take too long. We are just preparing the device. They are opening the package and giving us the measuring tools. We are going to check if we need lifts or not. As I said, we have 1 millimeter lifts. And if you see here in the anterior part, the bone is very, very thin, and here in the posterior part is rather thick. I told you we can use 1 millimeter lifts, 1, 2, or none. So probably here we will have posteriorly, we will have enough bone, and this wing will lay very close to the bone. But here we will probably need a lift, just because of this difference of thickness of the bone anteriorly and posteriorly. So we check this now with the dummy. I prefer to use my finger because the tool, oh my God, wait a second. Because I was telling you, because the tool is, the handle of the tool is always in the middle of the field. So I remove the handle, as you see here. I remove the handle and just keep the dummy to check the final position of the FMT. I will not touch anything. And you need a very close contact. This is what I'm checking now. There must be no room between the bone and the wing of the bone bridge. This is important because this is where the transmission of the sound is going to come from. So the bone must be in close contact of the wing of the place for the screw. And as I said before, this is very thin. What we do is put some Surgicel. This Surgicel is not intended to prevent hemorrhage, but just to retract a little bit more the dura. So the dura now will be further away from the bone, and we will be able to put it. Now, this is how we want the device to go inside. I'm letting it there just to show. And now I will insert into the subperiosteal pocket. And I'm taking a leaf, a 1 millimeter leaf to put anteriorly, as I said before. This is just, I didn't see that very well in the video because you do that outside of the microscope. So I was doing that outside. I was putting a 1 millimeter leaf on the anterior wing. And now we insert, as I said, we can twist this up to 90 degrees. You insert the receptor for the magnet into the subperiosteal pocket, and we put the FMT in its final position. And now with self-drilling screws, I told you it's a minute. Well, now it's 22 minutes from surgery, from the start of the operation, 23 minutes, and see how fast you fix it. Before it was a mess using a drill for the holes, and then the screw didn't fix so fit and so well. Now I'm checking there's no room between the leaf and the bone. There's no room, it's absolutely in contact. And here also, and here there's no, once you push the FMT, there's no room. So this is good contact here, good contact here. And now we take the screws, remove the bone, remove the muscle just to be able to put the screw more easily without disturbing the disturbance from the muscle. And now this is the screw that comes with the screwdriver, and this is real time putting the screw. And you just let it not very tight, put the other one. This is not tight enough yet. We put the other one, it's also seconds. You put some pressure on the top of the screwdriver, and like I'm doing with the left hand, and twist with the right hand until it takes, you didn't fix it too much. I didn't fix it too much. Now I go to the other one, tight a little bit more, come back here, tight a little bit more. And within 1 minute, you have very strong fixation. Now we check, we try to move the FMT to see if you can move the whole patient just by holding the screws. Well, now suture, as I said, is 2 layers. We suture the muscle. This is made, I mean, this is edited. This is, I'm not so fast. I'm fast, but not so much. And I don't think there's any special interest on watching a closure, but I put the whole operation as they asked me to do. But this is a bit faster, and we cover completely the FMT with the second layer of the flap, and then we suture the skin to finish the operation. So you will see that there will be no FMT uncovered, and then the second layer will finish closing the skin. I hope you have been able to see the video. I don't know, you know, the transmission of images is so sometimes it goes jumping and is not good quality. Here I'm seeing the video very well. I hope you had the chance to watch it also with good quality, because the video actually it has good quality. And
yes, Dr. Javier, that was an excellent presentation. We could see the whole video very clearly and all the steps were crystal clear. I would just like to know if we have any questions. The hall coordinator, do we have any questions?
Doctor, there is one question. We have put it in the chat box.
Okay. The question.
Okay, I check the chat. Do you rely on Autoplan for making decision on site? Do I rely on Autoplan for making decision on site? No. No, because you know, you can have all plannings you want before the operation, and once you get there, there is not a single landmark, so you don't know where it was the idea of the positioning. And if I need lift, I will check in place. So I don't do any imaging study to check where I am going to put it. Sometimes we do imaging studies just to check the situation, to see if, how thick is the bone. But even if you get a good planification before, you have no landmarks once you enter there, and this planning is not good at all. And second question is, superficial temporal artery was ligated with, which may be required for penile reconstruction. Is it required in all cases of superior placement? Well, it depends on where the incision goes. It may be a little bit further posteriorly. You saw that I extended the incision anteriorly. It may go posteriorly, and you may spare it in some cases. This is a 35-year-old female. It will probably not have a reconstruction. But anyway, in our practice, most reconstructions are done with prosthesis. They're not done with flaps or organic material. They're put with screws. So what we need is bone for the plastic surgeons to put the screws. If you are planning to make a reconstruction, you need vessels, important vessels. I understand that this may be an important issue, and keep it in place.
Right. So Autoplan actually does not help in these cases. And we can definitely avoid the superficial temporal artery as and when needed, and that can be saved as well. The one question that I have in mind, Dr. Javier, is that when you made the base for the BCFMT and we were directly on the dura, do you ever put bone dust over it so that it might help?
Do I put
spreading bone dust on the?
No, you mean to protect the dura or to?
No, you can always touch the dura. Dura is a very tough structure, but before putting the BCFMT, why don't we spread the bone dust over the dura? Because that is what I do whenever I am directly on the dura. So I collect the bone dust while making the bed, and then put that bone dust or spread that bone dust on the dura after everything is done.
Well, we
then put the BCFMT.
I know what you mean. We did that not with bone dust. We did that at the beginning with artificial dura over the dura, but I stopped doing that because I don't want to press the dura, or I want to press the dura as little as possible. If I put more layers, then I will create more pressure. So what I'm doing is the opposite. I try to put between the edges of the FMT of the bone. I put a Surgicel that retracts the dura and retract the dura physiological. Well, I know this is going to reabsorb and disappear. I'm not extremely worried about touching the dura, because after so many years we had no problem. But I put at the beginning
usually
artificial dura, but no bone dust.
Even if you push the dura, it does not matter. What I do in my practice is that I spread a small layer of Surgicel and over that a small layer of bone dust, and then put the BCFMT. Maybe that gives me a mental satisfaction or what. Right?
You know, there are many of these maneuvers that surgeons we do that, and I will say the same. It's the surgeon who needs that, not the patient. But we will do this kind of thing. So this is the way.
And one more thing I just wanted to ask, that in that model, which you showed now, that's 2, you have not measured the torque. Is it not needed now? Or it is only that your tactile sensation that tells that now the screw is perfectly fit? Because we normally measure the torque of the screw and see how fit the BCFMT is.
Okay, you need a torque wrench.
Yeah, torque wrench, you measure it.
When you were doing the first version, when you were drilling a hole, and you need a torque wrench because the limit between going outside and passing the screw is very high when you drill a hole and you use the previous screws. With self-drilling screws, we never use a torque wrench because, well, I mean, you can break them also, but yes, with the fingers you feel, and it's much tighter than before, and there is no risk. The risk of going loose with the screw is much less than before. So this is one of the advantages of the new device.
So because this is a self-tapping screw, you have that tactile sensation of the tightness, and you only decide on table that yes, this is done.
Exactly, you feel it. You feel it. Before you couldn't feel it. Even with 20 nanometers, you could have a loose screw, and here you need. I mean, you can break it, but you need to want to break it. If you just do like this with fingers, not with the whole hand. If you do with fingers and put it tight, it will be tight like much more than the other one, and it will not have the risk of going loose.
Okay. So do we have any questions? I think that was an excellent presentation, and the time is now running out. We may proceed to the next session. Thank you very much for your time and your excellent presentation that you gave. Thank you, sir.
Thank you, Rajesh. Thank you very much, all of you.
Thank you, Professor Gavilan, for an excellent surgical demonstration. It was as good as watching a live surgery for all. Thank you very much for accepting our invitation and showing this video. Thank you, Dr. Rajesh, for moderating this session and also giving your inputs on your experiences on bone breach. So thank you very much. Now we are moving to the last surgical demonstration of the pre-lunch session of auditory brainstem implantation. I think Dr. Thomas Lenars and Dr. Mohan Kameshwaran have already checked in. So I will request my colleague, Dr. Sunil Dutt, to introduce Dr. Mohan Kameshwaran, please.
Yes. Okay. I think all good so far. Enjoyed the previous session by Javier as well. And I'm here to introduce Dr. Mohan Kameshwaran. Now, I'm just looking at everything that's been written here, and I'm wondering how did they bring to one slide a 100-page CV of this highly accomplished man. Professor Kameshwaran is an authority in the field of otorhinolaryngology, a Padma Shri recipient with contributions not just to science, but also to the society. The phenomenal social service he's done to the state of Tamil Nadu and to the country, India itself, is something worth emulating. Dr. Mohan has been the founder president of the Cochlear Implant Group of India. I was his secretary in 2003, and look where we are today, Dr. Mohan, after 19 years. I think it's absolutely amazing. We are nearly 700 members in this focus group. Dr. Mohan is also the first surgeon in the Asia Pacific region to have performed the pediatric auditory brainstem implant. And I think I can go on and on. I think it would suffice to say this person is a supreme human being. Over to you, Dr. Mohan.
Thank you, Sunil. Thank you for those very kind words. Now I have the great pleasure of introducing a very good friend of mine and one of the, let's say, leading authorities in the field of auditory implants in the world. I speak of no less a person than Professor Dr. Thomas Lennartz. To introduce him to this audience, I think would be presumptuous on my part. In fact, it'll be like carrying coal to Newcastle. I don't think there'll be anyone in the field of auditory implants who is not familiar with the work of Professor Thomas Lennartz. He's a renowned expert in the field. He heads a department, the professor head of department at the Hanover department in Germany, University of Hanover, and has really built up the department into a department which is probably the leading department in this field. He's a prolific researcher and has produced several landmark papers, citations of over 7,500 and over 620 research papers. So I think that itself should speak about the man. I've had the pleasure of sharing the platform with Thomas Lennartz many times. Always been impressed by his very incisive outlook on many aspects of the auditory science. So I don't want to stand between him and you, and I really look forward to hearing from him, he being one of the leading figures in this field. So over to you, Thomas. I really am happy that you're here today, and hearty welcome to the conference. We hope to listen from you more and more over the coming days. The stage is yours.
Thank you very much, Mohan, for this kind introduction. Thank you to the organizers for the invitation to your conference. And it's a pleasure for me to speak to you on the topic of auditory brainstem implant. So I hope that that I can share my screen with you, and that we go for the brain. You should see the full screen, hopefully. So auditory brainstem implant, and I know that Dr. Kamal has extensive experience with this topic in his patients, especially in children. So I just can share a few experiences and data from my side. Now, when we speak about auditory brainstem implant, then we speak about central auditory prosthesis. And there are two versions in clinical use. The one is the brainstem implant, which is positioned at the second order neuron of the auditory pathway, which is the cochlear nucleus, as we can see here. And then there is another option, which is only in clinical study. There's auditory midbrain implant, which goes into the inferior colliculus. Now, these implants are indicated in patients where there is no connection between the cochlea and the brain, so damaged or missing auditory nerve, or we have conditions in the cochlea which do not allow for cochlear implantation. The main prerequisite is, however, that the central auditory pathway from the cochlear nucleus to the auditory cortex is really functional, and that there is no damage along these pathways. Now, there are several versions of this brainstem implant. There was also an experimental version available, which is a penetrating one. You see here pins that were inserted into the cochlear nucleus, but it's no longer available. And so we stay with surface electrodes, plate, so to say, which is placed in the so-called lateral recess of the fourth ventricle and on the surface of the cochlear nucleus. You see here the surface of the cochlear nucleus. So we just place it on here. The midbrain implant is penetrating. We will come to that later. Now here you see a graph from House Ear Institute, how this plate is then positioned over the cochlear nucleus, where the second order neuron starts, and the access to it is basically through the lateral recess. We can reach it to show you in a minute. And here you see how it's positioned. We have several parts of this cochlear nucleus, and these electrodes are basically on top of it. Now, the point is, of course, that we do not address the tonotopic organization of this cochlear nucleus in a proper way. That means we only stimulate from the surface, and therefore it is difficult to predict which frequency range is stimulated with this type of electrode. But that's what we have available for those patients who basically need it, such as with bilateral acoustic neuroma in NF2 patients, or in patients where we have an ossified cochlea, or where there is no auditory nerve due to malformation. And here we see more closer, we have cochlear ossification, for instance, or here in this case where there is only the facial nerve running, there is no cochlear nerve. Now, when we look on the development of our program, we actually started many years ago, and over the time we have used different types of audio brainstem implants as they came along. Mainly those from Cochlear Company and from Medel, and several of them have been, so to say, in our practice. We also have patients who have formerly used the cochlear implant. You see here these bars, and then switch over to audio brainstem implant, mainly in children where we first initially tried a cochlear implant, or also patients with neurofibromatosis type 2, where we also have a cochlear implant, and then by time patients lost the hearing due to some progressive damage of the auditory nerve. Now here, again in children, just to show you one case where we have no nerve at all. You see here there is no internal meatus. That is a clear indication, for instance, for hearing rehabilitation in children. Etiology is different. You see here eighth nerve agenesis, cochlear aplasia, Michel aplasia, golden hair syndrome, Charles syndrome. So very diverse cases we could follow over the years. And you see that the conditions which are there might also have different impact on the cochlear nucleus anatomy and physiology, but so far it's very difficult to check it preoperatively, especially in small children, whether these pathways are functioning or not. Now let's come to surgery. In most of our cases, we use a retrosigmoid craniotomy. In some cases also translap, especially if you had already previous surgery, then this can be done. The main point is that we have to expose the CP angle and cerebellopontine angle in order to get access to the lower cranial nerves and follow there then the pathway to the lateral recess. So you see here right ear is all exposed. We expose all of the sinuses, which basically give us the limits for our dura incision. You see here the transverse sinus, then the sigmoid sinus, the ear is up front here, that is cranial, and this would be inferior. And here you see now dura incision. We follow basically here the sinuses, makes this U-flap, and then we can enter into the CP angle. As you can see here, the cistern is opened, then there is some efflux of CSF, and the cerebellum falls, so to say, back, which gives us a nice opening into the CP angle. You see here, that is the temporal bone, the backside, this is the cerebellum, and here now we enter basically the CP angle. Here see it more in detail. We have to look on some vessels like the anterior inferior cerebellopontine artery, cerebellar artery, sorry. Here is again the temporal bone, and here we see already the lower cranial nerves exiting here to the foramen jugulare, and then we can identify the structures we see in the CP angle. Now, you see here some identification of those nerves, where we then also can deal with some vessels. Once we have identified them, then we can work further on dissection of the lateral recess. Up here would be the internal meatus. There is no nerve present in that case. These all are lower cranial nerves, and then we can identify the three of them. Now, the main structure is the ninth nerve, the glossopharyngeal nerve, which directly guides us then into the lateral recess. And you see, as we have done it, that is the ninth nerve, we have identified the lateral recess, and now we can place here the electrode. Now, what we try to find out is whether we can stimulate the cochlear nucleus, and therefore we use a probe electrode, which has just 4 contacts. This probe electrode is connected to the stimulator. You see how it's here inserted into the lateral recess. Now, once that is done, we have good auditory brainstem responses. I will show later to them. We go to place the implant. You see here the implant body is above the craniotomy. This will be just here over the occipital bone. We make a bone bed and also make here a connecting tunnel. You see here the electrode departing from the implant, and here you see the electrode pad more in detail. Now, show you just a video. You see here we make this pouch cranial to our craniotomy. Here the implant, it's a Medel device in this case, is then placed in the pocket. We always then try to make it as large as not necessary, but avoid too much tissue dissection so that you have still the periosteum basically over it, and securing the implant so that it cannot move. That is, I think, one important step, because we have to always avoid that this implant would move downward to the craniotomy. You see here now that is in place. Now, second is that we have made this kind of a tunnel. The bony bridge is still left, and here we take some time. It looks a bit awkward, but it's, I think, the good way to also secure the whole system and electrode. And you will see how I try to get it through. Might look a bit initially difficult, but you will see that this is then one just minor step, but important one to get it into the area of the craniotomy. You see now it comes through, and so okay. Then the next step is then that we basically design the dacron. You see this electrode has on the backside dacron pad, which is seen to induce some connective tissue growth in order to keep the electrode plate inside the lateral recess. You see here that we just trim it. In children, it can be that this lateral recess is quite narrow, so that it would be difficult to insert the whole pad, and that's why we then basically cut off some of the edges also. And then once that is done, you see here now the trim pad. Then we go to insert it into the lateral recess. Now, important is that the electrode contacts have to show anteriorly, and the dacron is on the back side towards the cerebellum. And now, of course, you can see that also shows some longer sequence, that it sometimes can be difficult to get it right in place. You see that has been already dissected, and it goes in. And here you see now again how we can insert it here into this lateral recess. I just want to go back here, and because we have shown that already, go a bit further here, and then insert it just to show you more on this. So I did jump, and now we place it here in the lateral recess. That's the 9th nerve. We follow it into the lateral recess that has been opened before, and now we can slowly insert it deeper. Sometimes it can be difficult. It's not that open. Some other cases it can be very wide, so that the electrode is not well stabilized, which means then that we have to, for instance, we have to fix it somehow, and I'll show you also what we do in that case. So you see now it's inserted deeper. How deep we insert depends a bit on the responses. We will see in a minute. Responses means that we stimulate electrically and record auditory brainstem responses. Now here you see a situation where we have basically the electrode in place, a white recess where the electrode was not easy to stabilize. And what we use is a piece of Teflon pate, which is then inserted on the backside of the electrode carrier in order to stabilize it in situ. And this helps to achieve that, because if it's very wide recess, then the risk for electrode migration into the fourth ventricle or out of it is quite high. Here you see now what we do with the recording. Again, a case where we place the electrode, as I have shown it before. And then once that is in, we stimulate electrically through the implant. And you see here we did it and then measured the responses. So all the electrode contacts are activated, and then we see on which we get some responses. You see here only these ones basically gave us some EABRs. So that means that our electrode was probably not deep enough. And you see here kind of these responses more in detail. Normally we get waves 3, 4, and 5, because 1 and 2 of the brainstem responses are generated by the auditory nerve. So there is no nerve, therefore they are missing, but we get ideally these 3 waves. And you see here such a recording with these brainstem responses. Now, going back to our case, it means that we had to go deeper, and what we did is just to place it deeper in and then measure again. And you see that we got now responses, as you can see here, from many more contacts. And so we thought that this would be then the right position. Now it's important because it's blind. You don't have a clear structure like in cochlear implant, where you just have the scalar tympani where you insert the electrode. Here you basically do it blindly, and you use electrophysiology to optimize the placement. Electrode is in, so to say, laid over cerebellum. Retraction is removed, and then we close the dura, as you can see here, in layers. And also you see how the electrode outlet is then here basically brought in order to get it fixed. Here we see now this retrosigmoid approach. That is this electrode, which basically is here in the lateral recess. You can, it goes out like this and to here to the implant. So that's basically what we did. Now, in terms of the results, I just want to show a bit more on details on children and adults. That is now here just in children. I already showed that we have several who have used the cochlear implant before with no success. Then we switched to the brainstem implant. After implantation, we have to sort of train the child. We want to get an aided threshold, as you can see here, across the different frequencies. And we try now to build up that type of stimulation using the stimulus and increasing it until the child shows some reaction, and then we train as it's normally done. Now, in order to measure some success, we use the CAP scale, the categories of auditory performance, initially a 7-point scale by Archbold, 1995. These are some tests which are underlined under these categories, like little ears, maze, mass, speech recognition tests, and so forth. That's all age dependent and also language dependent in some of them. So that is then transformed into these categories from no awareness up to use the phone. Later it was more sophisticated categories, CAP 2, which has now 9 categories. You see also more differentiated in terms of closed and open set speech understanding, but just to do this. Normally we get discrimination of some speech sounds without lip reading, and once we go further with the development of the child, it goes towards understanding of conversation without lip reading. So that is probably somewhere category 5 to 6. That's what we get. Good cochlear implant user child would go up to 8 and 9. So we are in principle below that. The other most important thing is that it takes time. You see here duration of ABI in use. It is in years. And you see that how gradually then these children go up in the CAP scale. In cochlear implant children, it would be much faster. going up like this. We see here, in one exceptional case reaching level 8, sorry. The others stay somewhere, as I said, 4 and 5. That's what we have to expect. Okay, so now there is one problem we have seen, that is electrode migration. You see here one case where we have initially placed the implant at the age of 2.9 years. That's what we got in terms of electrode contacts that gave us some auditory responses. And the child had CAP1, not very good. What we saw then over the years, let's say over 2 years, that the position of the electrode changed. You see here how it's basically moving, could be due to head growth, but also some other influences. And here the animation shows you where the electrode is in the skull, so to say, located. And then what we did is, you see again, these two positions before and after migration. Now, the interesting thing in this case is that this was positive for the child. You see now these contacts are stimulated, giving auditory responses compared to them. It means that probably the implant has moved more into the lateral recess. And the interesting thing is that the child now got CAP5, so probably something which was positive, but it's not always like that. We also have, you see several cases with electrode migration, basically 6, and you see that some of them then are non-users. This is CAP5 exceptional, the others are CAP0, which means normally if you have migration, it moves out of the lateral recess and then there is no auditory sensation at all. So we have to go back in again and do a revision. Here we have now those cases listed. It's a CAP0. Here are the cases with migration, but we have also some other cases where we have CAP0 and where we also had to decide what to do. For instance, do also revision surgery inside those cases, or where we also have to state that probably other additional handicaps might so to say interfere with the development of auditory and speech skills, and then of course it can be difficult to make use of the implant itself. Now, what are influencing factors for the result? Well, we've looked at CAP versus age at implantation. So that means, is there any relation between the age and the CAP and age at ABI implantation versus CAP score? And you basically see there was no clear correlation. You see this is age at implantation, or younger and older children looking on their CAP scores, we basically don't see really any kind of correlation with that. Age at implantation, ABI use up to last visits, this basically again shows there is no real correlation with that. Then we looked on the number of activated electrodes, and basically you can see some correlation. You see here CAP score versus activated electrodes. And you see that those who have more activated electrodes probably have better CAP score, which means that, for instance, the number of places that are stimulated give some different information, and this can be used then also for instance, speech recognition, what it basically mainly means. So in summary, in children, we have 22 children which we can follow over many years. We have done more cases, but we lost some to follow up. So far, 12 patients with CAP scores greater than 0. The CAP is slowly increasing over years. Best child reached CAP 8 after 10 years of ABI usage. But there is no other choice of treatment in patients with neural deafness. Migration was found to be an issue, and there is only a weak correlation between the number of activated electrodes and the CAP. Now let's go to adult patients. These are mainly NF2 patients, as we have seen here in those cases. Looking on them, how is the performance? Well, also here we see a clear difference to cochlear implant users. That is the average cochlear implant user in a given word recognition test, and they are scoring here 60 to 70% on average. Looking on the brainstem implant patients, NF2 patients, and non-NF2, we see that if they only use the auto brainstem implant, then you see that they basically have scored which are somewhere in the range of 10, 20, here exceptional, close to 40%. If they combine it with the lip reading, then they go up. They have some scores which come close to what a cochlear implant user has, but it's the visual enhancement. It's not the hearing alone. And also the same is true for non-tumor patients. These are the ones here. So we have to state that also in adults, the performance we get with a brainstem implant is below that what we see in cochlear implants. Now, also again here, some correlation with the number of active electrodes and performance, the same what we have seen in children. You see here, if the number of active electrodes is lower than 7, then we have significantly worse speech recognition results compared to patients who have a higher number of activated or active electrodes. Some references, okay. Now, in case the brainstem implant fails, just a brief word on the auditory midbrain implant. I would say we cannot stimulate here due to some reasons. There's, for instance, damage by tumor or by previous surgery or accident, or there is also developmental challenge where the cochlear nucleus is not well developed. Then there is an option to go to the inferior colliculus in the midbrain, which is the next surgically accessible structure along the auditory pathway for placing an electrode. Now, for this device, we use the penetrating electrode. You see here electrode rings on that kind of shank. The insertion is limited by this Dacron piece, and you see how it's inserted into the cochlear nucleus, into the inferior colliculus, sorry, penetrating the different frequency layers, and each of the layers should be stimulated by one electrode ring. Now you see here how it's done. The exposure is also retrosigmoid approach. The tentorium is up here. It's sitting, a semi-sitting position. That is the cerebellum retracted downward, and then we can reach here the surface of the inferior colliculus, and then we can place here the electrode. This works in terms of surgery. We had no side effects, no migration of the electrode. And when we look on the hearing performance, again, we see that these patients have some auditory perception. For instance, vowel test, that is auditory only. This is the visual, the lip reading, and that's a combination of the two. So there is at least some advantage with the combination of both auditory and visual. The same is true for consonants, for numbers, as you can see, and also here for speech, we see there is a clear advantage using this implant. And when we look on the auditory brainstem implant on average, it's comparable. So that means it's a good alternative for patients in whom auditory brainstem implant fails or it's not possible. Then we can go and use the auditory midbrain implant. Okay, some references. Now we made also further progress with that project, going to double shank so that you stimulate more parts of the inferior colliculus. See here these double shank electrodes, and here an intraoperative photo where both shanks are then, so to say, placed into the inferior colliculus. You see here then some post-op, that is the sagittal image. You see here superior and inferior in colliculus. Here we have the cerebellum. That is the occipital lobe, that is the tentorium, and see now how these electrodes are here placed in the inferior colliculus. So in summary, we can say that auto rehabilitation with brainstem implant, auto brainstem implant is possible. We also see that it's the treatment of choice if cochlear implant is not possible. And we have also an additional option, which is the auto midbrain implant in cases with failed ABI or severe brainstem damage. I think that's basically what I can tell you about this subject. Thank you very much for your attention. I'm open for your questions.
Thank you, Thomas. I think it was an excellent summary of the entire spectrum of subtle prosthesis. You touched upon some very important points. I'm sure there are some questions for you, but you emphasize the need for a very long-term follow-up on these patients, and they do take a lot of time, and that's also been the experience from all of us. Unlike cochlear implants, you have to work with them for quite a few years, and certainly they need to have also the assistance of visual input as well. The question of electrode migration, I think, again, that's an important point that you brought up, because it's also been our experience, because the recess is so variable and the electrode size is constant. And there seems to be quite a possibility in some that the electrode size does not fit the recess. Recess is too big. I think that partly explains why some of them at least have a tendency for migration. One of the difficulties, I think, is that we are not actually visualizing the actual size of the recess, and it's quite a blind process of insertion. So, whether visualizing the recess with endoscopes, whether that might improve and with a choice of different size electrodes also, that would matter in the future. I'm not sure, but I think certainly you made the point that this is an important factor for consideration. Also, revision in these cases is quite a difficult experience, at least in our hands. Revising these electrodes and putting in a new electrode is always a very unpleasant experience. But we've done 3 revisions in children as well. All of them went off well, but you never look forward to this. Unlike in a cochlear implant, the revision in an ABI is not a small surgery. So that's been again a matter of concern. So overall, I think you said some very important issues you brought up, and also very interesting information about the auditory midbrain implants. I think that's something which is entirely an experience from your center. We all look forward to information about the midbrain implant with a lot of brainstem distortion, where an auditory brainstem implantation is not anatomically possible. So I think these are very, very interesting information that you gave us today. Thank you very much for that. Now, if there are any questions from the surgery hall, then I think.
Doctor, we have one question in the chat box.
Mohan, there is one question in the chat box asking who should lead the surgery, neurosurgeon or the ENT?
Okay. The question is, is it a neurosurgeon or an ENT? I think this keeps coming up all the time. Yes, Thomas, I think we would like to have your opinion on this.
Yeah, I think it depends on the case. If you, for instance, have children where we have no tumor resection, then probably it's done by us as ENT. If you have big tumors to be removed, then it's normally the collaboration with the neurosurgeon. I know that in other places, also in children, the surgery is done in collaboration between the neurosurgeon and the otosurgeon. Also, the approach can be different. I mean, some people use the more oto-surgical approach, or translabyrinthine, which has good advantage. And then others use retrosigmoid. I think it is a matter of experience and a matter of setting. And of course, we have to deal with some specific surgical issues in small children in the posterior fossa, and you always should have a neurosurgeon available in case you get some complications. I mean, again, bleeding and so on. But normally, we feel quite safe with a straightforward approach. I don't know, Mohan, how you do it, but I think that's how we handle it. So.
Yeah. I think the important word you used was collaboration. I think it has to be teamwork. Both the ENT and the neurosurgeons have to work together. And if you're working as a team, it doesn't really matter who's doing what. In India, at least, medical legally, it's important that you have a neurosurgeon in attendance when you're doing the surgery. Certainly, you need to work as a team. So I think the answer is that it's a collaborative work. It's a teamwork. Both have their role, very important role.
Yeah, I think that's important.
And of course, the audiologist, because intraoperative electrophysiology is again very important. As you heard from Thomas, very often our placement of electrode depends on the feedback we get from the audiologist. So, yeah, we need to have a very good audiology team, which is capable of doing it in a much more experienced than in a cochlear implant team. So, you need to have very good, reliable intraoperative electrically electrodes are auditory, which are non-auditory, so that placement can be point that the more electrodes are auditory, the better the outcomes eventually. So this is again a very important point that he made. So we need to rely on the audiology information quite a bit in proper. Very nice talk, Thomas. Really enjoyed it. I'm sure everybody's really benefited from this talk. Thank you once again for sparing your time. I know it's very valuable time. Thank you very much.
See you later. Thank you.
And thanks to the organizers for organizing this wonderful thing. Thank you so much. Thank you.
Thank you.
Thank you, Professor Thomas Lenard.
Over to you, Shankar.
Thank you. Thank you, Professor Thomas Lenard, for having accepted our invitation and spent a valuable time in your busy schedule and agreed to share your experiences on auditory brainstem implantation. And it was an excellent video demonstration and a good discussion. Thank you, Mohan, for conducting this session and putting in your inputs also on the topic. So we are coming to the end of this morning session of this unedited video session. So I'm sure after going through all these videos, we'll agree that this thought of showing that unedited video session instead of the live surgical sessions because of these COVID situations, I think we are enjoying as good as the live surgical sessions, all the videos, and there was a good interaction from the moderators as well as the speakers. So I thank all the faculty who have international faculty as well as the national faculty who agreed to moderate this session and conduct a wonderful program in the morning, in the beginning of this conference. Okay, thank you one and all. We will meet again at 2:15 post-lunch session, next keynote addresses, as well as some panel discussions and some invited talks. Okay, thank you very much for your attendance.
Doctor, you can start, Doctor.
Yeah. Good afternoon, everybody. I invite you for the afternoon session of the first day of the conference. So on behalf of the scientific committee and the organizing committee of CIGICON 2021 and the 6th World Congress on Cochlear Implantation in Emerging Countries, I welcome Dr. Thomas Lenaz for the second time today for giving his keynote address. The topic for the keynote address is Sustainable Concept for Cochlear Implantation in Upcoming Countries, Education, Training, Infrastructure, Clinical Practice, and Research. Okay, already Dr. Thomas Lenaz has been introduced in the morning by Dr. Mohan Kameshwaran when he showed his video on auditory brainstem implantation. Just to recapitulate for the people who have logged in now later, Professor Thomas Lenaz is a renowned expert in the field of otolaryngology and surgery of the head and neck, and he has built the department position as a global leader in cochlear implantation. Implantation in children, refinement of surgical techniques, and enhancement of products realized here have resulted in significant advances worldwide. The department's scientific work is supported by the Collaborative Research Center on Biomedical Engineering, funded by the German Research Association. Research outcomes are transformed into advances in modern auditory implants in close collaboration with manufacturers. He has around 620 research papers to his credit, with over 7,500 citations. So I'll present here Professor Dr. Thomas Lenaz for giving his keynote address. Over to you, Dr. Thomas Lenaz.
Thank you very much. Thank you very much for this kind introduction, Dr. Madikeri, and it's a great honor for me to give you this presentation from a perspective of a developed center that basically has a lot of collaboration with countries, with upcoming countries, and subsequent also developing programs in there. And I just have to, let me check, I have to go for my, so I have to open my presentation, sorry. So now, sorry, I have to line up my screen. So now I have it, and it should be. I hope you can see it now. So sorry. Okay. So the sustainable concept for cochlear implantation in upcoming countries. It's basically not very much different to what we have done in the past and what we do at present. And the main difference is that, of course, you have today a much higher impact of technology than it was in the beginning of cochlear implantation some decades ago. Now we know that we are facing a global epidemic problem with the increasing number of people who have hearing loss, and this prospect of WHO shows the estimated number of people worldwide that are affected today and will be affected tomorrow. So it will go up to something like 900 million people in 2050. There are many reasons for that. The one is a growing global population. The other is that we have a longer lifespan. And third is that perhaps we have more factors that influence hearing and induce hearing loss. Now, there's of course a global burden of disease, and the main thing is that this hearing loss is not only in adults, but also in children, and especially in developing countries, this burden is very high, whereas in more developed countries, this childhood prevalence is less. So we face this problem and we have to deal with it. And one thing is, of course, that we also have to give service to patients who have a complete hearing loss, so to say, they are deaf or they have severe and profound hearing loss. Now, when we look on the available solutions for hearing deficits and rehabilitation, it's clear that it's not only the cochlear implant, but we also have hearing aids and we have assistance systems. But from a certain point of hearing loss on, only cochlear implant will help. And the problem is, of course, how can this be provided to those who need it? How can we identify those? And how can we also really try to build up a reliable service that is not only the surgery, but that is also a lifelong, so to say, aftercare. And of course, that is what we have to keep in mind. Now, cochlear implants have shown to be a success story of neuroprosthesis. They're very efficient. They really help to restore hearing to a level that patients can really understand speech. And when we look on the history of cochlear implant, it is also a history of fast technology development. So you see, we have probably, in the meantime, 1 million recipients worldwide. We have in Germany implanted 55,000 patients, but you also see that we in Germany have 1 million candidates, and we are far away from giving all of them a cochlear implant. It's not for economic reasons, it's for other reasons, but it shows, of course, that there's a huge demand for this type of therapy, even in developed countries. Now, the main point is that the number of candidates did grow. And initially it was basically just to provide some contact with the world of sound. You see here one of the first patients in Melbourne. He did wear his speech processor here around his neck in a huge box. And somebody had to speak directly into the microphone in order that he could get some cues of speech for understanding. Now, over the decades since the 70s of the last millennium, then you see that speech discrimination in the majority of patients is possible with this. And today we are basically saying that speech discrimination is possible in all recipients, more or less. There still are some deficits, speech and noise and music perception, but the main goal that those who are recipients have open set speech understanding and children can develop near to normal speech and language is, of course, achievable with the current technology. So now we have different care models which are in place. We have care models in developed countries where we have increasing number of CI recipients with a need for lifelong aftercare. We see that this takes human resources at the center in a growing number. We also see that probably new patients coming in might not be served at the center, but we need satellite partners. And then we have a hub and spoke model. So that means that we can rely on several partners which are not geographically located at the implanting center, but which are, so to say, reachable by any kind of communication. And this hub and spoke model is something which has been developed and well set in countries like Germany, United Kingdom, in France, and also in the US. In emerging countries, probably this might be different. There is a lack of resources and services. The first is that probably no screening program for early detection exists. There is no audiological centers for diagnostics and hearing aid fitting, and centers for all of the people, and that there are only a few departments of otolaryngology with given surgical, technical, and audiological expertise for cochlear implantation. And then there is also no sustainable lifelong aftercare and service. So the question is, how can all that be provided so that you not only do the surgery, which might be nice, but there is afterwards no use of the implant due to this lack of expertise and service. Now, there's, of course, a ways out of that situation, and it's mainly through modern technology. One point is the so-called virtual hearing clinics, which basically gives us the possibility by using the mobile phone to do diagnostics, to do early detection and screening, but also in the aftercare to monitor the patient. The other point which is important is on surgical training and support system. So how can surgical training be provided in a sufficient number of people so that they really can then serve patients in their regional area? And after the surgery and it has healed, we need a kind of fitting of the device. Also, this is an important point, which probably can be done today through modern technology. And then we need the remote control on the device, on the hearing of the patient, and to also be able to identify technical as well as medical problems along with that. Now, it means that we need to organize affordable, efficient, and effective hearing solutions for everyone. And it comes back again to this mobile phone. The mobile communication has an arguably bigger impact on humankind in a shorter period of time than any other invention in human history. Statement of the World Bank report. And I think that's true. It's true because we can say that many people, even in developing countries and upcoming countries, have access to this technology, and they wear it with them every day. So this, of course, opens then the possibility for a so-called virtual hearing clinic and build up a kind of mHealth system, which really links those people in the existing healthcare system. Now, when we look on this kind of virtual hearing clinic, that is, of course, something which is existing or can be built up together with the true medical part of medicine, which means where we have physicians, where we have also nurses, where we have hospitals, where we have operating rooms, and we can call this then the kind of precision medicine, whereas this one, the mHealth, is kind of the virtual medicine, which is directly accessible by the patient. Here, this is relying on infrastructures and given experts, which might be available or have to be built up over some period. Now let's go to this virtual hearing clinic. The goal is that mHealth empowers people to deal with their hearing impairment using IT-based support systems. And that's something what can be done through the mobile phone. So these IT-based diagnostics and rehabilitation, of course, are relying on the data that have been collected, and they gave the backbone of any kind of diagnostic procedure on decision-making and also on individualized therapy. So there are many points in it. We collect a lot of data from a lot of patients with hearing impairment. This gives us a large clinical and field database, and through some machine learning algorithms, and we can go to data classification and then also use the data of the individual patient. He, for instance, makes his own hearing test through the iPhone, through the mobile phone. These data are then brought into this database, and then the individual patient can be diagnosed as, for instance, having this degree and type of hearing loss. And then also, of course, this type of treatment shall be selected. So first of all, on the outcome prediction, that means that we have aided performance prediction using speech recognition systems, for instance. So it's possible that we can make with this kind of iPhone-based systems a prediction about what is the hearing of the patient, but also what would be the impact of any kind of therapy on his hearing situation. And this large relational database that has to be built up. That is one requirement you have, for instance, in your country. You can also rely on other databases from other countries, but in principle, it would make sense that you pool clinical data you have from all over the country of your patients, bring it in, and then with the help of artificial intelligence, you can then really go for this kind of categorization of clinical data, did similar to what a medical doctor would do. And then the system tells you exactly what the individual patient has. And then, of course, we can go for some personalized treatment, like hearing aids and individualized cochlear implant, for instance, fitting. All this is possible based on this kind of virtual hearing clinic. Now, second point is that we need experts, and experts have to be trained. They need, of course, some theoretical background. They need some possibility to get information on, for instance, hearing implants, on cochlear implants. And one thing is, of course, such a series of talks, of seminars that are provided. That's just one example from Hanover. In collaboration with Medal Company, you see that you basically have a series of lectures and webinars. This gives you kind of up-to-date information, but also on introduction to different topics. And this, of course, is important for experts or those who want to become experts, such as surgeons, such as audiologists, such as also speech and hearing therapists, in order to stay connected with what the state of the art is. Then the other one is surgical training. Most important, because you need well-trained surgeons who are able to do the surgery, but also they can deal with some difficult situations. And the question is how to do it. One possibility is, for instance, to go for CI training academy, so that you can either by direct visit or by web-based attendance go and have training on live surgery cases, but also on temporal bone dissection, which can be also done through the web. So that is possible not only in person, personal meetings, but also through the web. The other is the fellowship, which is more intense, but is limited in a number of people that really can do that. It means that you have to go out of your country, go to a center where you have all the possibilities. And then this fellowship will give you some intense training, including doing your surgery yourself. Now, building CI centers means that once you go back, then you have to build up your center. You need instruction by experts, those who can come to you and help you in setting up everything, but also during the first surgeries. And in the future, it could be done supervision by telemedicine, so that you really link your surgery with the expert, and he gives you then advice on an individual case. That's called teleconsulting. And then we have refresher by academy, what I already showed. And then there is also the library on surgical training material, so that you really can look through different cases which are, so to say, available as videos for your instruction. And then, of course, the registry of cases where you collect cases from different centers, and then you can learn from each other. Now, surgical training, of course, is something which means that you also can go through different modules, such as pre-operative, operative, post-operative. And here you see a list of different seminars we do together with this masterclass of cochlear implantation, an initiative by Dr. Fatih Baki and supported also by the cochlear implant companies. and just to see here what we do, different aspects in different topics, something which can be a backbone. Now let's go to surgery. I think it's important that you follow a certain given standard which is doable everywhere. And this means that, of course, you just follow certain rules which have been established and have proven to be safe and reliable. And it means that you need, of course, also a standard set of instruments. It must not be a huge amount of, but it's just something which you always have available in all your cases. And just to show you a few steps, I think how that approach could be. It's very simple with the retroauricular incision. We go for building different flaps so that we can basically have different layers, periosteal layer. Then we can, so to say, also make the pocket for the placement of the implant. As you can see here with the dummy, we also make our drill out of the mastoid in a standardized fashion in all patients, in all ages. There's no difference between adults and then children. And we also go for securing the implant with a bone bed that doesn't move, that is to prevent long-term complications. There are special hooks, for instance. Very simple suction hook helps you during the surgery. And then we can make a tunnel or channel for the electrode itself. You see here how it's made. Then we can, so to say, place the implant safely here, and it will be recessed. There is no movement. There is no risk of exposure to some skin problems. Posterior tympanotomy, also we have to follow certain surgical guidelines. The most difficult part, perhaps, of surgical training, but this is also teachable and doable if you follow just some guidelines where skeletonizing posterior wall, you identify semicircular canal, the incus, and then you can follow the facial nerve down to the mastoid tip, and then go also into the space between posterior wall and the facial nerve into the middle ear. And then, of course, you can expose around window membrane also with drill so that you see the membrane, then you can open it, and then you can insert the electrode in a safe manner. And we also do here kind of bone trough, you see here, in which we can fix the electrode later on so that it doesn't move. I just want to mention it because it's important that we do this surgery for a lifetime. And we should do the surgery so that we avoid complications as much as possible in order to give the patient this kind of reliable basis for his hearing rehabilitation. And then, of course, we also can go then for the removal of bony overhang, exposure of the round window. Also important that we avoid any misplacement. You see the posterior tympanotomy is widely made in order to get good overview, in order to be able to identify the structure of the round window niche, and then remove the bone sufficiently so that we then can really identify the round window. This is important, that the electrode goes really into the scalar tympani and not in the hypotympanum or somewhere else. So it's basically the surgical technique that must be subtle and reliable. And see here again what I said, that we can expose it. Then implant testing, also very simply done. It's just that you check before put in whether the implant is working. Then we place it, as I said, position of implant. Then here position of it, and then we insert the electrode in a safe manner through the round window membrane into the different devices. Different electrodes need different subtle technique with advanced off-stylet or just lateral wall electrodes that go straight in. And here you see a kind of insertion with a lateral wall electrode. We do it through the round window membrane. You see here it's done very, very carefully. Advance it to the given insertion step here. Another example in the other video, and we just want to do it as safely and atraumatic as possible. Also, that's all in the hands of the surgeon. There is basically the scrub nurse in assisting you. Here you see the fixation of what I mentioned of this electrode, that it doesn't move. Again, and then we secure the electrode here in the mastoid. It does not pop out. Also important. You see here how that is then done basically with the electrode in the mastoid, so that we can really then position it. You see here overhang of mastoid prevents any contact of electrode with overhanging skin. So something that is also important to avoid then complications on a long term. And here you see again how the electrode is nicely fixed and cannot move in anything. Then testing of implant, again, once it's in, it's also doable by either an audiologist or by the surgeon himself. The current systems allow that, and simple to measure function of the implant, impedances, and also the nerve response from electrical stimulation, as is shown here. So we activate the implant with the device for testing, and then we can see whether the nerve is responding. Something very important also to check on the appropriate position of the implant itself. Okay, now to aftercare. I think it's important that it's provided to the patient, and one possibility is again given through telemedicine with remote care. So you have implanted the patient, he goes home a long distance away. Question is, how can we really communicate with him? And well, there is remote care. That's something that is doable through the systems today, just by telecommunication connection, and the patient can link to your center, and then you can have direct access to his speech processor, and then you can, for instance, make some fitting adjustment. So I think that is one thing important. And then there's another aspect which has come up lately, that is the self-fitting of cochlear implants. So the patient himself, in a certain manner, can program or change the program of his implant, and with this can, so to say, improve the fitting and adjustment to the hearing situations he is in. So something which, of course, can be combined with the remote care and gives you access to the patient everywhere, and he himself also can, of course, then test himself how is his hearing, can test his implant, and also this data are then transferred to the expert center. Well, that's basically what I think would be comprehensive in terms of service for patients who need a cochlear implant, undergo this surgery, and also get then the aftercare, all based on current developments in telecommunication, using the mobile phone as the heart piece of this kind of care concept. Thank you much for your attention.
Thank you very much, Professor Thomas Leonard, for a very elucidative lecture, keynote address on this subject. So we wholeheartedly thank you once again on behalf of the scientific committee and the organizing committee of CIGICON 2021 and the 6th World Congress on Cochlear Implantation in Emerging Countries for taking over time from your busy schedule and agreeing and giving both the live surgical demonstrations as well as the. Thank you very much. Because it's a keynote address, there are no questions in this. Thank you, sir.
Thank you much again for this kind invitation. I hope that we can see in person or meet in person soon again.
Definitely.
The COVID situation currently has worsened in our country. Unfortunately, we have very high numbers now of new infections. And it's probably so that we are facing probably a new lockdown within the next 1 or 2 weeks. And therefore, it's very difficult to travel for me. Unfortunately, otherwise I would have gone and come to India. But I hope that we can do it very soon again. Thank you much.
Yes, Dr. Leonard. I think last we met in Tokyo conference. And if you remember, long back, I visited your center also and spent 3 days.
Yes, yes.
After the Vienna conference, actually.
Yes, yeah. Okay, I know, I remember, yeah. Okay,
yeah.
So all the best to you and looking forward. Thank you much.
Yeah, thank you. Thank you once again. Yeah. Now we are moving to the next integrated panel discussion, going to be on sustainability and cochlear implants, need for policy making. So now I request Dr. Nishita Mohandas, the Secretary of our Cochlear Implant Group of India, to introduce Dr. Kalyani Manke, who is going to take over this panel discussion. Thank you.
Hello, good afternoon to everybody. This is an integrated session on sustainability and cochlear implants, need for policy making in upcoming countries. Sustainability and cochlear implant, need for policy making by Dr. Kalyani Manke. It gives me great pride and pleasure to introduce Dr. Manke. She's our premier audiologist from Pune, India. That is my state, Maharashtra. She has done her PhD in AODCCC in USA. She has 40 years of rich clinical experience. She has been a former president of the Indian Speech and Hearing Association, as also the Cochlear Implant Group of India. She has represented in various committees of ASHA since 2008, received different awards 13 times, many publications in national and international journals, has done a lot of work at national and international levels. She's a voracious reader, a very fast learner, and adapts to any situation given to her. I welcome you, Dr. Manke. Over to you.
Thank you, Nishita. Thank you, the organizers, for giving me this opportunity. This is a kind of a Herculean task for me, a person who is not connected with any government service at all at any time. And I'm talking about policies and all. So anyway, it's a challenge. So first thing is, like, I would like to introduce all our panelists. Can I have a slide, please? Yeah. Okay, happy to introduce Lieutenant General Retired Dr. M.D. Venkatesh. His special interest is pediatrics, cochlear implant, and occupational hearing loss. He's an excellent blend of academia and administration, and his current position is Vice Chancellor of Manipal Academy of Higher Education. Next one, please. Dr. Alok Thakkar, strong academic person, Professor of Otolaryngology and Head Neck Surgery at AIIMS, New Delhi. He has 284 publications and 111 international publications. Wow. I really admire Dr. Thakkar. Next speaker is Dr. Deepak Dalmia, people's person. I really very honestly feel that he relates to people a lot. You know, he's head of the department, ENT department at Dr. Babasaheb Ambedkar Memorial, Central Railway Zonal Hospital, Mumbai. Dr. Dalmia has served as mentor surgeon for many people, many centers. He has publications national and international level, given 60 plus platform presentations. He's a recipient of R.F. Cooper Award and National Railway Minister Award. Next one, please. Dr. Asha Yatiraj, Professor, 30 years of rich teaching and research experience. She's a hardcore researcher. Entire fraternity, SLP fraternity, is scared of her because she can ask any question anytime. The reason is she's a fast thinker and she's a very analytical person. She sees every problem in a different kaleidoscope way as such. She has received best 12 awards for best paper awards, 150 publications on her name. And she has served as president of Indian Speech and Hearing Association and president of Mysuru chapter Isha. Welcome, Asha. Next one, please. Dr. Sunni Matthew, director of AYZ NIH, young dynamic director. Her area of specialization is oral rehabilitation and inclusive education. Dr. Sunni Matthew is member of various academic committees of ministry and Central University. Recently, Governor of Maharashtra has given appreciation award as a COVID warrior, recognizing AYZ NIH services offered to PWDs during this COVID-19 pandemic. She's really busy person, and last minute she had to attend one important meeting. So she has delegated this work to Dr. Aparna Nandurkar. Dr. Aparna, welcome. Next slide, please. Yeah. In a way, thank you so much, because of very short notice you agreed to work on this panel. But probably, this is something you are with ADIP scheme, you drink, see ADIP scheme, sleep with it, and you know all this thing. You really have understood the pulse of ADIP recipients, families, and challenges. And your motto is to reach out to the unreached. Wonderful. Aparna has 30 years of clinical and teaching experience. Welcome, Aparna.
Thank you.
Friends, just give me a little time because my slides need to be on. And can you allow me to share the screen, please?
Yes, Dr. I can.
Done. Yeah, got it. Okay, so sustainability and cochlear implants need for policy making. I always keep saying in a common language, once somebody got the implant is like married to cochlear implant company, married to the center where you are giving the services. And so we need to walk together. And this is something, a lifelong commitment. And we all have been experiencing a lot of challenges with these sustainability issues. Of course, we are all learners, but now CI programs in the country have been almost 20 years, it's decade, so we are in adulthood. So now we really need to think.
Can you hear me, madam?
Yeah, sorry, yeah.
We do hear you, Dr. Venkatesh.
Any problem? Yeah, am I having?
Yes, Dr. Venkatesh, sir, we can hear you.
Just Dr. Venkatesh, just allow me just 2 more slides, please, and I'll start discussion immediately. Yeah. So what do we mean by sustainability? United Nations has defined 17 sustainable goals. We are all aware about it. And these are interlinked sort of, it has created a blueprint to achieve a better and more sustainable future for all. So these sustainable development goals were defined in 2015, and they're sort of, we need to attain and achieve the desired results or do our job by 2013. And these are all 17 goals. Of course, we are not connected with all, but our important things are, good health and well-being, quality education, and gender equality. This is something we really have to think on these lines. And the tagline is something is, really very important. Leave no one behind. This is a central transformation promise for 2030 agenda. And we are committed to this.
Ma'am, your slides are not visible.
A unique. Sorry?
Your slides are not. No.
I'm sorry, these are not visible.
No, doctor.
Sorry.
Yeah, now it's visible.
Okay, I'm sorry. Okay, so just I'll catch up a little. These are the sustainable goals. We are aware about it. These are the 3 where our focus is, that is good health, well-being, quality education, gender equality. And this is something is very important, is leave no one behind. That is something we really have to think about it. And then sort of, our program goes with that. So how do we see cochlear implant program in the light of leave no one behind? That's how we are going to discuss all these issues. And now I'll start with my questions. Okay, so I would ask Dr. Alok Thakkar that earlier when government program schemes were unavailable, focus was on fundraising, and you have started program much earlier. So can you just throw some light on this, please?
Yes, it was a very different time, but I think the change related not so much to governments becoming available now. It just relates also to implants in general becoming so much more cheaper now in relative terms. I mean, 25 years ago, 600,000 was a lot of money beyond the reach of most middle class people, and certainly now it's just that implants per se is cheaper because of economic progress. But yes, focus has changed. Everything has changed. That was a situation when then there were very few centers too. There were hardly any centers, and we were just about able to actually manage to cater to the small population who could afford implants. Today, there are more implants. There's more funding support. In general, the country's made progress. So of course, the government can now fund so many more implants, and I think that's how things will move for the future too.
Thank you. Dr. Venkatesh, your comment, please.
Yeah. Thank you very much, ma'am, and good afternoon to everybody. For all my part of my cochlear implant program association, it was with the armed forces. And we began our program as early as 1997, as Dr. Alok has said, towards almost around the same time. And in fact, it was fundraising was not so different from a government setup vis-a-vis the philanthropy at that stage also. In fact, we had to fight with the government, convince them, case-to-case basis. We used to apply for, implant, and the applications, rather the statement of case would take time, by which time the implant materialized, the child would have grown and things like that. So there was a major issue. Firstly, issue was about the acceptability of cochlear implant as a solution. In fact, our own fraternity did not believe that this was a good solution. Everybody thought that, it's a fancy thing, being promoted and propagated by a few people and things like that. It took time for all of us to convince you, ma'am, you are aware we were together in Pune at that particular time. And it was very difficult to convince people that it works. And when it works, and also the progress was measured in years, not especially in the pediatric implantation. The outcomes were looked at or were seen only after at least 2 years to 3 years. Therefore, in that interim period, fight for every single implant was an issue. But without that, over a period of time, I think much of it was perseverance and the belief that, yes, it works and we need to promote it. And a small group of people at that time, I remember all of us used to be so close-knit, and we used to share information, share our progress with each other in such a intimate manner that together it gave us a lot of strength to promote cochlear implantation in that early part. 25 years ago was quite a time back. But then with perseverance, and when we were able to establish that, yes, it works, and showcase the outcomes after implantation, things became a bit easier. For us in the armed forces, it was slightly easier because we were able to get some funding and some annual numbers were earmarked. And as we established, today we have 6 centers which are performing reasonable number of implants over every year. So initially, yes, first decade was a big struggle. I think most weak-hearted would have given up and settled for our otologic practice. But then the belief that yes, it works and it makes a difference to young children and it makes a difference to the society pushed us. And today I'm reasonably satisfied the way things are. And all of us, many of us, most of us, we worked hard with the government, pushing them up for social schemes to support cochlear implantation. Philanthropy even today is not easy to get. You are aware, we are aware. And that it's very, very difficult to get consistent philanthropic support for fundraising. So yes, things have changed, as Dr. Alok has said, and we are in a better situation than what we were a few years ago.
So this was a historical thing. Now the EDIP scheme, RBSK and state government schemes are in place. So how is the life sort of? So I would like to ask Dr. Asha. She has a good experience about Southern India's, how things moved. So can you throw some light on this, please, Dr. Asha?
Thank you, Kalyani. I think the EDIP scheme and these government schemes have made a world of difference to our clients. There are people who couldn't have even dreamt that their child can communicate and can do well as somebody else who could afford it. They are aware that there is a lot of money being put in over there. And these are people with very minimal facilities, education, yet they are doing so well with their children. So we have people who are even plucking coconut for life, and their child is now communicating over there. I think it is a great thing that the government has done to help out our people who cannot afford it.
No, yeah, thank you. Dr. Deepak Dalmia, please.
Yeah, just I want to add one more thing, madam, that because of these schemes, now the cochlear implant is reaching in almost all cities of the India. Otherwise, before these schemes, it was restricted to few cities or metros. Now, because of these, this is the strength of these programs. But the weakness I feel is the awareness still is not up to that point which is required, that these programs are running. The awareness is still a little bit on the weaker side. And the other thing is, because of these below poverty line conditions, the poor people, they are getting, no doubt, they are getting too much of benefit with these schemes. But on the other hand, they are becoming non-users also. These are weaker points of these schemes.
We will come to that, yeah. Yes, yeah. So, but now at least we are reaching out to the unreached. That's more important than anything else. So now the sustainability is not just for the government side or the funding agency as such, you know, how far we can sell through. It is at the beneficiaries level also we need to think about it, you know, how the families can cope up with it, how they are sort of, because the recurring cost of the cochlear implant or the maintenance cost is very high. And we have to accept at this stage, right and wrong is different thing. But the way it is, the model, how it's working, it's an expensive affair. So how is the sustainability at the family level? Asha, I would like to ask you this question, please.
I have multiple points I would just like to elaborate, saying, yes, it has got a lot of issues over here. Our experience is that we have a lot of our places who come from neighboring towns, neighboring villages, and they're not willing to shift into where our centers are. So they want to travel from their hometown. So that's sometimes traveling 4 hours per day. So by the time the child comes in for training or comes in for mapping, the child is exhausted, the parents are exhausted. So the outcomes are obviously going to be less for such a family over there. And initially, yes, the entire family is supportive. But this is not something that gets done in maybe 1 month or maybe less than a month. So after maybe a few months, the support just goes away. The father starts getting restless. They want the wife to come back over there. So they are happy with just a minimal amount of improvement that is seen. And they say, this is enough. My child has started to talk. I said, your child can talk so much better. Stay back. But they don't want that to happen. They would rather that they're just content with this marginal improvement that is being made. But the biggest challenge is paying for repairs and spares. None of the government schemes are paying for that. They're not paying necessarily always for them, their accommodation or wage loss. They do talk about it, and I think the RBSK does talk about it, but it is not being given, as far as I know, to the patients. So that's one of the reasons why the families are not willing to shift into an area where they have to actually look after 2 different households. So that makes it really tough for this entire program to be sustainable. I think if all these also have to be looked in, giving funds for not just the device, for repair and other things also.
Dr. Thakkar, what do you think about, you know, from 2 years of age, the child is implanted, by the age of sort of 25, 30, what will be the total cost involved for that family? So it upgrades, repairs, you know, I'm not talking about explantation at all, you know, nowhere. We trust the product is good. It's fit for life. Okay. But the externals are not fit for life. So we have to really think on that.
Well, even for the product, they take a warranty for 10 years. And I'm not so sure how it's going to be when we have implants which have been in for 30 years, 35 years. I mean, the West has computed these costs. There's a recent paper from France, I think, which sort of said that the lifetime cost for a cochlear implantation, adult implantation, is 53,000 euros. So it is a fair amount of money for a lifetime cost. Yes, it is certainly an affordable thing for a section of our society, and I can well understand certainly cost effective too. But there are challenges. In our situation, I'm not so sure what the cost is. So it would probably be 1/4 of this or maybe 1/3 of this. But yes, the costs are significant.
Yeah. So that is a real challenge. We're really looking at it. So let's see what's the EDIP scheme has been doing. So Aparna, I would request you just to give you the just an overview about the EDIP scheme, means what you do and how you take care of post-surgery, under EDIP.
Yeah. So EDIP scheme was started in, EDIP scheme started in December 2014. And for under the scheme, total amount of 6 lakhs is allotted per beneficiary. And in this 6 lakh rupees, what is covered is the cost of the implant, the cost of the surgery, the cost of mapping for a period of 3 years, and the cost of post-operative habilitation or therapy for a period of 2 years. And what we have also done over the years, so when it began, we did not have like any differences from what happened with a non-EDIP case in terms of the kit contents or even in terms of the warranty. But over the period, like since 2 years back, we are providing extended warranty for the external processor, that is by 2 years. So total warranty of 5 years for the EDIP recipient. Other than that, in the kit, we are providing slightly more accessories like coil cables. In a general kit, the company provides 2 coil cables, but we are providing 3 coil cables. Plus magnet is only 1 in a general kit, but for an EDIP recipient, we are providing 2 magnets. And also since the last 2 years, we have also started providing 1 additional rechargeable battery. So in a non-EDIP kit, there are 2 rechargeable battery modules which are provided by the company. So now we are providing 1 additional one. Other than that, we are also providing more number of disposable batteries. So disposable batteries which are going to last them almost for 1 year, that kind of stock is provided.
Oh, that's good. So you are really taking good care of them for almost for 5 years. So yeah, but it's something like family should be made aware about it. Start in putting open a recurring deposit account sort of. I always tell all the families that because the maintenance cost is high, so whatever, whether you put 2,000 per month, 5,000 per month or something, but open a recurring deposit account so you will have some funds ready, because they have to bear in mind that at one point something they have to shell out this money for a maintenance cost as such. So we will go further on the search, whether this, because most of these are below poverty line people, and you just cannot say to them that, we have helped you for 5 years now, it's your responsibility. So somewhere it's a commitment from our side also. We need to think about how best we can think of these people. Now, when we talked about the families, there are challenges to run a center also, to clinic, the manpower as such. So what are the challenges there? Dr. Venkatesh, would you like to say something on that?
Yes, ma'am. The challenges to run the centers and clinics is definitely are there. Firstly, it requires a very, very dedicated and committed team. I think that's the most critical aspect of, you have to have the surgeon, the audiologist, the habilitationist who work like absolute team, and the support services to go with it for evaluation and for various other hospitalization and other things. That is one. Second is, as I said, major challenge is a good productive team. And also it needs substantial investment for establishing a state-of-the-art center for cochlear implantation. And all of us are aware who are been doing cochlear implantation or in the field of cochlear implantation that it is not a profit earning venture in any which way. So it is more of it is because of commitment, more of it is a belief that we need to do something good for our children with the special ability or inability to hear. So that is very important. Third important aspect which I'm coming to, which I would like to stress, is as we see the number of implant centers growing, as Dr. Dalmia brought out, that even the tier 2 cities are now having implant centers. The quality of implant professionals which are available to offer the services, that is something little which is troubling me. So there is training and certification is something that we need to look at. How are we going to do it? How are we going to sustain an implant program? It is not about giving the implant. It is about providing the right kind of professional to support the the implantation program. And much of the implant centers are, urban, in urban location. So that it's a divide is showing up big time with the social schemes coming up with the government of India and state government supporting cochlear implantation. What Madam Asha brought out is absolutely very right, that people from a hinterland or a rural area, either they'll have to relocate to the centers where the place where the centers are located, or they'll have to keep traveling here and there. And much of it is a real big problem. And morally, sometimes the center becomes responsible for taking care of such people who cannot afford the support system. That neither the IDIP scheme nor the social schemes are, addressing these issues. Therefore, to me, three major centers: one, a committed team; second is a very good trained team. As I see, more and more professionals will be required to run the services. And fourth is about the integration of these children into mainstream. I am only talking about pediatric implantation. I'm not going to speak about adult cochlear implantation, especially in our country. How are we going to mainstream them? So our schools, are they equipped enough to take on this? So there is a need for the centers and the schools also to interact with the teachers, to tell them about the special needs of these implanted children till they become wholly, integrated. Therefore, the problems are many, but then but we are also seeing a substantial growth of the number of centers who are doing cochlear implantation, and also the newer models of implantations are coming up. That means, shared resources and support services being at a different location than from where the implantation has been done. And more than anything else, I think we are all aware that if there is a relocation of this child to another center, how do these the new place adapt to the requirements of the child? There are many problems. Often there are no documentation is incomplete. When somebody reaches to, say, my center from Dr. Alok Thakur centers, unless there is a proper documentation, he comes and meets us, and then the habilitation can go on simultaneously. But there are definite issues, and only, I think, fully committed teams and fully committed centers can flourish. This is something that is of my view. Otherwise, the non-users will become more as we go forward.
Yeah, I differ here on 2 points. One thing is the full commitment or dedication and all this. These are very textbook terms. Pardon me saying that now, but the India is changing. The mindset of people is changing. So, to expect that giving wholehearted service to mankind and all, these are now gone those days. So people see things differently. But there is another point I would like to stress on that. Medical schools are not made aware about the rehabilitation model. Okay, the entire program, medical school program. See, we speech and hearing people or paramedics or all, we are geared up with the thought process of, of rehabilitation or to adjustment with whatever things you have as such. Versus medical model is fixing up the problem. There is a problem, there is a cure kind of thing. And from there, they want to change over their thought process. So I think even ENT fraternity needs to be upgraded. What is the process of rehabilitation? How it is a long-term commitment? Maybe just say CI is not just one-time thing as such. From surgeon's point of view, identification of the case, they are doing the definite, whatever the prerequisites of the pre-operative work, surgery is done and done kind of thing. But how do we have a dialogue with the team members? How do we see with them? How do we counsel the families? That is also equally important. So the mindset of everybody needs to be changed. So without that, this, the dedication that's so-called, that we have to walk with the cochlear implant cases lifelong. Is going to be very challenging. And that with that, when we talk about it, another patriotic theme is coming, when Make in India. And that movement is really creating a lot of challenges also. So I just want to ask, how it has affected you. Dr. Dalmia, can you throw light on this?
Yes, I want to add something in the clinic, what the challenges clinics are facing, because I spoke with so many doctor friends, and I asked them, what are the problems you are facing? They said one of the problem is certification, means many certificates are required. and that delays the procedure. And the certification, we have to do timely certification is one of the points they said. Even they said in the private clinics, they are not getting timely payment. So that because of the so many expenses are there, and sometimes suppose they are working on 10 patients, and out of 10 patients, they do the imaging and all these things. And after doing the imaging, the 5 patients disqualified because of the cochleovestibular malformation or any other regions. So they already spent on 5 patients and they will not get any money. So if timely treatment they will get. That is the important point, and the certification process, if it becomes faster, that will be helpful.
That's very true. Very important point. You have brought it into it, because reimbursement, people expect something when we are giving the service. The money should be reimbursed timely, because you just cannot expect that go on doing the thing. And especially about the radiological cases being rejected on the radiological finding, that needs to be discussed also. I strongly feel, just cochlear anomaly should not be the criteria for rejection, because these children will never benefit from the hearing aid. And then we are depriving them more than what we could have done. So actually some modifications are required. Some expert committee can be sort of decided. Yeah, and then something. Asha, can you just want to add on?
I just wanted to also add on saying EDIP has this cutoff of those who get who have incomes of more than 20,000. I don't think even an average family can afford it. 6 lakhs, 10 lakhs is a lot of money, even for a person like me who's earning fairly okay. So I think that that's also something that do away with it. Don't have this income bracket. Keep only the criteria over there. If they want something fancier, let them go elsewhere. But I think EDIP is doing a great job giving the basic over there, and a lot of them who can't afford it should be able to take it. It shouldn't be the same criteria as what you're giving for a hearing aid. The income criteria.
Yeah. Dr. Dalmia, you had some hurdle about Make in India thing. Do you would like to share your experience about it?
Yes, very sad for us, because in the railways, I'm in railways, and in the railways, they are implementing this policy strictly, and they are not giving us implants since last 1.5 years. I am getting implants through various CSR schemes. Now I approach many companies through our seniors and with our organization help, and I started getting implants through the CSR, but railway is not giving us, because they say no company is fulfilling that minimum 20% criteria. So this we have to think, and we have to represent, I think, through our forum to the Indian government, that they must think over this policy.
Yeah, Dr. Thakkar, you want to add something on this? Have you come across this? The hurdle about Make in India implant should be the mandatory thing?
It is coming through for a lot of things, but not for implants. No, we are getting our implants, the government can be rigid to work through. Government can be rigid to work through, no doubt about it.
Yeah, okay.
Even for the cancer drugs also, madam, everywhere, even for the instruments, everywhere this Make in India policy for hearing aids, everything.
Yeah, it's applicable to all. I'm not saying no to it, but so the whole thing is, some exceptions should be made also.
But it's making a difference from the point of view that companies are also coming around to investing and making part of their production things in India. So yes, there would be, all said and done, it is making a difference. There would be exceptions, and I can understand that implants may be an exception that need to come out.
Currently,
you have to balance it from their point of view.
Actually, some may not like this, but actually what I feel like they did the capping in the stands and the knee and joint replacement, something like may be done, but we must get these implants.
Aparna, do you have anything to opine on this Make in India? Is EDIP had any policy change on something on this?
No, so far we haven't had any kind of communication from the ministry. Anyway, for EDIP scheme, the procuring agency is Alimco. artificial limbs manufacturing company based in Kanpur. So Aliyavar Jung National Institute is not directly involved in procuring, though we are involved to a great extent in forming the technical specifications and everything. So till now, we have not had any formal communication either from the ministry or Alimco that Make in India is going to be implemented or is going to affect our procurement of implants.
Okay, thank you. So the next question is, we talked about this mind support, how easy and hard it has been. So Dr. Thakkar, would you like to say something on this? Or what is it sort of, at all India level, not just your institute, but...
Well, from the all India level, I would say that the ADIP scheme's focus on reimbursing rehab rather than just the implant has made a huge difference and will continue to make a difference. Because what will happen is that, of course, when there is money around, then there will be professionals who will come up to fill up that position. So in economic terms, we are filling up that position. It is much better than it was. But yes, we all know that the Achilles heel on our cochlear implant service is not quite the implantation, but the rehab. And it hinges on appropriate personnel and on a lot of social factors. So certainly social factors where patients don't avail of the services that are provided to them because of the difficulties that Dr. Yatiraj sort of brought up anyway. So rehab is the issue, is the next step that we have to improve on. It is changing. We have way to go.
Yeah. Asha, now since you are sort of seen both the world, private sector as well as government sector. So how hard it is sort of for manpower? Because when you were at the national level, your huge network versus and how those gaps were filled in. Can you throw lights on something on that?
Definitely in a private sector, I think the manpower is so much lesser. We don't have the kind of funding that a government institute has over there. I'm not putting down the organization I'm working for currently. They have brilliant work, but there is no comparison between what the government can afford to give in versus what a private institution can have. So for instance, like I could have exclusive equipment only for my CI unit, whereas I have to share my equipment with the other units over there in the institute. And all of us are doing multiple work over there in the private institution. Not that we weren't doing other things, but there were enough manpower for us to be doing exclusive work over here. But here now, everybody is doing everything. And so I find the focus is relatively less. And obviously, I'm not able to give the kind of time that I could earlier on rehabilitation. So I think there should be somewhere facilities being made saying these people should be exclusively doing only rehabilitation work over there. Like it has been mentioned again and again. I'm sorry.
The manpower requirement will be so huge. So
it would be huge. No, but I'm not talking about, I'm saying somebody is exclusively only to train students about rehabilitation. They are doing multiple different tasks. So if you say no, do diagnostics, mapping, and rehabilitation, they're all choosing to do the diagnostic and the mapping.
Easy.
This is the hard work. They don't want to do the hard work.
Yeah.
I want to add one more thing, madam. Even for the pre-operative workup, if we want to do the audiological evaluation of a child, then it is too time consuming. In a government setup, still the waiting period is so long. So these manpower issues are always there and everywhere, I think, even the government setup also.
Yeah, everywhere. Okay, so we have been saying, all the complaints about it, but the schemes are moving on. So we have to really see, we have to do the reflection, how good we have performed, how well it is moving. There is no point just criticizing everything. This is not there, this is not there. Connecting dots is equally important. So Dr. Thakkar, how do you grade your scheme's outcome? Whatever 10, 20 years things are going on at AIMS. So how do you grade that?
So sorry, I missed out a bit. So you're asking me the changes, or I am a firm believer that
outcomes of your scheme, whatever you are implementing the scheme at your institute, how do you grade it? Level 1, level 2, level 3, or do you give 10 on 10? Or
no, we don't give 10 on 10 because of our waiting list. You see, everybody has different limitations. Our limitations is too many patients. Our patients wait longer than they should. Frankly, we weren't too keen on the ADIP scheme because we already had more patients than we could handle. So everybody has different issues, and our basic issue is we have our waiting lists are too long, and we really struggle to get
I'm
to
talking about the
operate on a
outcomes.
patient within 5 months of presentation.
But basically the outcomes, whatever the beneficiaries, CI beneficiaries are there, how are they doing overall?
So of course, this is a very varied issue because there are patients who are greater than or in the edge of the 4, 5 year, 6 year age group window by the time they come to for implantation. But nevertheless, we did publish our results a couple of years ago, and our average score for the CAP score is in the region of 6.5, 7 kind of place. So I can't say that we should not be doing better. We should be doing better. Our issues come primarily again from the rehab issue, where we can't quite rehab our patients because they are unable to stay in the city for follow-up. There's a huge cost involved in staying in this city for follow-up. And yes, we are working at teletherapy, which we sort of try to do for these patients. But when we looked at our results, the reasons we were failing were primarily because of distance from the center, inability to come for follow-up. Of course, poor social indicators, that is where we are failing.
Okay, Dr. Venkatesh, your experience is little 2 decades backward as such, but at the same time, it was working more systematically at that time. Probably you had more minimal 6, 7 centers or something, but 1, 2, 3, 4, checking the boxes was probably more systematic or something. So how do you grade how that got evolved? Because the way now defense services or the coverage is, the number is also huge. Beneficiaries are more, them migrating from one place to other. So how do you see all that?
I think if you say that, over 25 years, how has the Armed Forces implant program has progressed, I'm extremely happy. It was an outcome of a lot of hard work from many people. And more importantly, as you correctly said, we went ahead in a far more systematic fashion, bringing in policy changes at the right time, bringing in standard operating procedures at the same time, and also interoperability that you correctly mentioned, our documentation and one center to another movement of the patients for habilitation was better. And we believed in total habilitation. That means we had everything happening at the same center, from surgery to audiology to therapy, and later integration to school. And I think it was overall, if you ask me, how would I rate the Armed Forces implant program, I would rate it, at around 7 out of 10. Again, we do face the same problems as Professor Alok has mentioned, notwithstanding. But I think more importantly, one thing that we systematically did was about capacity building for our centers. We did not start ad hoc centers at all. We had the entire team in place, and we got trained people to work in that. And our 2nd generation, 3rd generation, 4th generation, especially of the surgeons, we ensured that every year people went for training, and they did additional training and came back and worked in these centers. So it's been quite a satisfactory journey. I won't take any credit. It's been a wonderful teamwork of all our seniors and current colleagues who are working on this. So overall, I think we were slightly different. Perhaps we were able to do all these things because of the disciplined environment we worked with, and also about availability of funding, which was to an extent, at least every year we could decide that, okay, this year Armed Forces is going to buy 125 implants. So that went into various centers. So sustainability of the centers of at least doing 20, 25, 30 implants per year was the key to having a quality implant program in the Armed Forces. Yeah.
Thank you. Dr. Dalmia, because you have maximum number of migrating people.
Yes.
Come and just get the surgery done and that's it, So
Yes.
how do you sort of grade your program as such and the outcomes of your clients, or the way the system is moving?
Yeah.
How do you grade?
Actually, I can say we can grade 7 or 8 out of 10. The region and some plus points are there because we have the upgradation facility also in our scheme.
Okay.
So they will get the upgraded speech processor after 4 years or 3 years, or depending on the condition of the speech processor. And now we got the permission for bilateral implant also. That is also a plus point.
Very
to the railway ministry. We got the permission, but this Make in India policy is
It's the
because,
only sore spot for you right now. Okay.
Can I make a point, Dr. Kalyani ma'am? One point only.
Yeah.
What Dr. Dalvia mentioned about the replacement for speech processors and other accessories. We introduced it in the armed forces about a decade ago. So that was something which was critical to the implant program being successful. Second issue was about the bilateral implantation that we had included in the policy much earlier in the early part of 2010, 2011. So these things made a difference to the quality of the outcomes. Yeah.
I think your document should have been studied by other people, but being probably your closed door things, not accessible to others. But anyway, leave aside that. Aparna, now I have two questions. One is how you will grade this whole scheme as such. But you see very diversified outcomes state-wise. And Kerala model is often quoted the best. So I really want to understand what are the different, why are these differences exist? And what is there that Kerala has and what other states don't have it? And what is it that liaison work is not working? So you take your time, but elaborate on all these points, please.
Okay. So I will stick only to the outcomes per se. So as with any, a cohort of cochlear implant recipients, even the beneficiaries who have been implanted under ADIP scheme, we do see a range of outcomes. We all know that the outcomes are never going to be homogeneous because the children with CI themselves is such a heterogeneous group, and to top it all, the social factors a lot. So because of that, first and foremost, the outcomes are over a large range. And what we have monitored so far, the monitoring of outcomes that has been done under the ADIP scheme, it has been to some extent indirect through the empanel centers. So the empanel centers are providing the habilitation to the children who have been implanted under the ADIP scheme. So the monitoring is happening through the centers. It is happening on a regular basis, where we request each and every empanel center to provide us with data about the child's, listening, speaking, communication progress. And even after the child has availed of the benefits that are provided under the ADIP scheme, we are in touch with the families and we try to find out from them how the children are doing. Okay, that is one thing. Other than that, few years back in 2017, we had conducted a third-party evaluation. This was conducted by National Institute of Speech and Hearing, Trivandrum, and it was a retrospective evaluation of the ADIP beneficiaries and the outcomes of the ADIP beneficiaries. And for this purpose, the first 100 children that were implanted under the ADIP scheme and they had completely availed of their benefits were selected. And we had conducted a lot of different tests and clinical evaluation was actually conducted. It wasn't based only on the parent perspective. So there again, the most important point that came through is that there is a range, and this range of outcomes, like you were saying, it does depend a lot on the states. Different states, we are seeing different outcomes, especially South. Now South actually, unfortunately, because in the South, already specifically because you quoted Kerala has its own program and it's a very good program. So from Kerala, for ADIP scheme, we don't have too many beneficiaries because they are all getting, at a young age, plus they have a different system over there. But if I look at the other South states, we have seen that the outcomes are better over there. Again, literacy, plus the centers over there, the centers from the South, we have seen that they already had established cochlear implant programs, running for decades. So they had a system, they had a framework, so they applied that same tested framework to the ADIP patients and then things were much better. But as opposed to that, if we see some centers who have started their program right with the ADIP scheme, there were a lot of teething troubles, manpower issues. They did not have adequate manpower. So because of that, plus again, socially, some of the states in the north or states like Rajasthan, we see that the issues are totally different. There are like all these families are poor, but then, the poverty is at a different level. The problems are different, like loss of wages. Dr. Asha Yatiraj mentioned, because of that, there could be dropout from therapy. All those reasons could be responsible for poor outcomes across these states. And one more thing, what I would like to say here is that whatever outcome evaluation or monitoring we are doing, it's not really prospective. We are doing it retrospectively, so we are not able to conduct like a large scale study. Whatever outcome studies are there, some of them have also been published in some journals, but those are of very small, like 50 children or 100 children. Now, considering that we have thousands of children, those have been operated, these outcome studies are very limited. So there is definitely a need to conduct like a large scale outcome study, and definitely those who were implanted early on, like 2014, that child is now implanted for 7 years. So down the line, what are the problems? What we have seen though is like about 65% of the children are having mean length of utterance as per their chronological age. 90% of the children are attending mainstream schools. And again, if I talk with reference to like verbal communication, 85 to 90% of the children rely totally on verbal communication with good speech intelligibility. So that is what we have seen across the different outcome studies that have been conducted. Even we have tried to conduct a study today. I'll be presenting one paper also on that, where we have studied the outcomes as perceived by the parents. So overall, clinically, whatever we are seeing, there is a range of outcomes. But if you look at the parent satisfaction, that is definitely very much high up there. Parents are very happy and they are very glad. They are thankful to the scheme that whatever would have been otherwise inaccessible to them, they have got access to that. And they all have told us unanimously that it's been life-changing for their child.
Yeah, and now I just saw on your website, the total number of beneficiaries is 3,788. That's a huge number.
Yes.
I worry about a lot of things, because this is something the kind of quotes you have given might have been, as you said, study of 50 cases or 100 cases or all. But I always think about it's a Gaussian curve. So 3,788 cases, if I want to fit into it, how will be they, displayed? So we have to really think about a very serious study as such, some longitudinal study also, because now different age groups are there. So a lot of things, but good means the way people criticize, let me say that way. I'm on the other side of the fence. I'm nowhere connected with government scheme. So I always hear a lot of negative things. People always say things don't work out here. This is right now. This is, but the way I hear from you people, all that, it's wonderful. Things are moving on well. And I always think about in Indian context, if we go, 50 plus, we are okay. Means whatever points we get, because to go with a diversified population, it is so challenging. Means what works in Delhi fails in Mumbai, and what is doable in Mumbai, Calcutta rejects it totally. So this is a kind of a culture we have. So I think we are moving on well, but still
can I just say one more thing? Sure. So I don't know whether I will be very rude in saying this, but I think the outcomes are, I think, as good as the center, the therapy center or the therapist or the clinician that is dealing with the child. Because like if we look at the device is same that any non-addict child would get. Okay, even the mapping, the same audiologist is doing the mapping of the non-addict child as well as the addict child. So the same factors which apply for outcomes in any other child are applying here also. Of course, because they are from very poor families, we have more socioeconomic factors that play a part. Like, traveling for therapy is really very difficult. That is one of the most important challenges that parents are suggesting. But we have also taken a lot of steps to conduct ongoing training for the empaneled audiologists and for the empaneled therapists, so that we follow a similar structure across the different centers and the different states. So we have some parity. and not see different outcomes across the different states.
Here I would like to ask some more question to rehab related to Dr. Asha and to Aparna yourself. You know, here I really want to see rehab program. We always consider, you know, family's participation is important. Mother's role is very important. And this is so much drilled so much all the time. Now we are looking about it, financially strained people and financially stressed out people. There are many family issues are there. People have to commute a lot. So there must be good experience or success stories also, despite all these odd things, though there may be anecdote kind of stories also. But I think still it's worth giving a due credit to them. So I request both of you to say how mothers are motivated in general. I'm not talking about A segment versus B or something. Or are they really sort of motivated to learn because the literacy level is going up? Now women are really empowered. So do you see that reflection, that kind of thing in your rehab program? Asha, yourself, please.
Okay, there are two groups. I'll divide my parents into two different groups over there. One who are very placid and just don't seem to want to do anything. And it's not about the EDIP scheme, it is everywhere. So it doesn't matter how much I motivate them. They whether they bought the device or they didn't buy the device, they are not motivated enough to do it. Home training doesn't happen. They tell lies saying, yes, I've done it. Then I have to say, show me a video of what you did. That's when I get to realize, okay, they've actually not done anything. Then they have a makeup video just pretending that they have done some activity. Then I have another group of parents who are over enthusiastic. And at Mysore, we have multiple places. So they'll come one day to one institute, they go another day to another institute. So they're actually going to about 3 different institutes, getting 3 different ways of training. Each institute has its own way of training. And that confuses the parents, frustrates out the child. So the outcomes are going to be based on that. And so they think that the more they do, the more the child is going to get better. So I have a lot of counseling to tell them, go to one center, follow what that one center tells you. If you're not happy with my center, go to another center. But follow one way of teaching and your child is going to make progress. And definitely there's so many, we have star parents. So we would make this mom the person who would be the model to the others. So this mother will talk to the other parents. So for each different company, we actually have a group of parents who would be the model parents. So we would tell them, go talk to this mom. We never tell them, go talk to the mom who's not doing the work. Okay, so we only tell them about going and meeting up the moms, and we take their prior permission over there. So, and they're willing to do it. So some of them have left and gone away to another center. They've given their phone number, so they contact them on the phone and they get information. So they are very motivating. They let them talk to the child also. And these children are able to talk on the phone also, some of them. So there are lots of them doing well. But I really want to make one point over there with reference to the EDIP scheme. The start of the EDIP scheme was very shaky, and I'm sure everybody in the country will agree to that. The choice of the device was so bad that that group, which has been using it now almost 6 years now, and most of them are non-users, not because they don't want to use it. Those children were making progress at their level, but the device has gone out of function. They are not getting spares, it's not getting repaired. We don't have loaner devices. A lot of issues with reference to that. So, I mean, those children were not making progress, but the tragedy is from the EDIP scheme, they are the first model. So we keep telling our parents, go look at the other children, don't look at this group over there, and try and learn from them. So yes, they are doing well over there. The other big challenge is in India, I think it's mostly in most states, the children are coming to us only when they're about 2 years of age. And so you were asking, why is the Kerala model working so much better? Because they are finding children much younger. So they have got this group who are only doing universal screening over there in the hospitals. So they're starting the rehabilitation at a much younger age. In Karnataka, only recently I started seeing children who are at below maybe 6 months of age. Otherwise, it is from Kerala that we were getting this below 6 months of age. And they've got the upper limit of getting a cochlear implant as 3 years. So the parents are working very hard to try and start off doing everything, by that age. So that I think is the reason why the Kerala model is working better
Education
than the
level
rest.
in Kerala is also very high as compared
Literacy
to
level
other
is
cities.
also very high.
Literacy, yes, but they're also compliant parents. Some parents who really
Human
don't
beings are same. Human beings are same. But still, overall, the information level is still at a higher level. As I said. But do you want to add something here? Because we have just few minutes left.
Yeah, we are talking about the rehab program. So yes, there are many parents like from ADIP who are finding it very difficult to access like post-operative therapy. And but also I think with the COVID, lot of things have opened up. What we did during the lockdown, because the parents were not able to go to the therapy center, so we had requested all the empaneled therapy centers to do online therapies. Plus, from our side, we have established contact with all the parents, especially the ones, the children who were operated just before the lockdown or switched on just before the lockdown. So in the initial phase when the therapy is utmost important, it hadn't started yet. So for them, like we conducted meetings with the parents online. Now everybody has a smartphone. So we had very good attendance, all the parents, and we provided tips. And at that time, we also had some experienced parents join us, and we got those new parents to talk to these experienced parents and see their children and then understand that, yes, after a while, your child can also achieve this. So that is one thing which we had done, and like parent groups were very important. And other than that, all the points Dr. Asha Etiraj has talked about.
2019, if we had a panel discussion about M-learning, it would have been rejected in totality. And now, is sea change what we really see. The smartphone has become a real tool for us for a lot of things. So way forward is really positive. I'm just going to jump on a little further for a few more questions because we have just a few minutes left.
Excuse me, Manke ma'am.
Yeah.
Ma'am, there are 7 questions. So if you can, I don't know how many questions you have to ask the
panel. Then let me just,
no, but if it is something important, I think we should. Panel discussion is the way to go forward. I think it is very important. This is
so this is my last question. We will take
at least 5 to 7 minutes are left because at 4 o'clock we have another session to start with.
Yeah. So every panelist will just give, just one sentence or one way or 2 points, sort of, 30 seconds to each, and we will be able to take some more questions. So what is the way forward for the audience? Means we all believe in these schemes. We really see the sustainability will achieve through these various government schemes, but how better it should be shaped up, or how we want to expand it, or how we want to color it in a different way. So I request each one of you to say, Dr. Thakkar, yourself first.
So I don't think we should be looking at this in isolation. We have been looking at it in isolation because we are a group of professionals who practice in this. But ultimately, it's universal health coverage as it comes through, and that is happening in the country. And as the country probably goes to a higher income level, things will come and change. And I think what has happened in the last 2 decades is primarily because of this, and this is where we will change. Of course, we will continue to do our own niche area things and press for change in our niche area.
Okay, thank you. Dr. Venkatesh?
I would stress on 2 points. One, what Dr. Asha pointed out. It's about getting the children who need implantation at the earliest. I think it's important for us to spread the usage of universal screening. This is something that we did in the armed forces. We provided a screener to every single hospital. It's going on. So we are able to achieve the diagnosis, or rather the need for the child for a cochlear implantation much earlier. Second issue is about Dr. Alok Thakkar said, ADIP has to be linked with Ayushman Bharat scheme. And after that, whatever implants, replacements, the accessories that needs to be provided should be provided through a universal health scheme. It is a tough decision. It has to happen. Otherwise, the sustainability of the social contribution towards the ADIP scheme and other things will be real difficult. We'll have more and more people who become non-users, especially with the technological upgrades, need for processor being changed, microphones being changed, and the magnets that need replacement. And also what Dr. Alok Thakkar said, we are only looking at a 20-year warranty for an implanted child. If you're looking at implanted the child at 4 years, then what happens 25 years later? the child perhaps would need the technology would change. He would need a internal component replacement also. We have already seen that happening. There are device failures which are happening at the end of 10, 12 years. So these are the issues that, there has to be a complete coverage, a social coverage for these children. And I can see that only happening through an insurance scheme or a universal health scheme with Dr. Alok Thakur has stressed. It should be linked to Ayushman Bharat scheme at the national level. And more importantly, I think we need more responsive companies, industry. What they were when we started the implantation, they are not today in that sense. I think that there's a need for us to relook at how the industry is going to support the social schemes of Government of India, because it's a huge market as we go forward.
Dr. Dalmia, yes, sir.
Yes, one more thing, just the GST should be removed so that it can be a little bit cheaper. This is one way thing, and we all three, means the audiologist, the surgeon, and the government, all have to work as a team to improve this program and so that more people will get the benefit.
Dr. Asha?
I think insurance schemes should be there for unborn babies so that it gets covered by devices like hearing aids and cochlear implants also get covered. It shouldn't be a burden only on the government. It will not work out. The other thing is saying the criteria should be different. Extend the criteria for who is eligible for a cochlear implant.
Aparna?
Yeah, I would say that like government schemes, specifically ADIP scheme, I think it is here to stay. There are pros, there are cons, but if you look at from the level of the beneficiary, from the level, like the point of view of the family, for them, the pros are a lot. Okay. Also, we have to all get together to make it work. We are already looking at a revision of ADIP scheme, and many of the problems that we are been discussing in the past and we discussed today, I'm sure they'll be taken care of as we go forward. Plus, in future, if we get the Indian device, on which the work is already going on, the field trials are going on. If we get a device which is much cheaper, then all of these families really will benefit to a much greater extent.
Yeah, thank you. Thank you, everyone. I personally have something, when any scheme gets launched, it's not the one-time only device as such, because the replacement has to be the integral part of it, the upgrade as such. But secondly, even to upgrade any external device with the price tag attached every 5 years is incorrect. It has to have a better life than what it is. We are surrendering to the company saying that they say, oh, every 5 years you need to change, and we accept that. Something the device should have a little longer life than what it has right now. So suppose a child, 2-year-old child gets a implant at 2 years of age, till he becomes self-reliant, how many upgrades he will need? Maybe 3 or 4 upgrades. Okay, every 5 years, if you think about it, it will be 5 implants, and then otherwise 7 years, it will be 3 implants. Because at the age of 25 to 30, in that age group, these hearing impaired individuals will become self-reliant. Till that time, at least our commitment should be to support them, because you bring them in the hearing world and then the processor goes off and then you ask them, sorry, I can't do anything. You live in a silent world. This is more criminal, because then the person was better off in a silent world. You show him what is the beautiful world it is, all the sounds of music, and then later on we start saying it. So I think any scheme we negotiate or frame or something, it has to be considered for the entire, child enters into adulthood. Till that time, the support and how it should be. And then and secondly, is this a good business model? 30 lakhs for till the age of whatever, 25 or 30 years of age, if that's the cost come. I don't think it is really a good business model. It's a good device. Technology is wonderful. The solutions we are giving are excellent. The price tag attached to it needs to be pondered upon. So thank you all the panelists for giving your time for it.
Manke ma'am, no, we will take questions for 5 minutes.
Sure.
Yeah. So the first question is that in the scheme, are families informed about the importance and use of hearing aids, and is the cost of pre-implant therapy covered under the scheme? For Aparna.
Yeah, no, at present, no pre-implant costs are covered under the ADIP scheme. So whatever are the pre-implant assessments, audiological, radiological, or purchase of a hearing aid or pre-implant therapy, those costs are currently not covered under ADIP scheme. It all starts at the time of the surgery and thereafter.
Yeah, this is all for ADIP only. I don't know. I don't think you'll be able to answer this question because they've written empanelment of the surgeon and hospital is closed in the ADIP scheme. When will it open?
Yeah, it is.
So I don't think, yeah.
It is closed at present, and we don't have a timeline as to when it will open because we are more interested in conducting an audit of the already empaneled hospitals before empaneling newer ones.
Yeah. So an answer or a sort of a question also to what you said just now, that there are many medical colleges across the country. Why can't all the colleges start ASLP and the postgraduate diploma courses, which can greatly improve infrastructure and develop so many professionals required badly in our country?
Yeah.
So
that's true. It's a suggestion.
Yeah, it's a good suggestion. Then there is one, what would you say, not good a thing. That's what they've written, that lots of patient beneficiaries are on the ADIP website, including their addresses, cell numbers, and names. Is this not a violation of the privacy rights of those patients?
No, these are the previous data which we used to put on the ADIP website. Of course, the parents have consented to it, but after that, when we also realize that it is on a public domain, we have stopped doing it for all the reset recipients. It's only available to the empaneled hospitals. It is password protected.
Okay.
Yeah.
Actually, just I want to add one thing.
Yeah.
Here, you said that the filling of the post-graduation degree in the medical colleges. Actually, many audiologists are there. The filling of posts in government hospitals.
Yeah, we understand that.
Creating the post is more important than.
Correct.
Yes.
Yeah. Then another thing they've written, upgrade of speech processors should be considered because only basic is given, and then after a few years, the patients are pushed for upgrades, and then the new processor will cause them, and they may become non-users in this thing.
Yeah.
Yeah. And the other one they've written is there going to be a policy to have cochlear implants for acquired hearing loss and adults with hearing loss? So you can answer both of these.
Okay, so first question was about the upgrade. Yeah, so currently upgrade is not available under the ADIP scheme, but eventually we are pushing for it as professionals, as clinicians who are dealing with these patients day in and day out. We are pushing for it. When the revision of the ADIP scheme is going to be done, it will be done soon, hopefully. But of course, we are not waiting for that to come. In the recent past, we have tried to mobilize different funds, available to us, and we have been trying to help families who have been struggling with the servicing or the repair or upgradation. But that is not in a very large way, but whatever limited way, we are trying to mobilize funds from other avenues. Okay, what was the second thing?
Second thing was about the policy for acquired hearing loss and adults with hearing loss, whether implants could be covered for these two groups as well.
No, I don't think at this juncture the government is really favorable for providing it to adults. They are more interested in providing it to children.
Okay.
And acquired hearing loss, we are providing already to the pediatric population until the age of 12 years.
Okay.
So pediatric acquired hearing loss, we are already providing. We have provided also in the past. So we have a good number of recipients who have, acquired deafness. It's perilingual, I would say, or postlingual, and they have got the benefit. But for adults, it's not yet there.
Okay. So all in all, I would just like to describe this integrated panel discussion only one word: superlative. Whether it was with respect to the moderator, the eminent panelists, and the choice of the topic by the OC and the EC. And if you remember, Aparna, I had done this study for maintenance and sustainability, continued later on by you, and we've done this way back in 2013, and I'm glad that at least this topic is again picked up, so that in the near future, for people who are going to be hooked onto the implant, they should keep this in mind, that just doing the implant is not important. Maintenance and sustenance is a very critical thing. Thank you
Ishita, 1 minute.
Yeah.
I was scared to death to conduct this panel because not my domain at all. Nothing.
Imagine me.
No, but excellently done.
I was
Done by you, and the panelists were too good. They were
so I really, I bothered them a lot, and these all people supported me. Thank you, everyone. Thank you so much.
Imagine me, Dr. Manke. Thank you for your support.
Last minute, yeah. She had to join very last minute.
It is all a team effort here. Like the moderator, the panelists, you all can thank each other. But now it's time to thank you, and let's go on.
Thank you.
Thank you very much, all of you. Such a pleasure meeting you all, on our virtual mode. Huh? Thank you.
Thank you.
Hello, everyone. I am thinking that I am going to start my presentation. Is that correct? Here we go.
Dr. Gordon, I can't, yeah. Dr. Karen Gordon, yes. So,
hi, how are you?
Hi, how are you? Now we are going to start, and I'll just introduce you and then start, yeah. Okay. Dr. Karen Gordon is from Toronto, Canada. She's a professor in the Department of Otolaryngology and a graduate faculty member in the Institute of Medical Science at the University of Toronto. She works at the CIGICON as a senior scientist in the Research Institute and as director of research of Archie's Cochlear Implant Laboratory. She's a member of the Cochlear Implant team, which is responsible for determining candidacy for cochlear implantation of children to the program and monitoring them, those who are using either single or bilateral cochlear implants. She received her PhD in 2005 at the University of Toronto and her master's in audiology in Northwestern in 93. She's a registered audiologist of the Canada CASLPO and a fellow of the American Academy of Audiology and a member of the ARO, a very prestigious society, and the Society of Ear, Nose, Throat Advances in Children. Dr. Karen became the inaugural recipient of the Bassel Potts Health Clinician Scientist Award in Hearing Impairment in 2014. Prior to that, she was recognized for her research by being elected to the Collegium Otorhinolaryngologicum Amicitiae Sacrum in 2011 and received an early researcher award from the Government of Ontario in 2009. She has a huge number of publications and is regularly invited to speak to research. I'd also like to add on a personal note that she is very kind to fresh researchers or even new topics. In Chicago, one of her students told me, you asked Dr. Karen Gordon, and I had requested her to come and see the poster which I was presenting, and she was very kind about it. Thank you. And now she's going to give her keynote on memory and learning challenges in children with poor binaural hearing. That's a huge and fresh area. And I look forward to hearing it. And we are all going to have a treat, Dr. Gordon.
Wow, thank you so much for that very kind invitation. And it's lovely to see you again. It's really a pleasure to be here. And I just thank everybody for the invitation and the opportunity to talk about some of the things that we've been doing. So I'm going to share my screen so that you can see my slides. So let's just make sure everything's working. So you should see So how does that look for you?
Yeah, that looks good.
That looks good. Okay, perfect, perfect. And I'm going to give you a little bit of we're going to draw a little bit on these slides. We'll see how that works. So we are all very, very interested in making sure that children who have severe to profound deafness have access to sound. And I just heard the panel before me speaking about how much work we put into them and how much work that the families put into helping children develop hearing. But I think we also need to remember that the children themselves are putting in a lot of work. And this work and effort has some consequences, I think, that we need to be aware of. So what I'm going to talk to you about is the effort it takes for children with hearing loss to listen, the cognitive effects, and then the functional repercussions on memory and learning. And I'm going to focus in on children who have poor binaural hearing, and I'm going to explain to you why I think that this is an issue. Okay, so the first thing I want to do is acknowledge just an incredible team here in Toronto at the Hospital for Sick Children. I just can't thank them enough. They're clinicians, researchers, and people in the laboratory who are working with these children and helping us understand more about them. So I have a few disclosures and acknowledgements. And then I want to just tell you what I will be discussing with you, is this idea that listening effort goes to a cognitive load, and that's going to have implications for children with hearing loss. So what I'm going to start with is what happens in adults and the effect of hearing loss in cognition on adults, what happens in children with hearing loss in terms of the cognitive findings, the challenges cognitively that are associated with particularly unilateral hearing loss, and how that leads to effects of spatial hearing and the inabilities of children with bilateral cochlear implants and unilateral hearing to have good access to spatial hearing in development, and how that impacts memory and learning. And we'll also talk about this important factor, which is that children with hearing loss often also have vestibular impairments, and that this in turn has an effect on their memory. So let's go ahead. We'll start here with other beautiful studies done in other places, but this is something you can see. These are recent papers, 2020, 2021. And what I want you to see is that these studies are looking at fatigue, listening related fatigue, both in adults and children who have hearing loss. So what I want you to see on this graph on the right is that we're talking about adults here, parents of children, children themselves, and teachers who have completed a fatigue scale. So this is a measure of how much fatigue these individuals are experiencing. And the comparisons are between individuals with bilateral or unilateral hearing loss against peers with no hearing loss. And it's not surprising that the adults with hearing loss report increased fatigue relative to the adults that have no hearing loss. Again, parents of children show, yes, our children with hearing loss have fatigue, and this is much higher than the parents of children with no hearing loss. And the children themselves also, particularly in bilateral deafness or bilateral hearing loss, do indicate that they are fatigued relative to normal hearing peers. And here you can see something interesting is that the teachers are a little bit unaware of the fatigue that is related to this increased effort involved in listening. So here, when you look at children, again, fatigue scores that are being reported relative to normative data in the literature. Again, we have individuals with unilateral hearing loss and bilateral hearing loss. You can see across all of these domains of fatigue that where we're looking at general fatigue, something about sleep and cognitive fatigue, you can see that the children with hearing loss are incurring increased fatigue relative to their normal hearing peers. All right, or the normative values. So this fatigue probably has implications beyond just being tired. We know that this has hearing loss, and the fatigue related to it has been associated with cognitive challenges. And so this was a landmark study by Frank Lin earlier in 2013. This first came out, this idea that if you look at these measures that are indications and screening for dementia, what you can see is that, of course, over time, and this would be age of the participants, there's a decline in these cognitive measures. But you can also see that if you look at the darker values for normal hearing versus those adults with hearing loss, that these adults with hearing loss start at a lower level on both tests. So there's an increased problem with cognition relative to hearing loss. And so then we shouldn't be surprised that we do find cognitive challenges also in children with hearing loss. And Pisoni's group in New York has done a beautiful job looking at this. This is one particular measure that I love, because this is a game. I don't know if you had this game in India, but I grew up with this game, Simon, where you the lights of the buttons press in different orders, and you have to remember the sequence and press them in the correct order, and the sequence increases and increases. So Pisoni's group used this very popular game back in, I don't even want to tell you, I guess it was the 70s. And what they did is they used it with just audition alone, because it has a sound, with the lights alone, or both. And they looked at the span for both how long the children could use this game, and then the learning sequence. And so what I want you to see here is that if you look at the children with normal hearing versus the children with cochlear implants, how much lower these performances are in the children who use cochlear implants, indicating, yes, there are some cognitive implications in these children. And in a more recent study, McCreary has shown that, you know, if you're having troubles listening in noise, that's going to have greater effects on attention and working memory measures. So what I also want to show you is, if we go back to that fatigue scale, because maybe things are starting at the area of fatigue, let's go back and look at this bilateral versus unilateral group. Both for the adults and for the children. Remember, unilateral hearing loss is sometimes considered minimal hearing loss. There's this idea that if you have access to hearing in one ear, that it's good enough. And what you can see is, look at these fatigue scores here. They're both significantly poorer than normal and not significantly different. Okay, so this is really indicating that adults with unilateral loss are experiencing significant fatigue. And the parents tell us the same thing for children with unilateral versus bilateral loss. There's some differences in the child data and the parent and the teacher data, but I think this is very much worth exploring. And I think that the issue here is about the difficulties that come from listening with no binaural cues. And that's particular to children with unilateral loss, as well as children with bilateral hearing loss who receive two devices, particularly two cochlear implant devices, because these important foundational cues for spatial hearing may not be present through these devices, or may be completely limited in children who have a single-sided deafness, for example. So when we're talking about spatial hearing, the foundational cues that are required are these interaural cues, where a sound coming from one side is going to hit the near ear more quickly than the other ear, and it's going to hit that near ear more at a higher intensity than the other ear. And so without those access to those cues, then there's a debilitation in the spatial hearing. So if you think about it, for children, this is really quite complex because children are often in environments like you see here in the playground. And if you think about this child here in the middle, what does she need to play and interact with her peers in this situation? She needs to be able to have clear access to the sounds, to distinguish voices. She also needs to understand where these children are around her. And that is, a lot of that comes from spatial hearing. So in this game, obviously with no visual cues, only relying on auditory cues, where this child in the middle needs to find which child is calling her from outside. Of course, that's going to require spatial cues. And it's also giving this child in the middle a sense of what's around her. In the real world, we can imagine situations like this where we're focused in on something right in front of us. Often it's our smartphones, and this is a visual draw. And so we're really relying on our spatial hearing to tell us about the world that's going on around us. So in this situation, this might be fairly safe and somebody might bump into you and that's okay. But in this situation where you have somebody really focused in on her cell phone here, walking across traffic, I hope the traffic light is red because and these cars are actually stopped, because she is completely relying on her auditory spatial hearing to be safe as she moves through. So of course, spatial perception is important when we look at conversations and speaking with people, when we're doing this in person and with more than one speaker around, which I hope we get to. Although I love to speak to you all by Zoom, and maybe you don't need your spatial hearing in this situation. Hopefully we will get to a place where we have others around us. And again, the ability to distinguish one voice from the other, one of the components of hearing that you're going to need is your spatial hearing. So if we think about adults and children who have lost spatial hearing because they're not getting great access through their devices, and or individuals with unilateral loss, what happens is they've lost a really important access to the world around them. And you can imagine that a child with unilateral loss will really find this particular game very difficult and interactions with her peers difficult. And then I think we need to also acknowledge that these children may not understand what's going on around them because of the loss of spatial hearing. And they also may have some difficulties understanding where they are in space, because vestibular input is so important for that, for you to know where you are in the world. So imagine many of these children, probably up to 50% of the children that we see with severe to profound hearing loss coming for cochlear implants already have significant vestibular impairment. And so if this idea of where they are in the world is also absent or discordant, this must play a role. So imagine children moving along on a bike, having to rely on the vestibular system to tell them where they are and their auditory system to tell them what's around them. But if both things are impaired, this is going to take a lot more effort than a child who has normal hearing and balance function. So I think we need to really think about the consequences of unilateral hearing loss. And when I hear people talk about this as a minimal hearing loss, I think that terminology is problematic. We know that they have problems in so many domains. Some of these are obvious. Poor sound localization comes with the loss of binaural hearing, and that also comes with compromised speech understanding and noise. But I think it may also surprise some people that children with one normal hearing ear and a hearing loss in the other also have deficits in speech and language development, increased cognitive load, reduced IQ, high risk of repeating a grade, so academic consequences, and they know they have a problem because they're reporting that they have hearing challenges and even reduced quality of life. So I think we should also remember what I talked about before, is that we are trying to restore spatial hearing to children who have hearing loss bilaterally through the use of 2 cochlear implants. And we also know that our best chance of giving that to them is by providing 2 cochlear implants in these ears at the same time, the same surgery, so that the bilateral auditory pathways can develop in tandem. But even in these children, a lot of our work, this is one group who looking at poor localization in England, shows, yes, their spatial hearing remains impaired. And our group has done a lot of work in these children showing how much they are benefiting from the 2 cochlear implants, how much development they do get from the cochlear implants. And even so, they remain poor, so they have poor sensitivity to binaural cues across all of these studies. And they also hear their bilateral input as separate signals often. They really don't fuse the input between the two into one image, auditory image. And we know that this is happening in the brain, where we see many examples of cortical processing difficulties when we have the stimulation coming from both devices. So we wanted to know the effects particular to poor spatial hearing. And what we did for this is to do something that I think was surprising to many people, is to compare children who have bilateral cochlear implants provided simultaneously at young ages. And now these children are about, on average, about 9 years of age. So they've used their devices for many, many years. And children who have single-sided deafness who didn't receive any treatment on this side. And the reason that we were very interested in these 2 groups is because of this abnormal access to interaural cues. So in the bilateral group, that access is abnormal. They have some ILD or interaural level difference access. The sensitivity is probably not normal, but no timing differences, very limited. And then, of course, if you have single-sided deafness, these cues just are not absent at all, so are not available at all. So this is a group. These 2 groups represent children with poor spatial hearing relative to a normal and typically developing control group. So we looked at these 3 groups with a number of different tests, many, many tests, actually. These children did a marvelous job, and I want to highlight the student, Claire McSweeney, who measured all of these tests in these children. It took quite a few hours for each child to be tested, but you can see that we're doing measures of hearing, of balance. And here I'm going to tell you a little bit more about these memory tests. We did a spatial navigation, but I'm not going to talk about that today, but I will talk about the academics of the testing that we did for math and reading. And I'm also going to talk about this language screener. So let's talk about the memory tasks specifically. So we did, first of all, a verbal memory task where we provide digits spoken with no visual cues in a sequence. And then the child has to repeat that sequence back either in forward or backward order. And then the span is the length of the sequence the child can correctly recall and respond to. Then we also did a visual spatial perception and memory task. These were 2 different tasks. The first is a 3-dimensional task. You can see these blocks here where they're placed in different positions. And again, we indicated a position, order in sequence, and the child had to repeat that sequence in forward or backward order. We also did it in 2 dimensions on this 4x4 grid, where this dot here is moving into different places in sequential order, and the children have to remember those locations and indicate them in forward or backward order. So you would think that children who have hearing loss would actually be very good at these tasks because they do not require any hearing. And with cross-modal plasticity, the idea might be that they are actually more attuned to visual spatial perception. So keep that in mind, because you're going to be surprised when I show you the findings. When I looked at the sensory challenges in children who have bilateral in green, you're always going to see these children, the data from these children in green, or the children with single-sided deafness in blue relative to normal hearing peers in the pink. What you're going to see is that they have balance deficits. And those balance deficits are actually significantly different from normal, but no different from each other. There is a there's slight differences in the better hearing ear. You can see that children with one normal hearing ear perform similarly to their normal hearing peers, as you would expect, in quiet word recognition tasks. Here's the phonetically balanced kindergarten score. And you can see that children with bilateral cochlear implants, as we know, if we looked at the better ear, it was still significantly poor, although there's a range of data here, and the children are actually doing beautifully well. But as a group, there is a significant difference, as we would expect. But also, let's highlight the asymmetric hearing, which is going to be obviously dominant in the children with unilateral deafness. And you can see also there's a slight degree of asymmetry that can occur in children who receive bilateral cochlear implants, even though they were given at the same surgery and at the same time. So we had all of these different measures, so many measures, and what we did was an analysis of how all of these measures cluster together into what groupings. This is a very interesting statistical technique, the principal component analyses, which allows this to occur. And what I want you to see is the main cluster here, this dimension 1, which describes a huge amount of the variance in the data. Almost half of the data is from these tests shown up here. And you can see that, it's mostly these measures that I want you to focus in on. The other measures are, these ones are all about learning and memory. So, and some language here as well. So we call this the learning and memory dimension. Then there is another dimension that is around self-reported hearing challenges. The third dimension was about balance and vestibular, and there was a hearing dimension as well. But you can see that this first dimension really encompasses many of the tests that we did. And I want to describe the outcomes of those tests and what we're seeing. Let's look first at the memory tasks, okay? Both the visual spatial, the dot matrix, the Corsi block task, and the verbal, the digit task. So here, what I want you to see is that of all of these measures, dot matrix, Corsi blocks, the digits, all of them will increase with age, as we expect. And you're going to see that in most of the measures, as children got older, they got better at doing these tasks. But I also want you to see the significant difference in both of the groups with hearing loss, again shown in green and blue. And what you can see is if we look at the dot matrix, this is a visual spatial task. It's looking at working memory because the children are repeating in backward order. And you can see here that both groups of children across the ages with hearing loss are showing a decrement relative to normal. And the other thing I want you to see is there's no significant difference between the two groups. So there's no advantage in this task of having a normal hearing ear on one side relative to children who are using 2 bilateral cochlear implants. In the Corsi blocks, actually the trend was really specific to the children with unilateral loss. And interestingly, fascinatingly, there was no significant difference across the groups in the verbal recall. Really amazing. The same thing we saw when we looked at short-term memory. Now, this is the same memory tasks, but the children were recalling in forward order. You can see the same effects of age that is improving, and across age, what you actually see is it's these visual spatial tasks that show deficits particular to children with unilateral hearing loss. So think about this. These are children who should have access visually, but this is a spatial task and they're showing deficits relative to normal. So do these deficits, we think, that come from poor spatial access in hearing, and I'm going to show you also a vestibular input as well, does this have consequences for their academics? Well, they do cluster together in the same component. And indeed, when you look at the scores, again, we expect that there's going to be effects with age. And you can see that in the top row, where all of these scores of the reading tasks, 3 reading tasks and a math task, that we have improvements with age. And you can see here again on the reading tasks that the 2 groups with hearing loss show poor reading scores relative to their normal hearing peers and no significant difference between the groups of hearing loss. And again, in the pseudo word reading and in math. So these same problems and deficits are seen in both groups across these academic tests. Finally, language, again, the same idea here, that we have significant deficits relative to normal in both groups and no significant differences between them. So for me, this was a case of a glass half full and a half empty. So glass half full, it's amazing that children who are deaf and receive 2 cochlear implants simultaneously are achieving language and academic outcomes similar to their peers who have 1 normal hearing ear. That is incredible. Unfortunately, we still have a glass half empty, because these children, both of who have limited to no binaural hearing, show memory deficits across modes into visual spatial modes, as well as into the visual spatial modes, as well as learning challenges. So the question here is there an absence here of cross-modal adaptation to the spatial deficits? Why are we seeing these spatial deficits cross into vision, and what the academic implications are there of having impaired spatial hearing? So when we think about the evolution of cochlear implants, we used to provide only 1 cochlear implant to children who are bilaterally deaf. We realized that even if there was very limited hearing on 1 ear, putting a hearing aid in that ear actually helped, which gave us this idea that maybe hearing in both ears would really provide some improvement in hearing. And then we moved to bilateral cochlear implants, which we found actually was very helpful, even without providing good access to these binaural cues. But bilateral hearing was very helpful, which told us maybe we should be looking at children with asymmetric hearing loss. So we use bimodal hearing, where we've got children using an implant in the deaf ear and a hearing aid in the other ear. And then further to that, we've now moved into providing children with single-sided deafness with a cochlear implant in the deaf ear to provide bilateral hearing, because now when we think about cochlear implant candidacy in our program, we're really thinking about what to do to give bilateral hearing. So in the bilateral deafness, we're going to give 2 cochlear implants. When it's asymmetric hearing loss, we're going to give bimodal input, and single-sided deafness, we've begun to explore this bimodal input using a unilateral device. And when you look at these children, and in one early study that we assessed the cortical responses, looking at the sources in the brain of where this activity occurs, we started with 5 toddlers with single-sided deafness and gave them cochlear implants at very young ages. You can see they all had hearing in their right ear with hearing loss in the left ear. So when we stimulated the right normal hearing ear, we get this pattern of representation in the brain to the contralateral cortex, which is there at the beginning of cochlear implant use. It's there 1 month later, it's there 6 months later. We're not affecting the hearing in that right ear. When we look at the left cochlear implant, initially we get a huge amount of unusual activity ipsilaterally, a little bit in the contralateral cortex, but you can see this very unusual ipsilateral activity. But we, after 6 months, which is very quick, we start to get normal representation where we want it, only in the contralateral cortex. So this is an increased representation of the formerly deprived ear. So that's really important. So I want to just take the last part of this talk to discuss the effects of vestibular problems. And if you remember in the study that I showed you before, the balance deficits that were highly prevalent in both groups of children, both children who receive 2 cochlear implants, as well as children who have single-sided deafness that are not treated. And as I told you, when we look at the vestibular results in these children, about 50% of them will have vestibular impairments. So we've been trying to provide some cues for these children of where they are in space by this unique device, which looks at head position and provides some input regarding the head position to the cochlear implant through auditory input. So when there is a pitch change in the head, forward or backward, this device provides sounds that will increase in frequency or decrease in frequency when the head is pitched backward, or change in intensity when the head rolls from side to side. So when we looked at the effect of this device, we were looking at a group of typically developing individuals, children, adolescents, and young adults, compared to children who have bilateral cochlear implants and known vestibular loss. And you can see there were 8 of these individuals. And you can see that it's not surprising because of their vestibular loss that they have very poor balance relative to the control group. So what we did here in this particular study, we wanted to see how these individuals were maintaining an upright posture while they were doing cognitive tasks, and how remaining upright may be hard for them when they're paying attention to other things. So we have these body-worn cameras on the back and the head and the feet, and that allows us to record the motion of the person as they're either sitting, which there's really very little movement, obviously, when they're in tandem stance, 1 foot in front of the other, without this unique balance CI device, and then when they are standing with this balance CI device. And the measures that we were making were the same measures of working memory that I told you before, a digit span where they're repeating back a sequence of digits that were spoken with no visual cues, or this visual spatial dot matrix task where they're recalling the position of the dots in this matrix in backward order. And this is work done by Rebecca Benjamin in my lab. So what I want you to see here is the data that we have in terms of the cognitive task trials, correct? And the first thing you'll notice is that the group of children with cochlear implants in both the digit and the dot tasks are significantly poorer, even in a seated position, than the normal controls. And this occurs across all of the tasks. You can see that their performance is poor. You can also see that there is improvement in the dot matrix task relative to the digit task in this case. And this may reflect the use of this matrix that they're looking at to actually correct for the vestibular impairments, that they're actually using this as a fixation part, and maybe these children in particular may be helped by the dot matrix task. But you can actually see that there's no difference across these tasks in these scores. But if you look at their movement, there we start to see some differences. So here is the amount of movement measured by path length across all of these sensors that we had on the body. And here what you can see is that the children with cochlear implants shown in orange show a particularly significantly larger movements in both the digit span as well as the dot matrix task than normal hearing peers. And this occurs both for translation movement, which is this linear kinds of changes rather than rotation, but the rotation shows the same effects in both, in the digit span, not in the dot matrix task. So, but overall, I want you to see that there's more movement in the cochlear implant group when doing this working memory task. And I should also mention that this is not seated. These are in the tandem stance conditions. The other interesting thing is that when we look at this digit span disadvantage, so the effects of doing the digit span compared to the dot matrix, what you actually see is when the balance CI is off, there's more movement in when there's digit span, they're doing the digit span task than the dot matrix task. But when the balance CI is on, it's amazing that this movement actually decreases and they're more like their normal hearing peers. And this occurs both for translation as well as rotation. You can see this increased movement when they're thinking about those digits rather than focusing on that dot matrix. And this improves to normal levels in when the balance CI is actually on. So when we think about the implications, we have to think about these children with hearing loss and many with concurrent vestibular problems, how they might fare in this situation, which is so common, where they're interacting and communicating with peers in a playground. This is where they learn, this is where they grow. The effort required because of the loss of spatial perception is significant. And so what I think we need to do is to think about these moving forward in terms of hearing. So hearing in terms of a spatial perception, so here, and we need to improve the outcomes in these children in memory and learning, I think, by promoting binaural and spatial hearing and spatial awareness. Which may help them out, both for children who have bilateral hearing loss as well as children who have unilateral hearing loss. We also need to think about balance and the giving back these children a perception of where they are in space, and perhaps this device, such as the one that we've developed, could give some help about where at least the head is in space and give some input there through the cochlear implants to improve stability and help these children with not worrying so much about those things and attending more to what they need to do in terms of learning and memory. So with that, I want to thank you so much for your attention and for, again, the invitation to present to you here today.
Thank you. That was amazing, mind-blowing. It is a totally new area. Thank you for presenting, and in the wee hours of the morning when it's really cold and
yes, it's quite cold. No snow yet.
Yeah, that was super. I mean, really amazing.
Thank you so much. Stop sharing.
Thank you very much. On the organization committee, I formally thank you.
Thank you so much, and have a wonderful rest of the meeting.
Yes, you too. You too.
After that fantastic session, ladies and gentlemen, I have a couple of housekeeping announcements to make. Firstly, I hope you all are enjoying this virtual conference which the scientific committee and the organizing team has put for you. And secondly, during the breaks, you all can visit the exhibition tab or the exhibition area to check out our educational partners who's helped us to get this conference up and running. In a couple of minutes, we will then split into the respective halls for the next section, which is going to be the oral paper section, probably in each of the respective halls in about a couple of minutes. then we will assemble in those halls and then have the oral paper session. So see you in the respective halls in a couple of minutes.
Deepa has to be in this thing, no?
Greetings to all. So I welcome you all to the last session for today, which is the session on oral presentations for the surgery. And as we all know that each and every presentation will be given 10 minutes. And in those 10 minutes, 8 minutes will be for the presentation itself and 2 minutes of questions and answers. We have a lead panel of judges here who will be marking you for this. And I'm just waiting for Dr. Rambabu to come and join us. And as soon as he joins, with his kind permission, I would like to start this session. All right. So
Hello.
we are again.
Hello.
Hello, sir.
Yeah, hello. Hi.
Yes, sir. So can we start, sir, now?
Yeah, we can.
Right.
Just show it.
Right. So I would like to call upon our first speaker for today evening, Dr. Amit Kesri, who will be speaking on cochlear implant in ossified and malformed cochlea by VRIA technique and institutional experience. Dr. Amit, please go ahead.
So at the outset, I would like to thank you, the organizers, for giving me opportunity, and good evening, chairpersons and all the judges. So I'll be sharing my experience on the ossified and malformed cochlea, which we have done in our institute. So the cochlear fibrosis and ossification, although are uncommon, but pose challenges during the electrode insertion. Most of it can be diagnosed by the MRI and CT scan. But common causes of ossification are bacterial meningitis, otosclerosis, idiopathic trauma, or autoimmune inner diseases. Grade 1 ossification is the commonest which we have encountered, which means the round window ossification, or the grade 2 where the proximal base turn. And grade 3. Grade 4, we have not done the implant. Cochlear fibrosis and ossification is an ongoing process, which is very, very important that the one of the scans should be done closer to the surgery, especially in India, where the patient take time to get finances or from the government sanction. Surgical team must be well versed with the grades of ossification and strategy to manage it. Judicial decision must be made between recanalization and drill out to preserve the neural structure for better stimulation. Coming to the malformation are common in a basic cochlear implant center, because according to all the studies, 18 to 20% has malformations. Most common malformation in large vestibular aqueduct and incomplete partition, also known as Mondini's. Then there are common cavity cochlear hypoplasia. Each malformation pose unique challenges, and in our experience, different malformation in both ear exist. One may be less malformed, one may be more malformed, and not strictly as prescribed by Senegru et al. We have seen different malformation. So this is a retrospective study which is done for last 6 years, transcanal VRIA technique, and I will just share a few cases and then the result. So this is a grade 2 ossification. We can see that there was some fibrosis. The scan was 5 to 6 months old. So initial plan was to drill out and to do a cochleostomy and remove this fibrosis and put in. We have an ITD also there. So initially we tried to drill the basal turn, but the basal turn was not possible. So we did a lot of basal turn, and then we went into the scala vestibuli, and then we could insert the implant into the scala vestibuli, as we could see the fluid coming out. So you can see that implant is going superiorly towards the scala vestibuli, not towards the scala tympani, because that was fibrous. The problem was that when we do a C-arm, we see that this implant is just electrode, and we don't know that how the ossification has progressed, because as I have already told, the scan was 5 to 6 months old. So we took the patient into the theater to the scan again, and then we did a scan. So you can see that through the scala vestibuli, the implant has gone into the internal acoustic meatus, and although we got all the impedance and some telemetry was there. So again, here the picture is very clear. We have drill out here, and there was a proximal turn here. All these were ossified, which was earlier the fibrosis. So that's the ongoing process. So next thing we did is to elevate the TM flap further. This is the malleus, and we could get a lumen anterior to what we have drilled earlier. And through this, and when I removed the implant, I got a CSF leak. I just put a fat here, and then I was able to put implant. This time you can see that implant is going antero-inferior into the scala tympani, and then we got a very perfect NRT in this case. So it is an ongoing process. Sometimes it may involve only the apical segment. Here we did a medium implant, and then in this case we can see that we are trying to put in the implant, and the implant is going in, but there is some resistance. So even after some effort, we are not able to put the implant, and 2 electrodes were out, rest of the 10 were inside and good. So here the point is not to push in too much when you have resistance, we know that there was a apical fibrosis. Coming to the case of apical ossification, here at outset we know that there is a ossification quite severe here. So we cannot put in electrode. So we choose for a compressed electrode. So this is a video. We made the well and everything, and then a compressed electrode was put in. So this is the ITD which is getting checked, and then we decided for the compressed electrode as we has got. So ITD is very, very important when we decide about the electrodes, and this is a compressed electrode in place. Coming to the malformation, this is a paper by Anandan Dana Singh, and they have sort of 3D, and we like it very much because it shows exactly what size of cochlea it is, and it is very useful in day-to-day practice. So we may have got rudimentary oticity. We did not implant this patient. We have got 2 cases like this. Then coming to enlarged vestibular aqueduct, which is very, very common. We can see the typical enlarged vestibular bilateral side without any other malformation, and we can just find a oozer here. It is not the gusser here, which is important to know. So it is not the gusser here. It is just the oozer, because it is not connected to the CSF spaces. So coming to the cochlear hypoplasia, these are the challenging cases, because you can see that here the jugular bulb is quite near to the basal turn on the promontory. So there is a chance that you can get in. So in the case, this is the small cochlea. We choose for a compressed electrode. During the surgery itself, you can see that as soon as we tried to open vent inferior, because there was no landmark, there was flat promontory, there was opening into the this jugular bulb. And then after that, sealing that, we went superior to that, and then we could do the cochleostomy. So initially, when while doing, because there was no round window, there was no any landmark, and this is all transcanal technique, and we could put the implant. And then since there was a small perforation in the canal to see all the landmarks, we just put it with the bone pate and the periosteum. And this is the electrode. You can see that we were able to put it in. This is a compressed electrode. Again, a case of cochlear hypoplasia. So here the important point is to see that how large is the internal acoustic meatus, and we choose a medium electrode here, because this was a case here. So we choose a medium electrode here, and we were able to put it. So the electrode size is also important. Here is another case. It was important that that the cochlea was quite small, and the ISP was also quite large. So we choose a implant. So you can see that there is a CSF leak here. We choose for a form 24 implant in this case, because the internal acoustic meatus was large, and as soon as the implant we are able to put, we can see that the CSF leak just stopped, and then we just did packing. The very important point is that you have to make large than the cochleostomy size. You cannot make small cochleostomy. Again, intraoperatively we have tested the C-arm. C-arm is very, very useful, because here the migration of possible into the left internal acoustic meatus. So you have to put the electrode to the lateral canal wall. This is the operative. So the C-arm is very, very, very helpful in all the malformation cases, and we get it done intra-op only. Then again, there is a cystic apex with the enlarged vestibular aqueduct. So again, we have done an implant, and there was some all the electrodes and everything was in, or all things were not. The X-ray was little problematic, so we did a CT scan, and then the CT scan shows that everything is into the cochlea itself. So coming to the again a case of cochlear hypoplasia with large internal acoustic meatus. Here we because of the very large IM size malformed cochlea, we have done a cul-de-sac. So you can see that we have done a canal wall down. We are planning for a cul-de-sac. We are having mucosa. This is the abnormal chorda tympani you can see. And then we just removed all the mucosa around, and then very soon the stapes will be visible. And then we closed the incision tube with the periosteum. And then again, this was the done. So we have to do the implant from both sides. And then there was a CSF lake you can see, and then we use a foam electrode here. And then after the foam electrode, kind of sealed it area, and along with the fat and Sagicellan glue, we closed that area. And then the cul-de-sac closure was done, which was already done. This is our experience over the years. In the last 4 years, we have large number of implants. And as we have grown, initially we were very careful and we did not take any malformation. But as we have grown into the cochlear implant program, we have fibrosis, ossification, and malformations also. Malformation has increased in last 3 years because the state implant program has increased. All normal cochlear is being now done at many centers. So we are doing, since last 3 years, we have large number of malformation. The most important point is the pre-operative planning, different type of electrode array you said we have available, and the intraoperative CM is very, very important. So this was the malformation in short, incomplete partition, cochlear hypoplasia. We have large number of cochlear hypoplasia, common cavity rudimentary, but of course we did not implant. And then most common was the enlarged vestibular aqueduct. So to conclude, cochlear malformation are common, but it's possible to implant most of them with proper planning and intraoperative decision making. Cochlear implant surgery in malformation have a learning curve, and all young cochlear implant should be aware. In morning, we have seen 2 sessions, very good sessions on all these, both the topics. In large ISE and high pressure leak, subtotal petrosectomy should be considered. Otherwise, many a times after a few days or few weeks, you may have to resort to this. Intraoperative C-arm or digital X-ray are very, very helpful. Telemetry may be erratic. Even with proper placement, we have seen after the proper placement in the cystic apex cochlea, we do not get a proper telemetry. So if you are confirmed with your C-arm or with your X-ray, persist, it comes after some time, with half an hour when you close the skin or later. So do not worry about that. And coming to the fibrosis ossification can be easily picked up. Grade 1 ossification can be missed initially in radiology, but it is most easy to manage. And fibrosis can be cleared with multiple type of peaks in your armamentarium with some curved, some SF devices to remove it. Insertion test device or depth gauge, depending upon which company you are using, is very, very important to know what size. Scala vestibuli implantation is done. We have done in for 2-3 cases. But you have to be careful that through the scala vestibuli, do not go into the modulus and through the IM, which we have gone through one case when I have said. Mentor and seniors in consultation is very, very important. My mentor has been generous enough to give advices in pre-op period and intra-op period also, and because they have large experiences. So when you post these kind of cases, you should take the help of senior surgeon. Thank you very much. For any questions and comments, I am available.
Thank you, Dr. Amit. I would request the judges can put forward their questions to Dr. Amit Kesri now.
Yeah, congrats, Dr. Amit. Good presentation. Did you use only one type of implant this thing, or did you try any other model?
Sir, we did nucleus, cochlear nucleus also initially when it was in the RRC, because we are in the government. So we have to take the minimum implant. So we have used in EDIP cases, in 1 or 2 cases for minor malformations. And we have we try that we have to use a full banded electrode. But yes, only 2 company experience, cochlear nucleus and this medal, all devices almost, all electrodes.
Okay. What about these gushers? Were they, I mean, white after the surgery? Like after packing
yes.
and other?
Yes, sir. So, I mean, the gusher is very easy to manage. Once you put the implant, it is very easy for enlarged vestibular aqueduct. But if it is an enlarged IAM, internal acoustic meatus, then the plan either should be very tight packing with the Form 24 electrode, which is very, very useful. You can thread the electrode like Dr. Sanaglo said in the morning, or you can pack around. The idea is to have a good very good size cochleostomy or the round window, so that you can pack around also with the Form 24. Or if you are not confident, use a subtotal petrosectomy approach, close the Shishin tube, and do like we do a good subtotal petrosectomy.
Yeah.
Very, very important, sir.
So the approach barrier technique would be okay for if an extended problem comes for you?
Sir,
Like,
yes, the approach is very, very good, sir, especially for the drilling out, for seeing all the landmarks. And even in the classical technique, we can just elevate the TM flap if the need arises, and then we can manage the site. Like when we want proximal distal basal turn SS, then we have a very good assist from the transcanal side. So the thing is that everything, the entire promontory is in front of you. You can manage. Even we have managed the foot plate CSF leak along with the cochlear implant. So we are able to manage all kind of problems with the Varia technique. And when there is a severe malformation, we do, along with enlarged IM, we do subtotal petrosectomy, which we have done for 4 cases.
Okay, thank you. Thank you.
Thank you, sir. Thank you for the opportunity.
Any more questions for Dr. Amit? All right. Thank you, Dr. Amit.
Thank you.
I would like to call upon our next speaker, Dr. Viswajit Gogai, and he will speak on minimizing surgical complications of pediatric cochlear implantation experience from our early days or early cases. Thank you, Dr. Viswajit.
Good afternoon. My topic of today's presentation is minimizing surgical complication in pediatric cochlear implants. It's our early experience. Myself, Viswajit from Guwahati. This is a demographic profile of our patients. We have very small numbers, 48 till date, but amongst them we have 5 bilateral implants. And these are the basic steps of surgery roadmap. Every step has a crucial in terms of outcome, in terms of complications. I'll not give good details about the steps. And every small steps makes a big impact on the final outcome. Suppose we use a povidone iodine as an antiseptic dressing, but we wait for a minimum 20 minutes so that it gives a good bactericidal and virucidal effect. Similarly, in case of markings and incision and flaps, we should take care. So we can appreciate how the optimal gap between the recipient implant, the receiver implant, and the implants. And in the simultaneous implant, there is a good optimal sequence. And that's how we making incisions. Avoid monopolar diatemy as much as possible. And also during the flap elevation, but as possible, we use bipolar diatemy. Suppose we have any inadequate flap, we don't hesitate to take another flap so that the ultimate flap should not be too tight during the closures. Nowadays, we stop using retectors, we use stay sutures. And we should also put detectors intermittently during the implant bed drilling so that the does not cause injury to the flap. And since the younger implant is now, so we have the more experience of diploic hair cells, which is a more marrow component, which causes more bleedings. And we should not waste time to stop this kind of oozing by going with the diatemy or a diamond drill. We should swiftly finish the cortical mastectomy part. And we can have an idea pre-implant by going through a radiology regarding the cochlear rotation. We can found difficulty to get the round into proper round into membrane. And during that process, during extensive posterior tympanotomy, we may encounter exposing of the facial sheath, and we need a more drilling towards the medial aspect of the facial recess, but we should be very careful not to injure the exposed facial sheath. And that's how we ultimately get the 360-degree visualization of the round window membrane. And we can have by drilling the body overhang and also little drilling towards the floor of the round window niche. After getting the round window, we remove the round window membrane by a hook. And after that, if you found that there's a good trajectory for the implant, then it is better to try to avoid too much of drilling towards the cristra fenestra. Basically, there should not be any kind of sharp edge, particularly when we are going for slimmer electrodes. And I want to highlight another very important point during the inferior cochleostomy, the position of the head. Any position may be the head, but during the inferior cochleostomy, the position of the head should be such that the facial horizontal portion of the facial lamp is in a true horizontal plane, so that we can have a exact location of the inferior cochleostomy. Sometimes hypotympanic cells may mimic like a round window, but in that kind of scenario, Fustis can help us that it is not the proper round window, that is the hypotympanic cell. CSF leak, let's this CSF leak stops, and if it's a gusher, then we should revisit our radiology. So when you go for new electrodes like this kind of electrode, we should have a good exercise, good familiarity, and the philosophy behind why philosophy of the electrodes before placing it in the recipient, so that it has a proper positioning inside the cochlea. And that's how we can do so that it has a proper perimedular hugging of the electrode inside the cochlea. And this is my last section I try to share with you. This is the last case. If you can appreciate, it's a very beautiful insertion, and there's a complete kind of insertion. Then what I did wrong, the soft tissue, we have some dirty elements. We try to remove the soft tissue. Then I'm going for closure and the manipulation of transmembrane part of the electrode. But when I did the NRT, then we have found that there is no response all of my basal part of cochlea. So we should not, in that kind of scenario, definitely serum will help, but rather than serum, I'll prefer to explore, remove my flap, and we can appreciate the electrode is slightly displayed out. So ultimately we have inserted the electrode, and that's my very small share with a very small number of cases, very small things that makes ultimately the final outcome. And the success of cochlear implant surgery does not stop at a safe landing, but it concerns a smooth lifelong journey ahead. Thank you so much giving me the opportunity to share my small experience.
Questions by judges?
Yeah, congratulations, Dr. Biswajit Gogai. Though it's a short number, you have done quite carefully and safely. So in your observation, what was your commonest complications that you have come across?
In a very small series, I have a 2 cell with a congestion in the implant bed. That's not immediately after 1 month or like. But when we change the magnet, that's how we have overcome that complication also. But as such, no as a major complication, sir.
There are no surgical complications as such.
No, sir.
Okay. Only post-operative little congestion.
Congestion over the implant. Only 2 cells, sir.
Is it because of the magnet or is it because of
when we have changed the magnet, then we have found that this congestion has over. And we're putting some neosporin or my drops also. I'm not going for any kind of oral antibiotic or systemic antibiotic, but it after 2 weeks there's no such condition.
How many years follow-up that all these patients are under now?
So which one? That
All your cases. All your cases.
But we have started the CI cases since 2014 only.
Okay. So your first case 2014 and you're still under follow-up all these patients.
Dr. Gogai,
Yes.
is it on intra-op any radiography?
Yeah, we do, ma'am. We do. Like it is, suppose the last case, we always, generally we do all cases, but if you found a difficulty, we always go for the modified standards view. And also we sometimes we do in bilateral cases, I took the photo, digital X-ray on the day of discharge.
So what you wanted to suggest in this small series? Like what was your intention of presenting this? What do you want a message giving to all of us?
Ma'am, when I search papers, CI says I think one of the safest surgery till date, because it is done by most of the mentor surgeons and all this. But as a beginner, when we have the more programs are coming, then we have a more CI surgeries will come, more centers will come. So junior surgeons like me, so we should take a very safe steps in every step. It should be very meticulous. It's not like that I'm getting some scheme and I've started the surgery. Because look, ma'am, after this COVID and all this, we have not that much of exposure to have a mentorship. Because my mentor was Amitav sir, and after for 25 of surgery, we have to go for that all this scheme. So we should be, as a junior surgeon, we should be very careful in our step, so that we have a not kind of a paper from India after 10 years. My experience of explantation in my early 50 cases.
Okay.
That's my motive.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Biswajit.
Thank you, sir.
Let's move on to our next speaker. I will call upon Dr. Kranti Bhavna, who is going to present on radiological autoplan-based study of intracochlear electrode position, cochleostomy, and round window in transcanal way. Over to you, ma'am.
Thank you very much for this opportunity. So let me just share my screen. Is my presentation visible?
Yes, please go ahead.
Yeah. We can see.
So this study is regarding radiological autoplan-based study of intracochlear electrode position through cochleostomy and round window in transcanal Varia technique. So we know that Varia technique is an alternative technique of cochlear implant surgery. In this, you do not make a big cortical mastoidectomy. The cochlear electrode essentially goes through a transcanal tunnel. Traditionally, in the Varia approach, all these electrodes are introduced into the cochlea through the cochleostomy approach. And what we have started doing now at our center is round window insertions for all these electrodes for now around 100+ cases. So various studies have described electrode array insertions through round window, because we know that through various studies that the scalar dislocations or presence of cochlear electrode into the scala tympani is more with round window insertions. So there was a lot of studies with the posterior tympanotomy technique, but there were dearth of studies that compared the electrode position in both round window and cochleostomy insertion through the transcanal Varia approach. So we know, as one of our speakers told, that the middle ear is totally in your view when you are raising the tympanomeatal flap, and with adequate visualization, the round window is just in front of you. You drill the niche, open the round window membrane, and very smoothly through the transcanal tunnel, the cochlear electrode can be introduced. On the other hand, when we are doing the cochleostomy, most of us still do that. You are doing anterior-inferior cochleostomy. You are opening the cochlea just below anterior-inferior to the round window, and then introducing the cochlear electrode through the posterior tunnel into the cochlea. Both the techniques are good. You can actually use both of it. I now use my cochleostomies for posterior rotation of cochlea, but as I already mentioned before, that round window insertions are now becoming the norm. So we wanted to use the Autoplan software to perform post-operative evaluation of intracochlear electrode array positions using both the approaches, round window and cochleostomy, and we wanted to compare them as to see and actually refute the misconception that round window insertions were not possible with Varia. We wanted to study the parameters of electrode array positions, especially angle or depth of insertion, scala tympani insertions, kinking, tip foldovers, etc., following both the approaches, and we wanted to look for any significant difference between them. So subjects between 2 to 15 years who were implanted were used. In this retrospective study, intracochlear positioning of electrode array was analyzed using the Autoplan software in both the different surgical approaches, that is round window versus the cochleostomy. DICOM files of post-op CT scans were collected for analysis at our center, and Autoplan version 3 was used. So initially, image properties of DICOM file is analyzed for integrity of images and for missing slices. Optimal cochlear view on all the 3 dimensions, axial, coronal, and sagittal, is defined by adjusting all 3 views using crosshairs on the screen. And the parameters which we take is most important, diameter and the width. Height is also taken because though it might not be now directly being used in the ECF formula, but I think that also has some algorithm difference when you are analyzing it. The diameter is known as the value A from round window to the lateral wall, and the cochlear duct length, the linear length of cochlear duct, is defined as the length of cochlear duct from center of round window to the apical tip of the cochlea. Individual electrode contact identification is done through auto contact identification tool, and the position marked by tool is further fine-tuned for accuracy. And finally, the AID is measured in degrees for each electrode contact by software based on post-operative CT images. So Pearson correlation test was used. We used 26 subjects for this study, 16 round window, 10 cochleostomies. What we found that our average CDL was around 38.12 millimeter, whereas maximum was around 43 and minimum being 34.2 millimeter. A graph which shows the AID, insertion depth, and angle of insertion depth, and the CDL. All of them were implanted using the metal standard electrode with a length of 31.5 millimeter. We are using normal cochleas in this study, and full insertion was ensured in all the cases. When we look at AID, average was 667.87 degrees, whereas maximum being 773 degrees and minimum being 580.8 degrees. It is important now that on results we knew that on statistical analysis, no significant difference was found in the angle of insertion between both cochleostomy subjects and round window subjects. So average in cochleostomy was 670 degrees, round window was around 666 degrees. When we look at the frequency coverage, the low frequency coverage provided by standard electrode ranged from 47 Hz to 269 Hz in all 26 subjects, with an average lowest frequency of 115 Hz. Whereas when we look at the highest frequency covered with standard electrode array, that ranged from 9,614 Hz to 13,799 Hz, with an average of being 12,124 Hz. So most surgeons who adopt the transcanal Varia approach prefer cochleostomy because they feel that it is in the direct line with transcanal tunnel. But in this study, we use the round window, and it is easily accessible as the entire middle ear is in view with the panoramic view of the middle ear with the Varia. Now we resort to cochleostomy in extremely posteriorly rotated cochlea when we do our pre-op radiological planning. So in addition to primary goal of this study, we also wanted to read the electrode placement issues on the Autoplan, and the results of this study indicate that there was no significant difference in AID, angle of insertion, when we are doing round window and cochleostomy. So thoroughly by Autoplan software, we know that irrespective of the insertion technique used, electrode array was completely visualized inside the scala tympani, all the subjects, without any scalar deviations or tip foldovers. Autoplan based study on electrode array position provides evidence that round window insertion is possible with the transcanal technique. Also, there are no displacements, there are no kinking or bending of electrode when round window approach is being used. So it refutes the common misconception that round window insertion of electrode array is not possible in Varia, and that it will lead to electrode displacements, bending or kinking. A detailed study using Autoplan software has established that there is no difference. So I would finally conclude that since there is no difference as per this study set is concerned, that there is no difference between round window insertions and cochleostomy insertions when it comes to electrode array position and placement in scala tympani. Hence, it is feasible to perform round window insertions because multiple studies have now proven that scalar translocations, displacements, are more with cochleostomy, and also that the placement in scala tympani is more with round window. So when you want to ensure that it is in the scala tympani, round window should be the approach. Also, for all the cases where you are planning surgeries where there are residual hearing, it is important that you plan a round window insertion. So that's what my conclusion is. Thank you for your patient listening.
There is questions.
Congrats, Dr. Kranti. Almost all the cases were retrospective studies?
Yes, this was all of them were already implanted. We selected those because I was doing cochleostomy only till I think 2016. After that, I have done all my round window approaches. So we wanted to select those and ones which we did in between. So all of them were retrospective.
In the prospective measures like Autoplan, if you use,
yes.
I mean, would it make any difference in your study?
We are planning to do that as well now, using Autoplan for our prospective studies as well. Look, I don't think it's going to change my approach because now I know for sure that my round window approaches are working very well, not only in a matter of surgical issues, but also in a matter of mapping and audiological outcomes. So that's very important. What Autoplan we are planning to do for Autoplan study is it's going to make me plan my electrodes. Now that you know that there are so many studies, systemic reviews, meta-analysis regarding whether longer electrodes are better or shorter electrodes are better, all that. But what Autoplan, what we are going to do is going to make me make me more comfortable when I'm planning my anomalies. So we are going to do that, and we are now actually doing it. So that's what we are planning to completely make it for all the patients.
So in short, I mean, how do you rate the Autoplan usage? Like, what is the maximum advantage that you will state?
So maximum for the take-home message.
It's not available to all the centers.
It is even not available at my center. I did send all those images through a drive to the Medal Center to get these studies done. Yeah.
Sending to the other center also. Like, how do you rate its advantage? Do you recommend that it could be? I mean, it should be there. I mean, leave the barrier technique.
Oh yeah, I'm just talking about Autoplan. Yes. I think as technology is increasing and it gives us a beautiful picture of not only the CDLs but AID. I think it is going to make your surgical planning more crisp, and it's more useful when you are planning on anomalies. So if it can be incorporated, let's just not talk about the price and other aspects. If you talk about pure science, then I still feel that this is going to find a good usage for cochlear implant surgeons when you have the whole surgical map in front of you.
Kanti, very nice presentation, but you had mentioned only about the medal. What about the other companies?
So yes, very true. I have done all the three, but we wanted to initially, because I have done round windows for all the three companies now, but we wanted to have a study with one electrode first. We have data of other as well. So I have done advanced bionic 1J, and I have also done cochlear. So this study was, we wanted to have all the confounding factors away, and we wanted to stick to one company. But I will come out with results with other companies as well, the implants which we have done with other companies.
Okay, thank you.
Thank you.
Thank you.
Thank you, Dr. Kranti Bhavna.
Thank you.
Now may I call upon Dr. Naresh Panda to please present on the periosteal flap in cochlear implantation revisited, surgical audit of a novel periosteal flap at a tertiary teaching hospital.
Yeah, good evening. Thanks to the organizing team to have given this opportunity. And this evening, I'm going to talk on a periosteal flap in cochlear implantation, which the department had described in the year 2020. And then we decided to do a surgical audit of this periosteal flap. Cochlear implant surgery has been there for over 4 decades now, and we all know that various modifications in the incision type of periosteal flap and surgical approach to the cochlea have been proposed and incorporated into the surgical technique. Now, many surgeons have described innovative flaps to ensure good coverage of the device. It was Belcani who had described a periosteal pocket technique without drilling the bone. A palva flap, a tailed palva flap in the subperiosteal pocket was described by Oran et al. Fawad et al. Described a new anteriorly based periosteal flap without any complications. Kirtane et al. From our country described a posterior superior based periosteal flap, which and the purpose for all these innovations was to ensure stabilization of the receiver stimulator unit to avoid migration. So the objective of this presentation is to critically evaluate the safety and reliability of the new periosteal flap in cochlear implant surgery and by way of surgical audit. The methods, we had 39 patients who underwent cochlear implantation between July 2020 and to September 2021. And the cochlear implant surgery utilized the novel periosteal flap, which was described in the department. All the patients have been followed up between 2 months to 11 months. For comparison, the various flap issues which I would be talking were evaluated by comparing 51 children who underwent cochlear implant surgery between July 2017 to July 2019 with the anteriorly based palva flap which we were utilizing earlier. So this is the video, is the left ear, and the incision starts in a curvilinear fashion. The incision goes posteriorly so that when you elevate the periosteum, you have a very large and curvilinear flap, and this curves posteriorly. So this I will talk about later. I'll show you the picture that this covers the implant quite well. It lies posteriorly. The skin incision will go anteriorly. This is the periosteal incision, which is the right ear. You start in this fashion, go posteriorly, much posteriorly, and then curve it anteriorly to the mastoid tip. This picture shows the closure of after covering the device. Closure lies much more posteriorly because of the simple reason that you have a periosteal flap with a very large anterior-posterior diameter, which goes posteriorly. This skin flap will go anteriorly. So this is safety-wise, both the periosteal incision and the skin incisions are lying apart and at different planes. A scoring system was used for various issues, and this scoring evaluation was done by an independent observer. There were certain parameters which were used for the scoring evaluation. This was ease of surgical exposure, surgical maneuverability of the flap, ease of closure after fixing the device, any immediate postoperative complications occurring within 24 hours, and delayed complications up to 30 days. A score of 4 was assigned to excellent assessment and a score of 1 was for fair assessment. Both the flaps were compared for their scoring out of 18, which is the best score. The results, the comparison of various variables for the two groups showed reduced possibility of emissary vein injury and ease of closure of wound after device fixation. The mean total scores were also better in the novel periosteal group, which was statistically significant. In the novel flap, only 2 out of 39 children had a minor skin color changes in the initial postoperative period, which disappeared in around 7 days. There were no major complications like wound infection, hematoma, device migration with the new periosteal flap, or any flap revisions were done. This table would show, this is the comparison between the two flaps. These are the surgical exposure, ease of working, emissary vein injury, ease of closure of wound after device fixation, immediate complications, delayed complications. Mind you, the points for immediate complications, if there was a complication, if there was no complication, it was 2 points. If there was a complication, there was the points were 2. So if you can see that between emissary vein injury, this was statistically significant. And again, ease of closure for wound after device fixation, again, the difference was statistically significant. On comparison between the groups, the differences in rate of surgical site complications were not statistically significant. So, the Pearson chi-square was 0.2998, and which was not significant. We also compared the total scores between the two groups, and it was found that the flap group had a score of Palva flap group had a score of 13.67, whereas the newer periosteal flap had a score of 17.90. This was again significant. So complications in CI continue to occur. We all know, in spite of modification in the flap technique, they occur in the range of 1.8 to 8.2%. Skin flap complications after cochlear implantation often warrant surgical intervention. A good design of the flap is paramount to avoid flap complications in the postoperative period. And a flap should have adequate blood supply, should be wide enough to cover the device and with no tension. We also have been using pelvic flap for a long time. Its only disadvantage is its thinness in very young children and tears sometime, and you have to use another flap like we have been using for flap tears. We have been using a temporoparietal fascia flap. So what are the salient high points of the novel periosteal flap? It's a robust flap. The larger anterior part of the flap goes posteriorly to cover the device. The closure remains at a fair distance from the skin incision, which is far too anterior. A flap is well vascularized, it has adequate thickness, and is tension-free. There is less edema, reduced dead space, and absolutely no vascular compromise. Lastly, it avoids the emissary vein as the periosteal away from the vein. So to conclude, the novel and innovative periosteal flap has demonstrated safety and reliability of the flap in the surgical procedure of cochlear implantation. The less time consuming, well vascularized and robust flap affords effective coverage of the device with minimum flap related complications. Further validation of this flap is required to be done at different centers, which would vindicate the advantage of this easy to do periosteal flap. So lastly, there is a way to do everything. Better find a way to it. We have probably found a better and easier periosteal flap for cochlear implantation. Please try it. You would not regret it. Thank you very much.
Okay, any questions from the judges?
Yeah, Dr. Naresh, very good presentation. Very interesting. I just wanted to know, like, what was the previous, before this periosteal flap technique, which other things that you have tried and you found a gross difference with this? Just out of curiosity.
I think we have been using the Palva flap from the beginning, and we did not change the technique. The only thing is that, as we progressed in our program, we started doing very young children. And in very young children, the problem was many a times, the thinness of the flap. And when you have to do the drill holes or when you are making the bed for the implant, that's the time when there is a partial tear of this flap. And you have to then again extend the incision, use another flap, rotate a flap to cover the device. That actually necessitated that I thought that maybe, this would be a better flap to do in cochlear implantation.
So which part of the implant, like when you suture it back, what part of the implant likely to be covered by this suture line?
I didn't get your point.
Like the complete receiver implant package is inserted into the pocket.
Okay,
and
yeah. Majority of the sorry to interrupt, but majority of the receiver stimulator unit goes back into the pocket, which you create anyway. For any we create a large pocket. Only the part which is a part of the magnet which remains little bit, anterior part remains, which is covered by this flap.
Fantail and
yes.
Yeah.
I wish you
so apart from the
apart
from the flap, all other technique is the same, like
exactly
making and all that you kept the same.
Yes.
I wish you had shown some intro picture of you taking a flap, because we didn't really understand exactly from where you were taking the flap from. You had just shown one line there. You had just
That's a line. You start superiorly, curve it posteriorly, go way back, and then curve it anteriorly towards the mastoid tip.
Yeah, instead of a straight line, you took a large posterior.
The curvature, and this curvature is the one which actually helps. It makes your job easier to raise the periosteal pocket also.
Thank you. Thank you, Naresh.
Thank you very much. Good evening.
Any other questions, Dr. Rambabu, Dr. Sangeeta?
No, thank you.
Okay, I think with that, we conclude this session. This was the oral papers presentations, which was the first section of the same. We will have a second section of the same on Sunday morning, for which I request your help. Dr. Rambabu and Dr. Sangeeta Varti, thank you so much. Dr. Rambabu is from Apollo Hyderabad, one of the premier centers of pioneering centers of cochlear implants in the country, along with Dr. Vinay Kumar. And Dr. Sangeeta Varti is in Hinduja Hospital with Dr. Milind Kirtane, and she's an amazing team member, of the surgical team member. Sangeeta has also done tremendously well as a cochlear implant surgeon. So thank you so much to both of you, and thank you to the four speakers this afternoon, Dr. Naresh Panda, Dr. Kranti Bhavna, Dr. Amit Kesri, and Dr. Biswajit Gugoi. Very good presentations. You contributed really well. With that, we conclude day one sessions, day one of the scientific program. I think it went really well, apart from a couple of connectivity glitches. And I think for the first virtual conference, we've done really well. The responses have been really good. Thank you all so much for this. And also, I want to let you know that there is an exhibition hall that we would really encourage you to visit whenever you can. And this probably is a good time to visit there once and say hello virtually to all the educational partners that we have. We have about 17 of them, one strategic partner, one platinum partner, 2 diamond partners, and about 13 gold partners, as we call them. Please visit them and show your support because they made this virtual conference possible. I would also like to know, because there were a few of you who were a little confused, as we were here as well as hosts, when there is a common session, for example, addresses, so common to all 3 streams, you would visit the surgery hall, hall 1, like you would have done in a physical conference. The main auditorium would be where you will all assemble. And for that, this is the surgery hall, which will be the main auditorium. When there is a common integrated panel, for example, between audiology and rehabilitation, you would be in the audiology hall. But then when there are 3 breakout sessions, 3 parallel sessions, all 3 halls will be active. So this is for tomorrow and day after. Please remember that. With that, we conclude. And I wish I could have told you, please join us for a social program this evening, and then perhaps join us for a dinner in the evening. And
virtual drink.
Virtual, I don't know. So we are all going for it. We are about 8 of us in the organizing committee, both EC and OC here. From the Avyaya office, we are going for a nice dinner now, and hope you will have, after a full day of scientific deliberations, you would have a good evening, and we'll see you in the morning tomorrow, day 2. We will start at 9 sharp in the morning. Thank you all.
Thank you.
Thank
you, sir. Good night, sir.
Good night.
Congrats, Sunil.
Thank you, sir.
Congrats.
Thank you. Thank you, Rambabu. Thank you.
Well done. Well done. Well done.
Thanks, Sangeeta.
Okay, right.
Bye.
Bye-bye. Bye.
uh,